Puri. Insurance famous na dapat. Orang yang mau berdiri di sini dong, betul betul ini takut ni kan. Market takut ni kan?
क्या करो वहाँ पे जज ट्रेक करके ले लेके आओ ओके तुम
आज नहीं आज थोड़ा मटन पकाएंगे उनके साथ पूरा लेके आया हूँ सिलेंडर है डब्बा है पूरा है
तो भी कर दो ना भाई यहाँ पे वहाँ रखो भाई काली पीली डालो जरा
Dr. Umesh sir, he has done his MBBS and MD from Usmania Medical College and started practice since 2015. Currently he is working as Assistant Professor of Psychiatry in Institute of Mental Health, Hyderabad, and he is a consultant psychiatrist at Roshni's Counseling Center, Hyderabad. Dr. Fani Prashant sir, he has did his MD from PGI Chandigarh and later worked as senior resident at NIMHANS and started his private practice in 2006 at Hyderabad. Currently he is working as a consultant psychiatrist and director of Chetana Hospital and is also a consultant at KIMS Hospital, Secunderabad. He is the first editor of Telangana Journal of Psychiatry and currently the president of Hyderabad Psychiatric Society. I invite speaker Dr. Shailesh Mate onto the stage, please.
Good morning all. We recognize all the seniors present, Dr. Chandrasekhar sir, MS Reddy sir, Ashok Reddy sir, Vinod sir and George Reddy sir, Anita madam, Sudharani madam. There is a slight delay in the program because of a walkathon on awareness of drug trafficking today. Please kindly accept it. Now over to the chairpersons to take over the session. Thank you, sir.
Yeah, good morning. Welcome all of you to TSPSYCON. It's a wonderful program ahead today, and we are starting with brief interventions in substance use by Dr. Shailesh Mate. Dr. Umesh will introduce the speaker.
Good morning all. Dr. Shailesh Mate, sir is a consultant. Sir is a consultant psychiatrist. Sir has an MBBS, DPM and DNB from Mumbai. Sir is a fellow in clinical sexology from Maharashtra University of Health Sciences. Presently working as a member of Mental Health Review Board, Thane Division, as OPD at the clinic at Thane, one of the directors of Insight. Thank you. Welcome, sir.
Brief interventions in substance abuse has been a concept which has been there for a long time. It started off with Miller and Rolnick who actually suggested the idea of mnemonic called frames. Okay, the brief interventions are supposed to be interventions in mostly outpatient setting where a lesser time can be spent on patient which is focused on which stage the patient is having a trouble and what are the counseling which is required, and depending upon that you do intervention which is lasting for less than an hour or so, maybe for a few sessions, rather than the usual de-addiction program which runs for a few weeks and as an inpatient, and okay, it's a long time. So the brief interventions also are supposed to be very effective if used in the right context and right place. Okay, now we have Dr. Shailesh Mate who is going to enlighten about the topic. Welcome, sir.
Good morning. Very good morning to all of you, and thank you for that good introduction and brief. As sir mentioned, screening and brief interventions are really brief, which started long back, but many of us don't use it most often, okay? As it has to be used in a different setting, not in a indoor patients or not in the patients who come to us with the help for substance abuse. So different scenario, different settings, which are all these. Very interesting, it is which settings we use it. Mostly it has been used in a research setting. Clinically, where we have been called upon in a general hospital setup from a physician and a neurologist that this fellow is consuming alcohol or any other substance, please come and see and counsel him. So there we can use it as a brief intervention model where we can motivate the patient to reduce his substance abuse or to take treatment for it. Yes, it is a lot of theoretical things here. I remember when I was a student, and we used to get a lot of call in KM hospitals that this fellow has troubled us in the middle of the night, especially from the physician. Why he had just come with the vomiting and we know he had consumed a lot of alcohol. Next day again he is wanting a discharge. You come and see and counsel him. So as a resident, I never used to understand what to do with this fellow. He would say, sir, कल ही लिया था, ज़्यादा हो गया, अभी क्या करें? Regular तो लेता नहीं. So what the counseling should I do? I was very curious that time. Then इतना ही बोलता था कि दारू मत पी. That was our counseling. And still, today we are learned here. Today we know many things about the substance abuse, but more than us in the society, physicians, rest of the doctors, family physicians, they see a lot of people with substance use and abuse, and they never turn up towards any psychiatrist. And what is their counseling to them? Can anybody guess what they counsel to their patients? What they say? दारू मत पी, बहुत हो गया, तकलीफ हो जाएगा, या ज्यादा से ज्यादा सेकेंड इंटरवेंशन इज मर जाएगा. ओके, या तो पेशेंट डर जाता है, उसके पास जाता है बाद में और अपना बढ़ा देता है. So that is the brief intervention that these people do. So it is our duty as a psychiatrist to teach these people also what is brief intervention, and it is that we should also know it. So what it contains is a screening and brief interventions and referral to appropriate treatment. Now this is very theoretical topic. I tried to have some clinical relevance so that we can apply it in our settings and talk to our patients. And apart from that, if you are going somewhere, in fact, I don't know, many of you do a lot of community activities where you go into the community and talk on various topics. So there it can be used definitely. And what is it? It is a preventive intervention, okay, aimed at reducing the recurring behavior arising from the substance use. It is used for mild and moderate cases, not severe dependence, alcohol dependence or substance use cases. Cost effective, it is not for the patients who are dependent, as I very clearly said. Again, it is used in a setting where patient has come to us not primarily for the substance abuse. Many of us in our OPD, patient either come to us or brought by the relatives. Mostly it is brought by the relatives. कि बहुत नशा करता है या दारू पीता है, जो भी है. So there it cannot be used. But yes, some principles of it can be used there also. Again, it says it doesn't make sense if it is the patient is already in our OPD. Okay, some of these can be used. The principle of this can be used, but entirely the concept doesn't apply to a patient where patient has already come for a substance use. Then what is a concept? The concept is to reduce the burden of the disease disability associated with the misuse of the psychoactive substance. There are alcohol, illicit drugs, tobaccos, prescription medicines and all that. Now, this is a preventive strategy where you are feeling that the patient shouldn't go into a repeated use pattern, or the substance use shouldn't affect him physically. That is how you start with the brief interventions. Now, before brief interventions, we need to screen that how much is the consumption pattern. Now, what is screening? Screening is detecting the spectrum of unhealthy use, risky use and problematic use. To the diagnosable disorders also. Like in these settings, sometimes you can see the dependence pattern. Sometimes it is just abuser use or risky behavior pattern. So that is how you need to find out in which category this patient is at this moment. Okay. Now, apart from addressing the diagnosable disorders and aiming at that, you have to also intervene the patient who are at high risk by telling them the appropriate consequences that are going to happen. So various screening tools are there, which are started in 1970s and 80s. I'll just brief about all these things. I will not go in details of each and every screening instruments. Initially, we have this Michigan alcoholism screening test, which is MAST. Again, it may not be very appropriate in a setting where we interact with the patient for a few minutes. It is 25 questions are there with yes/no answers. The score of 2 may not be a problem, but more than that is definitely a problem. What it finds out the alcohol use, social occupational consequences, and previous attempts of treatment. It can be used in a lot of studies. While using in a clinical setup, you need to find out the relevant questions and probably clinically you can ask that. Another is CAGE. Everybody knows here what is CAGE. The problem with both these screening is they detect more of dependence pattern, not of use pattern. Again, CAGE indicates more of dependence pattern, not the risky behavior pattern or problematic use pattern. Any PGs are sitting here? Okay. For them, I will just read out the questions. CAGE is, have you ever failed to cut down your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt guilty about your drinking? Have you ever had a drink first thing in the morning? So cut down, annoyed, guilty, and eye opener. These are the questions. If you ask them, probably they will say yes to one of the questions. Then you see it is a dependence pattern. Now this is very interesting. Does anybody know what is this picture shows about? Kya hai? Sorry? So the case you know, you are aware of this case? So it is in the media, okay? So dangerous. So from here, say if somebody used, instead of giving him alcohol, if they had given him a craft was yellow, so some lives would have been saved. So what is craft? This is very important screening tool. Car, relax, alone, forget friends and trouble. Okay? Very easy to remember, and in fact, while you are dealing with the adolescents, I want you to use this. It's very efficient and effective. Identify the substance abuse, substance related riding and driving, substance use disorders among the youth, 12 to 21. In first part, you will ask, did drink any alcohol more than few sips? That is the question. But here is very interesting thing. Do not count the sips that alcohol is taken during the family or religious gatherings. That's what it says. So yesterday का कोई जो अपना religious event हुआ था, you may not count that. Okay. So माफ कल वालों में से कोई आ भी नहीं रहेगा यहाँ पे अभी जो रात को बहुत देर तक थे यहाँ पे. So okay, anyways, craft may not be applied to them. Again, it is for again it is used for not just alcohol but for marijuana and hashish also. Third question that you need to ask is, do you use anything to get high? So it could be any substance. So then you go back to the second part B of it. Have you ridden a car driven by someone, including yourself, who was high on or has been high? So it's a very relevant question to find out the risky behavior. Do you ever use alcohol or drug to relax? Feel better for yourself. Many people do that, many adolescents do that. Okay? Do you ever use alcohol or drugs while you are by yourself, so alone? Do you ever forget things when you consume alcohol or drugs? do your family and friends are concerned about your drug use? And last is, have you ever gotten into trouble while using alcohol or drugs? So, very easy. Car, relax, alone, forget friends and trouble. So even you can memorize this, and while you are dealing with any adolescents, you can ask these 4 or 5 questions and you will get an idea how risky behavior this adolescence is having. Very simple, yes, no question answers. Also it has been studied that the scores with the craft are associated with DSM-5 criteria for the substance dependence, which shows any score of 1 is 32% likelihood of giving the dependence pattern. 2, 64%, 3 score 79, 4, 92, 5 and 6 are 100% likelihood. So again, this is very relevant. Clinically you can ask in few questions. So I advise you, recommend you can use all these things. Another screening tool is alcohol use disorders, which is again known as audit. 10 questions it has. Score of 8 or more is considered as a hazardous and harmful use of the alcohol. But rather than using a full audit, I want you to use audit C, which is a short version of it, which has only 3 questions, which scores from 0 to 4 and gives us a good idea. Very simple questions. How often do you have a drink containing alcohol? Never. Monthly or less 2 to 4 times per month, 2 to 3 times per week or 4 times per week. These are simple questions which clinically we also ask to the patient. कितनी बार लेता है, हफ्ते में 1 बार, 2 बार, 3 बार, कितना ड्रिंक होता है. Second is how many units of alcohol you are taking. 1 to 2, 2 to 4, 5 to 6, 7 to 9 and on. How often you had 6 or more drinks, at 6 or more drinks units for a female, 8 or more for a male. In a month, never, or less than monthly, weekly or this thing. Depending on this, you score it. Very simple. You can use this. Any score more than 4, 3 in a woman are optimal for hazardous drinking. So simple. Can read this, repeat this, repeatedly ask to your patients, and you will be in a better position to understand this drinking pattern. There are various screening instruments like assist alcohol smoking substance involvement screening test. Again, this asks the questions about the past 3 months, which gives you various risk patterns of the patient, but again, lots of questions, so probably clinically may not be relevant. Again, this POSIT, problem-oriented screening instrument for teenagers, lots of questions. It also has 139 items, so probably used for a research, not for us. Apart from using these instruments, also we have simple biological tests. Okay, most of the times a patient is brought to us by family members. Family members tell us history. ये बहुत drug use करता है. Yeah, recently nowadays I see lots of adolescents brought by their parents saying that we have found some substance in his bag. He denies it and he says मैं तो कुछ लेता ही नहीं. Okay. So during this situation, whenever you interact with the patient may not tell you what he is using, how he is using. So we have simple blood test, urine test, where we can identify the various substances. Urine test, we have a kit like UPT. Okay, many of us must be using it, so it shows us what are other substances he is or she is using. In blood test for alcohol, we get deranged liver function test, GGTs. So you can do all these tests and discuss with the patient. Now, how do we discuss with the patient? Patient is in denial. How do we discuss? What do we say? What do we ask? Or what do we tell? Can anybody just tell me? What do you say? Reports are ready and you see cannabis is positive or liver functions are deranged. How do you say? What do you say? Anyone, please. I'll take one. Yeah, anyone? So are we supposed to say directly that yes, your reports are very bad and we don't know what will happen to you? Or how? Because patient has not come to us for his substance abuse. He has been brought. He has been probably forcefully brought. So what do we say?
सारी चीजें दिख रहे हैं आपके इन्वेस्टिगेशंस में, सजेस्ट कर रहे हैं कि आप ले रहे हैं?
नहीं सर, मैं तो नहीं लेगा।
Suggest कर रहे हैं।
स्टैंडर्ड आंसर। ऑल एडल्ट्स विल टेल मी इतना हेडेक होता है। एक ने तो मुझे मस्त बोला है, सर आपने कभी लिया है कैनबिस? मस्त रहता है, एक बार फूक के देखो। What should I do? Then one fellow तो told me, आपने लिया ही नहीं तो how can you treat me? Oh my God. Well, these are very difficult patients, very difficult to handle. And if you tell them, I mean, very often what I found, if you tell them, your liver deranged है, ये सब कुछ deranged है, either mutely they will say, ठीक है, then you will say, फिर क्या करेगा? मैं बंद कर दूंगा. He will go and never return. That is what happens. Or they are in a denial, or they argue. Okay. Now, I think we need to build up a lot of suspense here. We shouldn't tell them directly. बॉस ये तेरा खराब, बॉस ये तेरे में गड़बड़ है. डायरेक्टली बोलना ही नहीं चाहिए. वो सस्पेंस मूवी दिखाते हैं ना 2 घंटे, 2-3 सेशन को बुलाओ, कोई प्रॉब्लम नहीं. Tell them slowly. That's what I feel, and sometimes it works. Now, how you build up the suspense to these people? You need to ask them why he has been come over here. He has been brought by the parents. Okay, brought by wife probably. So, what do you think? What do you expect? The results. Probably that is the first question you need to ask them. What do you expect? Some people will say it will be normal, it will be, or I don't know, or they will say, aap batao. So, the idea is you need to make this patient to come to the point that you tell me. Okay? Probably that time you can disclose. That is the one strategy. Again, whether that will work or not, we don't know. Because these are very, very difficult patients, especially brought by the family members where they don't have any concept. But sometimes, while doing a lot of intervention, it might help them somewhere. May not be today, but maybe after a few days or few months. So, by knowing all these things, screening test, how do you assess? Very simple assessment. Everybody knows it. Day in and day out we do it. Okay. 3 areas we need to ask the questions. Amount of the substance, frequency, and quantity. Okay. Probably you need to ask them the consequences also, whether they had faced some or other consequences they might have faced in their life. They might have missed something next day, or was in some also there were a lot of physical complications. So probably that also we need to ask them what kind of alcohol you are using. And in terms of brands, I got a funny experiences with these adolescents. You know, cannabis ka maal kitne rupe ka lete ho? That is the relevant question to ask them. You know why? You know why? Kitne rupe ka maal lete ho? 100 rupe ki pudi, 50 rupe ki pudi, 200 ki pudi, 500 ki pudis. Because that as the price higher it goes, no, it is a pure माल से रहता है ना, और उसमें अच्छा नशा चढ़ता है उनको. That is what these people told me. So yes sir, और many people have the addresses. यहाँ पे अच्छा मिलता है, इधर अच्छा नहीं मिलता है. So all this is very, very different experiences these people tell us. So yes, you need to ask these questions. And you know, when you ask these questions, what another thing that happens, कि the moment you tell them कि cannabis ले रहा है, जो भी ले रहा है, कहाँ से लेता है, कितने रुपए का पुड़ी लेता है, फिर then you ask 50 का पुड़ी अच्छा रहता है कि 100 का पुड़ी अच्छा रहता है, बोलते हैं साला ये अपने जैसा दिख रहा है, पता नहीं थोड़ी देर में मांगेगा एड्रेस किधर का है. So probably they will connect with us, you know, they will connect with us, and that is what we want in this brief intervention, that these people should connect with us. Then only probably they will be ready. Okay, anyways, assessments of various screening tests, audit, cage, craft, clinical interview and examination. Again, patient's perception about the change is very important. We need to ask them, what do you think about your own alcohol use? Did this drug cause you any trouble? Okay, in your life, following substance have been any used? So along with alcohol, there is always a tobacco, or these adolescents use lot of substances like cannabis, cocaine, amphetamine, hallucinations. Okay. Now, during this there are various stages of changes. Okay, all of you must have heard this. Pre-contemplation, contemplation, determination, action, maintenance, and relapse. Okay. We need to see this in little detail. I will come to that point. Okay. Now, when we assess the patient, when we know that with this the patient has some problematic use, okay, or risky use, what interventions you are going to do? Well, as it says, it is a brief intervention. What you are going to talk. So what is brief intervention? It is a technique used to initiate the change for unhealthy and risky behavior use. Now, here we are not talking about the dependence pattern. Or dependence pattern hai. So, what is your approach? Definitely we will tell them to get admitted, whether they will say yes or no. Okay? But here we will have some brief intervention to them, and it is very structured, client-centered, non-judgmental. This is very important point. You have to be non-judgmental, which is very difficult for us. You know, it's really difficult for us. You see some problematic use, and you know, sometimes you feel like that is the best brief intervention that we are going to do. You feel like, but definitely you can't do that. Okay, it is 1 to 4 sessions of, as sir very rightly said, 5 to 30 minutes, 5 minutes or 15-20 minutes. If you have got a lot of time, then you can give, but probably in our OPD, I don't think we can afford to give more than 20 minutes. Again, the aim is harm reduction. Okay, harm reduction. Reduce the substance used to safe level. Probably he may not say, I will quit. Okay. Again, depending on his use pattern and risky behavior, that you need to guide them. Okay. So it is face-to-face interaction conducted by various people. Physician, psychiatrist, psychologist, nurse, social worker. In fact, what I feel, as a psychiatrist, we need to train the people, whoever come with us. All these people, we need to train them for the brief intervention. Then you will be at a ease. Yes, my colleague will do this, or my psychologist will do this. In a setting where we have been called by the physicians, there we need to do it in a brief way. Okay. Sometimes when you have a friend, I mean lot of friends, or you have been called in a conferences by a physician, there you can talk about all these things. So what the physician can do. Physician don't intervene more than तेरा liver fail हो जाएगा या मर जाएगा या छोड़ दे. इससे ज़्यादा उनका interaction होता ही नहीं है. So उसमें से कुछ लोग सुनते हैं, कुछ लोग नहीं सुनते हैं. So again, the various opportunistic setting where we get a chance to go and educate the people, you need to do that. Okay. After this intervention, you can guide them to appropriate referral centers. Again, coming back to this Prochaska and Decremente's trans-theoretical model of behavior change, which is very good. Okay. What is it? It has got 5 stages, which is called as, one is pre-contemplation. Okay. Most of the patients who come to us are in this stage. They don't have any desire or any plans to make a change. Okay. Here we are dealing with the patients who doesn't have a plan to change. Now, as we did the screening, we know we have got some results about risky use or some laboratory results which shows the bodily harm. So how do you make this person from not ready to change to start a change? That is where the skill is. Now, as these people sit in front of us, okay, they are not in a plan to kind of change it, okay. What is most important thing what you are going to do is here, inform them about what you will learn, what your their scores, okay. Informing in a non-judgmental manner, that is very important here, okay. So once they get the information, probably you need to ask them, now what will you do? Okay. Their answer will guide us for the next steps. Okay. They will say probably ठीक है मैं देखता हूँ, कम करता हूँ या बंद करता हूँ. Then फिर कैसे करेगा? How you are going to do it? They don't have any plans for that. Probably in the discussion they might say, Doctor साहब आप ही बताइए, or let us see what we can do, how you can guide me. Then is the right time to guide them. Now while guiding them, you need to go next step of contemplation. So where the person was not there come for any change, started asking few questions, probably is thinking of change, not fixed, and is confused whether he has to change or not change, or he doesn't know the ways of changing it. So here you use this model, okay. Now here in contemplation, what you need to do is, apart from providing information, you need to motivate them. Now what are the motivated factors? As we're talking to him, it is not just about the substance use. You're talking about generalist lifestyle, where the risky behavior comes, where the use pattern comes, in which condition he uses, where he uses, how does, what is he do, what is his lifestyle. So when you are aware of most of the things in his life, so you can use that examples in his life. Now recently I have one doctor who's a BMS doctor is admitted with me. Cortisone tablet, around 20 to 30 tablets daily consumption, okay. Fortwin, IV injectables going on last 1 to 2 months, okay. Family was fed up, although he was saying his OPDs and taking his rounds, but it was becoming difficult. His work was deteriorating over a period of time. So in between OPDs he used to inject himself and start saying this. So anyways, I mean, he had come to OPD and then family forcefully brought him. He was not ready for anything. Okay, ठीक है सर, वो तो मैं कम कर दूंगा, बंद कर दूंगा, उसमें क्या है, मुझे नींद नहीं आती इसके लिए मैं लेता हूँ, प्रॉब्लम तो नहीं है. So as he answered all these things and was not ready to at all. Then just while talking, he was from a lower class family. He is the only educated person in his family. So our family was very proud of him that our son has become a doctor and he is practicing. So that was their value system was there in him. But now the point is, we know this value system is there. Probably this is the anchor where we can hold him over here. So when you talk about this fellow, when I spoke to him about his work pattern which was deteriorating, and his aim was, I am the only person in my family who has become a doctor. I want to become a good doctor, but I hooked into this. Now why I hooked into this? Because he has a broken love affair. And family didn't agree to this. So he has to marry a girl without his, not consent, I would say, by force of the family, and he was not very happy in that relationship. So what he used to, he has told me, sir, घर पे जाता हूँ तो कहाँ इसका मुँह देखो, गोली ले लेता हूँ, सो जाता हूँ, tension. Now this is his motivation not to change. Okay. In his daily life, he has this, he has to go back home, see the home environment, family has forced his marriage, and he has to sleep there, so he doesn't get sleep, he thinks. Now this is what motivates him. So हर रोज मैं ले रहा हूँ, जाके सो रहा हूँ. Now when this is overweighing for something, he is unlikely to give up his substance. So another anchor where what we can teach him the benefits of change is how it is affecting his daily life. If it is affecting his practice, where it is difficult for him probably over a period of time to sustain it, and if he, as a doctor, he knows it is harming his body, but He was not aware that he is going away from his practice. That awareness can motivate him to give away. So this benefit and risk can bring this patient to a contemplation stage. From there, you can take, so when he is ready, you can take him for preparations and guide him. Once he decided for this change, you can guide him starting medications. And in this case, I told him to get admitted. Let us see how it goes. So he was ready to get admitted. Most of the times, they are not ready. Sometimes we do forcefully admit in our setup and do all these things, whatever we have to do it. So then preparation, then action plan, you have to give him treatment and what he has to do, how he has to stay away from the substances. Then again you have to monitor labs, maintenance and everything. Okay, so I'll be a little faster. Components of brief intervention. Feedback is very important. Whatever information you have gathered, you have to give him a feedback. Again, you have to build up a lot of suspense here. Immediate feedback nahi dena chahiye. Okay, slowly you inform them, get them answers from them, and then next action plan. So when in next action plan, so this components goes into the model of frames. Okay, feedback, responsibility. Probably they can follow it. It is difficult, so this is how they are going to relapse. So you can encourage them, support them, and that is how you do it. While doing all this process, the important thing is, as I said, non-judgmental. So empathetically you need to listen to them. Reflective listening is very important. Okay? Can anybody explain to me what is reflective listening? Yes, sir. Yes, madam. Repeat the same thing in a different package. Okay? Or you can rephrase it. That is how I feel, oh, somebody is listening to me. Okay? And be non-judgmental. It becomes difficult, but we need to kind of learn this. And from that, you can instill a confidence in them that, yes, you can do it, and probably there is a journey. Most of the times what happens, you can encourage them, it's okay now you did, sometimes probably you left the substance for 1 month. That is good. Let us see, now you can do further tasks. Okay. So that's how you can build their confidence in self-efficacy. Okay, come end of my presentation. Yes, brief intervention and screening are there, but there are lots of obstacles for us. Lack of time. Okay, definitely we don't have time. It needs a lot of training and motivation to the professionals. We need to train them. Okay. Organizational factors where you are using it, administrative support, priorities, technologies. So again, if you are using these, whether financial gains or not, all these matters. Okay. Now in conclusion, the self-report screening tests are reliable, valid in most clinical conditions. Okay. Use of screening test depends on provider and the patient characteristics. Self-report response bias can be predicted, detected and minimized. Brief intervention can reduce the substance and alcohol use for at least a few months, or it can motivate the patient to take some kind of help, maybe from doctor, maybe from somewhere, or sometimes. I have experience of many patients who had come after 1 year. So initially they met me once or twice. Some talk probably after 1 year, nahi sir, abhi something we need to change. Okay, it is very acceptable matter. It's cost effective for smokers, drinkers, and many of the drug abuse. Okay, thank you so much.
Thank you, Dr. Ramtek. It was a very good, informative presentation. Now I open the floor for any comments, suggestions, or questions. Mike.
Sir, it's an excellent presentation, sir. My question is, usually alcohol use patients, abuse or dependence patients, they use abnormal defense mechanisms like denial and rationalization, sir. So how to deal with them?
It's as I said in the presentation also, most of the times they are very difficult because yes, the denial comes in various parts. I mean, not just substance abuse, but isse to kuch ho hi nahi raha hai. Although you can see the complications, that liver is failing or probably a lot of vitamin deficiencies. So now again, information is very important. You need to inform them. How much they are going to accept, it's very difficult. Okay, but at least if you listen to them and try to connect on certain points. Okay, especially these adolescents, if you connect with some part of their daily routine use or somehow they are getting the substance, or in terms of alcoholics, how it is affecting some part of their life. See, some anchorage is there always. Either it is a difficulty in their professional life or in a family life or difficulties with the kids. Okay, most often in grown-up people, say 50 plus, the attachment with the kids is not there. Okay, and they feel it, somewhere they feel it. Okay, I want to go home and talk to my kids, but kids, because of their using pattern, they are not close to them. So that rift you can use. I mean, this information you can gather from them. If that anchor can fit, you can do that. Certain other beliefs also. Some people are religious. Okay, so take information of that and you use that. Okay, how it is affecting them? Do you think this? So again, gathering information and connecting the dots probably build trust in you. The moment trust is there, slowly denial will go. Okay, it is the issue of trust, and it takes a lot of time.
It's not a question or anything. I really compliment Dr. Sailesh for an excellent topic. Very sensible, sounds very commonsensical, but the way you put it is very, very important points, especially for the youngsters. Non-judgmental, making a relationship, we all know, but the way you explain the way it is, the BI, and that particular thing also, cost of change and the benefits of continuation, the way of looking at it from a different angle. These are the things, and especially at least for the 12 months, harm reduction. I think we have to look at those points instead of saying completely off, which is very easy to talk about. And that way it's a very useful lecture. Thank you very much. Mr. Mohan.
So thank you for that excellent talk, sir. I'm Dr. Abhiteja. So during my 7-year stint at CMC Vellore, I thought we covered almost every case that is in the textbook. But then 3 years ago when I relocated to Nizamabad, and I used to fail a lot of times to find during my interview whether they are consuming any substance or not. Because when I would say, do you take alcohol or in confidence, they would say, no, how could you ask me that? But eventually, thanks to my seniors, Dr. Rajendra and all, they told me, no, they don't consider this local toddy as alcohol. Yeah. It is a culture.
That is another very popular misconception. दारू बंद किया, हाँ बंद किया, ताड़ी ले रहा है, वो ताड़ी ऐसा, उसमें क्या है? कोई problem नहीं है. So they feel it is a health drink.
Yes, sir. So, but have we adopted any Indian versions of these brief interventions where we can diagnose local,
I'm not aware of any screening test that is existing.
We have to adapt and understand what local issues are and then change accordingly.
So again, see, the idea of presentation is here. As a clinician, we learn from the screening test, but you need to rephrase your questions when you're dealing with. Suppose I'm dealing with the patient who's in a Nizamabad, I need to rephrase my question. I'm dealing with a patient who's in metro city, I need to rephrase the question. Depending on the socio-economic status and understanding of the patient. That is how it makes an excellent clinician out of it. It's not just some questions, tick mark. That is not the idea of learning. Okay? Yes, questions are there. You rephrase it, reframe it, and then you ask to your patient.
Thank you so much.
I think most of us in practice use concepts of brief intervention into our counseling when we are actually. The most important point, as Dr. Ramkumar said, it is to connect to the patient and able to make him reflect back as to what actually he is saying, what is the reality. If you are able to do that effectively, most of the times the contemplation, the pre-contemplation to change starts coming back quickly. And the brief interventions are the most cost-effective ways of actually dealing with addiction problems. And rather than the ideal rule of complete abstinence, work through, it suggests that you work through harmful, through reasonable, and then try and see if it can be done. Sometimes it works wonders with some patients, sometimes it doesn't work. Okay, but the concept has to be clear that what we are actually trying to, at what stage the patient is in motivational cycle, and what is the suggestion and what is the intervention you are going to do. If that is done, I think it is reasonably a good method. Anything from PGs? Yeah, Dr. Sai Krishnan. Mic akkade on. Mic pe pakkane on.
I'm sorry.
In continuation of what Dr. Aviteja asked.
Sorry.
Yeah, in continuation of what Aviteja asked, I'm not fine. So he asked about culturally relevant screening tools. So I also believe there are certain aspects of brief intervention which need to be little modified. Say classically, what textbooks say is avoid argumentation, and then no fear, appraisal, nothing.
Bro.
But in Indian context, I very confidently believe that the fair appraisal is a very good module. It can affect the remission rates and those things. Likewise, say for example, we see tobacco packaging. Although we may not say that the amount of cigarette smoking has reduced, but then it has reduced because of packaging where it shows carcinoma images on the cigarette packets. So I believe saying that ये तुम लोगे, इनमें लोगे, यदि को liver ऐसा हो गया, मर जाओगे, those things are not they are not to be told as per the literature or from the Western. But in Indian context, I think it will definitely.
See, what happens, you are very right, but do you know, you will not be the first person as a psychiatrist to tell him that मर जाओ. आपके पहले बहुत लोगों ने बोला मुझे.
But a doctor saying him that तुम मर जाओगे.
So before he comes to you, a doctor also had said, he is not the person who had come to you directly, because again it is substance use abuse. Okay, so probably yes, he has been told again and again. And जो डरते हैं ना, वो dependence तक जाते ही नहीं. The moment they see in the society the package of tobacco, the package of everything, and they see that their friends are dying because of alcohol use abuse. In fact, I forgot to talk to you. If you have 5 minutes, I'll just brief about some kind of patients in the society. We see there are 5 kinds of people in the society. Okay, substance abuser. First, for occasionally using the substance. Okay, so occasionally will be once in 2 months, once in 6 months, or maximum once in a month. Okay. Another criteria of the patients is who are using occasionally, but their occasions comes very frequently. Okay, okay, that will be say every 15 days, 10 days, or whatever. Okay, number 2 kind of patients. Third kind of patients is who are regular consumption. Okay, regular in terms of, but the quantity is very less. So 1 drink, 2 drink daily, 10 साल से हमारा चल रहा है, कोई problem नहीं है. Okay, third kind of patients. Fourth kind of patients is binge drinker. Okay, fifth is our dependence pattern, daily drinking, consuming, whatever. Okay. Now, as you very rightly said, the fear model works for whom first 3 kind of patients. Okay, occasional who is regular, or very regular. The moment इनको ये सब पता चल जाता है ना, देखो, there are people in the society who had gone up to abuse, problematic use of the substance, stopped their substance by their own somewhere. They didn't reach to anybody. Now, certain things in the society has acted on them. So we call it something called as rock bottom. Okay? So now the rock bottom hit to them, they recovered. They didn't needed an intervention. But I feel the patients who come to us from any of these things, they are not scared of death. Believe me. I have seen a patient से पूरा पेट फुला हुआ है, चलने को नहीं होता है, कब छोड़ोगे जाके दारू पीना है और मर जाएगा, चाहे तो सर क्या हो रहा है, किसको जीना है. Probably they are in the last stage of intervention. We can't do anything about them, or we can't use that motivational model grid where we have to take the anchor from them. Yes, it will create the fear, will create some awareness in the patient. They will leave, they probably will not come to us. They had left the substance. But who had come to us may not be the first person that we are telling them, this is going to harm you. We have to tell them definitely, but rephrasing in a different way. Okay, that will help them definitely. Again, the tone has to be different. Okay, the tone has to be different. Now, do you think the tone of a physician and a psychiatrist will be different while telling that how you are going to die? It will be different. Physician will be very irritable and क्या करता है? 3 बार 4 बार जाने तो physician के पास will be irritable. We shouldn't do that. I mean, of course, it is by practice. It takes a lot of time. अंदर से feel भी होता है most of the times. You know, ऐसा लगता है कि दो अभी थप्पड़ मार दे. But anyways, you need to be different. Yeah, thanks.
I also agree that there's nothing like you should not make the patient fearful about what's going to happen. The way you talk about it and the way you reflect about it, and most of the times, okay, it is how you reflect it. Okay, most of the psychiatrists, we must have learned by now that what the patient is thinking through when you're trying to tell. If you start that as a monologue, okay, and tell them that, hey, this is what I'm not drinking, I'm not having, I'm actually physically fit, I'm going for my birth. Okay, there's nothing, all the doctors are big. They're only showing me this LFP and threatening me. What is this? My father drank till 90 years, he's not going to get anything. What am I going to go through? So then he understands, the doctor is able to understand what I'm going through. Okay, then maybe what you're saying actually makes a little sense to them, or they try to listen to you, or you're able to connect to them better is what over a period of time I understood. Or okay, that's what. Yes, sir.
2-3 quick things. Firstly, I agree with MS Reddy. That presentation was excellent. I heard large part of 2/3 or 3/4 of it at least. At state level, to have this level of presentation and the narrative that you gave is very pleasing. But about last thing that you were discussing, such a person and presenter, I have one idea that I have written about quite a few places and I have practiced it. Consider it, all of you, young people and my colleagues. Besides you saying this is what will happen or this is what we think is happening to you, you know what I found useful since at least 1990, Ames days, is present to him the objective evidence of health damage. For example, if you have a X-ray screen in your clinic, present a normal CT, show him his CT. No distortion. Some doctors will distort. I don't do that, I don't believe in that. But show him a normal CT and say, this is the normal CT, this is your CT scan. It scares the shit out of him. Okay? Let him know that normal gamma GT is 0 to 40. Your gamma GT for last 6 months has been 3 times that we got done, about 350 or 400. So to repeat, objective evidence of health damage being discussed as a clinician. You know? Second point linked to that, I think I heard you say, I'm sorry I missed the initial part, but I think I heard you say that brief intervention or any of these techniques can be very useful not only by us or psychologists but also by physicians and surgeons. And that's a huge untapped potential. Consider this, please, all of you. For a patient of alcohol, tobacco especially too, a physician or a surgeon who has helped the patient out of a health complication is the best person to do brief intervention, not you or I. Not Ames, Nimans, Ivas. Okay? You have saved the person from a bleeding gastric ulcer. Now, gastroenterologist, if you have trained him or her to do the brief intervention, then the patient knows this is the guy who saved my life. You see, a lot of oncologists, pulmonologists are getting into tobacco treatment, and this is why they are effective. Because I first help you with your health complication and then give you brief advice to the point and say, boss, this is what you should know. So those are the two major thoughts that I want to share. Thanks.
Thank you, sir. Thank you.
Yeah, Dr. Jaz.
Bro, Jagdish bro.
Pharmacotherapy to motivate patients to get detox and use how do you take it?
Yeah. Again, many of the patients that come to us is about the dependence pattern. Okay. We need to make them understand their pattern of the use, where it is causing the problem, and abuse and dependence pattern. Then probably you need to give them medicines and tell them this is how we are aiming at it, that it will help you. Most of the times the dependence pattern patients fear is the withdrawal symptoms. Okay, the moment they stop it, next day morning they get vomiting, restless, tremors, and that is very scary for them. So if you tell them that these medicines are going to help you for that, they are likely to take it. Okay, most of the time they take it. By the time they come to us by brute force, they are somewhere in the mindset that they have to take a medicines. Few patients I have seen not taken. They will say, हाँ ठीक है दे दो, घर पे जाएंगे, नहीं लेंगे कुछ भी, उनका उनका चलता रहेगा. Few patients I have seen, they were taking the medicines, but they were consuming their substance also. Okay, and they come to us. अच्छा तो है, पहले 5-6 पेट पीता था, अभी 2-3 पे आ गया, थोड़ा कम हो गया. So at least okay, you see, ठीक है बाबा, तो कुछ तो भी कम हो रहा है. Probably you can again motivate उसको भी कम आए. So various outcomes you will see by counseling them. And some people are not ready for treatment because they have been brought forcefully. So there, again, giving them medications probably will be difficult. As he was telling, some people की डराना जरूरत है, या few of the patients who are dependent and there is a risk for the life. So forcefully they have been admitted in the hospitals also because we see there is a risk to the life. Okay, that way also some patients are dealt. Anecdotals, I don't think there are any studies. Anecdotal experiences, individual experiences, forceful treatment से क्या होता है?
Well, this is just like not exactly question. Not exactly a question. Just like a clarification. You see, many patients come to the specifically I'm telling you about alcohol. Like they take a short period of benzodiazepine in the in the initial phase of withdrawal they come. They just want. He said, I'm not getting a sleep. Sleep they can go back with the benzodiazepine. And they make it like a regular process. But every time they have develop some sort of simple transit features and they come for the benzodiazepine, goes into benzodiazepine, and sometimes they take over-the-counter benzodiazepine also. And in the process, more than alcohol, they go into benzodiazepine. Without the brief intervals we are talking about, these are the people who is going to benzodiazepine dependence. They may reduce their reduce their alcohol intake, but they go into benzodiazepine intake. In that case, what sort of intervention process you think about?
Yeah. Very important. Brief intervention talks about the intervention, but doesn't think of the most of the personality part. Okay, where in clinical practice we need to see that also. A person who's likely to abuse benzodiazepines has a lot of personality issues probably. So if we see that again, and clinically you judge that if I'm treating this fellow for alcohol, he's finding relief with this, feeling better, he's likely to abuse. If you get that little idea, you can give them an idea about that. For how many days I'm giving you, please continue for that time. Come and see me again. Most of the time, I don't know how many of you people practice prescription देने के बाद में आके दिखाना, बोलना चाहिए this line, या तो लिखना चाहिए. मोस्ट ऑफ द डॉक्टर आपने दवाई दिया, हमने लिया, अच्छे हो गए, आए नहीं, फिर अभी 6 महीने के बाद तकलीफ हो रहा है, फिर आ गए. सो प्रोबेबली यू नीड टू रिफ्रेश दैट कि 10 दिन के बाद या 5 दिन के बाद आके दिखाना है. Okay, then so that we can reduce, treat you again. Okay, whatever they may feel, probably they will feel doctor बार-बार बुलाता है, पैसे लेता है, whatever they will feel, but you need to tell them. Okay, and again, if you feel that he is hooked to benzodiazepines, probably if you give different, in fact, I have few patients who just come for prescription of benzodiazepines or some naltrexone kind of substitute. They come, then you give them prescription, you will never see them. That is what they. Then it is okay. I straight away refuse to them. बस जाओ, मैं नहीं दूँगा. Okay, it is up to you how you want to handle it. And when you are seeing that this person is getting hooked to this, you can explain that now you are getting hooked to this. Probably we need some other kind of treatment, non-benzodiazepine withdrawal symptoms kind of treatment.
Sir, so the talk was very wonderful. One last question.
We have seen patients detoxification. If you start with 100 mg of chlordiazepam, they will come down to 10 mg of chlordiazepam. We are able to maintain. But stopping that 10 mg of that very low dose of benzodiazepine, it would be very difficult. We would be maintaining on that 10 mg for a long time. It should be fine.
So
but stopping that 10 mg and trying to give other alternative sedatives is not satisfied.
No harm.
What is whether we can continue it or we can, but we say not to continue. What's your take?
No harm to continue.
No harm is one factor. You can replace it with some other medication and see. If it works, that's good. If it doesn't work and 10 mg is taking, as sir said, it's very low dose, your monitoring is LFT, can continue probably.
Thank you very much, sir. I think it has been a very wonderful session. The participation from the floor is also very encouraging. Before closing, I just want to set this as a conclusion that brief intervention is not to lose the nihilistic factor which is there with the de-addiction treatment, that if I don't, this person is not going to get benefited anyway, or let me not talk or give him the lecture or sort of a thing. It is to intervene at an appropriate time as service intervening from the physician level, not only from the psychiatrist. It's not purely for the psychiatrist. And people who need a longer intervention might need a rehabilitation center, admission, therapy. Okay, that process will go on for patients who require a longer thing. Before I close the session, I give it to my co-chair.
As Sir was pointing out about the brief interventions, for the first time in Telangana State Branch, we had a pre-conference workshop pushing the boundaries of psychiatry beyond the psychiatry and to the other medical fraternity, to the point of even to the nursing staff. And the workshop was very successful because the feedback we received was so good. And just to note that this was the idea of brainchild of George Reddy, sir. It was first of its kind in the state branch. With this, I thank Dr.
Thank you for calling me here. I'm really, really grateful to you. It's like coming back home. Thank you.
Thank you.
Thank you, sir. Now to felicitate the speaker and the chairpersons, I invite Dr. Sudharani ma'am, Dr. Aparna ma'am, Dr. George Reddy sir and Dr. Vishal Akula sir onto the stage.
Dr. Sailesh is son of the soil. He is from Nizamabad.
next session. So the next section is topic is long-acting and depot formulations in addiction psychiatry. The speaker is Dr. Atul Ambekar, and I invite chairpersons Dr. Nimesh G. Desai, sir, from who has done his MD Psychiatry and MBH in USA and MRC Psychiatry in UK. He is a senior consultant, psychiatrist, independent consultant in MH and former director of IHBAS Delhi. I invite you on the stage, sir. Dr. Desai is a psychiatrist and qualified public health professional with public service academic career of 40 years on the faculty of Finance, Bangalore and AIMS Delhi. Next, we invite Dr. Sujit Sarkar, sir, the next chairperson. He is a professor at Institute of Psychiatry, Kolkata, and he is honorary editor of Indian Journal of Psychiatry, assistant editor of Indian Journal of Psychological Medicine, Indian Journal of Private Psychiatry, and past editor of Bengal Journal of Psychiatry, Eastern Journal of Psychiatry, co-editor of IPS textbooks named Suicide, Indian Perspectives, Recent Advances in Psychiatry, and publications. He has more than 70 publications in national and international peer-reviewed journals, and his areas of interest are suicide, research methodology, OCD, child and adolescent psychiatry, and genetics. No. So, on to chairperson, sir.
So, Dr. Atul is presented online. Yeah.
Harsha, please keep the link. On behalf of organizing committee, we welcome Dr. Atul Ambekar, sir. We are handing over the proceeding to the chairpersons.
It's a pleasure to introduce Dr. Atul Ambekar, and I think he has been doing seminal work as Professor, National Drug Dependence and Treatment Center, and it would be really a privilege for all of us to listen on depot formulations for the treatment of addiction disorders. And over to Desai sir for further few lines on the topic, and then we can start.
Thank you. Thanks, Ashley. Dr. Atul Ambekar, I have seen since what, 1997. Atul, grow from his first PG days to now. Atul, it's great. And his topic, like Dr. Sujit said and the organizer said, it's wonderful. I really want to listen to Atul about this because this is not often discussed. Long-acting and depot formulations in addiction psychiatry. So Atul, all yours. We'll listen to you for whatever length you decide and then have some discussion. Thank you.
Thank you, sir. Thank you very much. At the outset, my sincere thanks to the organizers for giving me this opportunity, including my friend Dr. Vishal Akula. It's really unfortunate that for some unavoidable reasons, I could not be there personally. But since he gave me an opportunity to interact with all of you online, I'm really grateful. What I will do now is, over next about 30 minutes or so, 30 to 40 minutes, I will walk all of us through some degree of some important issues related to long-acting pharmacological options in addiction psychiatry. What we need to remember is that this talk is not just going to be about something like clinical practice guidelines on who and how to give and so on. What I am going to discuss is basically some bird's eye view type of issues, some broader issues related to how do you assess effectiveness of an intervention and what are the ethical issues involved in choosing a particular kind of interventions. So we'll begin with this topic now. What we need to understand is when we talk of long-acting pharmacological options, they are relevant largely in the context of opioid dependence treatment. There is some work on using naltrexone long-acting injections for alcohol use disorders as well. But the more complexities in treatment as well as regulations of treatment, they arise in the opioid dependence treatment, and that's what I am going to talk about today. So, as we all know, opioid dependence is one of the most serious public health issues known in the entire world. In fact, among all drug use disorders, opioid dependence has the largest share of mortality as global burden of disease. The disorder, like any other addictive disorder, is on the lines of a chronic non-communicable disease, and hence what we require a judicious combination of pharmacological and non-pharmacological approaches, and for a very long term, just like we do for depression, schizophrenia, or even for diabetes or hypertension. And that's the reason why, like all of these chronic non-communicable diseases, the compliance and retention in treatment is a major challenge in opioid use disorders. As far as management strategies conventionally that we all follow, they go for opioid dependence. We have what is known as detoxification, in which we provide management of acute withdrawal phase, followed by, in many cases, we put patients on antagonist maintenance. And both these treatments, withdrawal management only or along with antagonist management, they have high rates of relapse and have lesser acceptability among patients. On the other hand, an approach like agonist maintenance or opioid substitution treatment, it has been shown to have high retention rate, reducing opioid use, and in general improving socio-occupational functioning and quality of life. And that's the reason why most of the treatment guidelines, including India's own IPS guidelines as well as Ministry of Health guidelines, they favor agonist maintenance as the ideal long-term treatment for chronic opioid dependence. So what we have is naltrexone as a medicine which we use for antagonist management, which we know lesser acceptability and compliance is a challenge. On buprenorphine or methadone, while the acceptability of medicines is much better, but there are always concerns in aversion. People may want to divert them, misuse them, sell them, or in many cases, in fact, may want to dissolve these tablets in water and inject.
Recording stopped.
So which would defeat the purpose of treatment. And that's the reason why there has always been, for a very long time, a search for some kind of options which can address both these concerns, compliance as well as minimizing the risk of diversion. Now we know in psychiatry in general, long-acting antipsychotics, they have been playing a very important role in psychiatry. So people have been wondering, can long-acting formulations be developed for opioid dependence? And this is really not very new. As long as more than 10 years ago, some of our colleagues, they had actually published a review article on long-acting preparations in substance use management. So the work has been going on for a long time, and one wonders why it has not picked up. And that's what we are going to address in today's talk. So as far as technological innovations in treatment of opioid dependence go, for both these set of medicines, naltrexone and buprenorphine, we have both depot as well as implants available. For buprenorphine, we also have cutaneous patches as well as oral films, which we are not going to discuss today as in terms of technological advancement. As far as naltrexone goes, the long-acting formulations are available more commonly as a form of injectable depot formulation, which are microspheres of naltrexone with some other polymers. The various strengths are available. Most common strength is 380 milligram, and it's supposed to be administered once a month as intramuscular injection. Naltrexone implants are also available, which are going to be surgically placed below the skin. Very high dose of naltrexone, and they last from 2 to even up to 10 months also. For buprenorphine, again, I'm showing, since this is one of the rare sort of formulation, and very few brands are available internationally. I'm showing them here, but I do not really imply any kind of endorsement here. So there is a preparation called as probufin, which is 6-month implants. Then we have once month or once weekly also preparations in the form of sublupent or Vividal. There are some differences in them. I'm not going into details of these differences, but the implant ones, it can last even up to 6 months. The subcutaneous injections, they can last from 1 week to 1 month. Different kinds of different sites on the body on which they can be administered. Obviously, implant is much more intensive procedure and hence requires much more intensive training. The level of training required for the health professionals is much less in terms of subcutaneous injections, monthly injections. So now what we are going to do is very quickly we have a critical look at the evidence which is what effectiveness as well as some of the ethical issues around these formulations. What we need to understand, I will need to, as a disclaimer, one is not endorsing any certain type of treatment here. It's certainly not really a headline. Please do this, do that. That's not the idea here. The idea is to generate discussion on, as a profession, the approaches we should follow for our change in our practice. Looking at the some of the effectiveness issues first. One of the earliest trials was a placebo-controlled trial of injectable sustained-release naltrexone, a very good RC12 blind placebo-controlled 8-week trial, and showed very good results in terms of best results with higher dose of naltrexone, followed by lesser dose of naltrexone, and followed by placebo. No surprises there really. But then this involved comparison of injection naltrexone with placebo. Even we know when the oral naltrexone itself has had not a great evidence of efficacy in general. So ideally, injection naltrexone should be compared with oral naltrexone also. So we should probably have a research design in which we compare placebo, oral naltrexone and this newer formulation of injection naltrexone to see whether it really works over and above it or not. And that's why this RCT I came across looks a wonderfully designed RCT, 2019 publication, where they compared extended release naltrexone, oral naltrexone, placebo. The outcome parameters were all the standard parameters like reduction in drug use, as well as some of the secondary important objective outcome parameters as well, including quality of life, craving, and so on. But, and it's a big but, the sample size was only 6. So this was really a study about how to do a good study, not really an example of a good study. So this was an idea, a sort of a learning model for how to conduct a good RCT, but really could not provide us any important piece of evidence itself. But the most seminal piece of evidence was this, published in none other than Lancet, a double-blind, placebo-controlled, randomized 24-week trial of 380 milligram sustained-release naltrexone with Couthro, all the standard outcome measures, abstinence, confirmed with urine, craving, retention, and so on. Good sample size, 250, and very clear evidence of superiority of sustained-release naltrexone as compared to placebo on almost all the parameters. So far, so good. But these were two very important critical issues here. That this trial was funded, number one, by a pharmaceutical company, and this trial's results were used to get FDA approval. And where was this trial conducted? The trial was not conducted in the US. The trial was conducted in Russia. In Russia, where agonist maintenance treatment is not available, in fact it is banned. So you actually chose a setting where the good treatment is not available and compared to inferior quality treatments to show us which of these is less inferior. That's what the critics argued. Also, in this trial, the risk assessment of putting patients on naltrexone was not adequately conducted. Particularly the risk of overdose in treatment dropouts, that was not addressed. We need to remember here is, what does naltrexone do? Naltrexone is an antagonist. So on naltrexone, people immediately lose their tolerance to opioids. So once they stop naltrexone and they decide to start taking opioids again, they may not understand that now they do not have tolerance. They may take opioids again in the same dose they were taking earlier, which then can happen as that can result in overdose. That's why naltrexone treatment has been frequently found to be associated with high overdose and mortality. So critics actually in the same issue of Lancet raised this issue that why should such a trial be allowed and the results of such a trial be allowed to grant US FDA approval. Nevertheless, as the industry mechanics go, dynamics go, the FDA approval was granted, it was welcomed, and in fact in many state governments in USA, they started sort of very strongly endorsing long-acting injection naltrexone as a part of government-approved kind of a treatment. In fact, the US Secretary of Health and Human Services, something akin to our Health Secretary or even Health Minister, after visiting the manufacturing plant of this pharma company, he declared that the naltrexone depot injection is the future of opioid addiction treatment, while buprenorphine and methadone were simply substitution of illicit drugs. And as a response then, the doctor community there, academicians, researchers, doctors, about 700 of them got together and wrote a letter to the government that no, what you are saying is wrong. The agonist maintenance is not simply substituting one illicit drug with another, but this is actually something promoting recovery. They in fact provided recommendation that you need to improve treatment capacity in the country and make the treatment more affordable in the stigma and so on. So in some countries, doctors besides possessing brain also possess spine, is the example I wanted to sort of cite. So, but should we actually consider long-acting opioid agonists? That's a very important review as well as opinion piece article came on from the France. And France is a country which has a very high coverage for both methadone and buprenorphine treatment. In fact, highest in the world. So on both these treatments, they are available with prescription, with dispensing, very tightly regulated, and they have been demonstrated to have detection in HIV instance as well as they have noted about 20% of illicit opioid users, they misuse buprenorphine. So for this reason, this particular opinion piece suggested that we must find some place for long-acting buprenorphine preparations as well. As far as efficacy of these preparations go, again in this wonderful, very good study, and this I think is the kind of study design we should be looking for any newer treatments available, not comparison with placebo, but comparison with existing standard as well. So what we are looking here is not really evidence of superiority, but in fact an evidence of non-inferiority could also be informative for us. So for this particular study, this actually showed that injections were not inferior to sublingual, or in other words, equivalent to the standard of care. Walter Ling actually is one of the, can be said to be father of agonist maintenance, but with buprenorphine in US, and then their group, they conducted, they published this large-scale review on what would be the place of buprenorphine injection, tracing the entire history. And what they themselves wrote is that at this moment they do not find any demonstrable superiority of outcomes using extended release preparations over our usual sublingual tablets. At least in US, there has not been a very enthusiastic response to these new preparations. Why? Number one is the complexity of delivery of this treatment. You require more training, more resources. Obviously, the treatment is more costly. And in terms of patients also, it brings an element of non-predictability in their lives. They on oral everyday oral or sublingual medicines, their lives are largely stable. They know what time they will take this medicine, what time they will experience the peak and trough, and so on. With these injections, they are afraid whether they will be able to adequately control their craving and withdrawals and so on or not. Also, there are issues about what if patient for any surgical reasons require a full mu agonist, opioid mu agonist. Then how do you actually remove the effect of this partial agonist buprenorphine when it is already inserted in your body? So these are some of the actually important clinical concerns. One of the reasons behind less than expected popularity of this form of treatment. And what kind of treatment patients actually can be chosen? Some suggestions have been given. Patients who are ready to make life changes, stabilize, or so on. ultimately, what experts say is anyone who has an opioid use disorders can benefit from oral sublingual buprenorphine tablets, can also benefit from this also. There should not be any artificial attempt to determine the prioritization. And what about comparing once again, long-acting agonist with antagonist? This particular group compared extended release naltrexone with daily buprenorphine naloxone combination. So two very entirely different kind of treatment approaches, yet compared head on. This was obviously an open label study. You can't really expect to have blinded. They took 159 detoxified patients and concluded that efficacy was almost equal. But please mind here, patients were already detoxified. We know the most important challenge in naltrexone treatment is the first few days of treatment when you are providing them acute withdrawal management. That's when patients are likely to drop out and relapse. So that stage was already crossed, and hence one really is not surprised to see that both of them have had a almost similar outcome. Stretching the argument further, this particular study again compared sustained release naltrexone and buprenorphine naloxone. Again, an open label study, a large scale trial. Here also, when they looked at data from intention to treat model versus the per protocol analysis, the results were slightly different. Per protocol, the sustained release naltrexone and buprenorphine naloxone were almost had equal efficacy. While intention to treat model, the sustained release naltrexone fared slightly better because the patients who dropped out were already removed from the analysis. We have also talked about that we should look at impact on social determinants of health when comparing the outcomes. This was a sort of a systematic review, and what they found is long-acting formulations were improvement in many social parameters as well. But it's important to have patient's preference to be taken into account. All of these were trials. What about the real world? This particular group of authors, they compared 4 types of medication in a very large-scale database and found that sublingual buprenorphine naloxone had lowest discontinuation rates, even as compared to injectable long-acting naltrexone. So this really tells us something, the difference between the real-world data as well as the experimented, controlled kind of designs. Here also, this group of author Wakeman et al. 40,000 odd treatment trips were analyzed. Comparisons were conducted of no treatment versus different types of interventions, and they also concluded that our standard sublingual buprenorphine or oral methadone is associated with best reduction in overdose and reduction in other kind of opioid-related emergency room visits. This is what I was talking about, which many people miss, policymakers also miss. That when large number of people are put on injection naltrexone, usually research trials as well as in the real world, people do not take into account the risk of overdose and mortality. And what they have found is that a large majority of overdose deaths, as many as 85%, occurred within 2 months of last injection of Vivitrol. So which means when patients discontinue their injection long-acting naltrexone, that's when the risk of overdose is high, and this is something which cannot be discounted if we were to consider having this treatment available. To cut all these long stories short, the final answer came from this large-scale analysis, which they also looked at cost-benefit findings, and what they found was that among all these types of interventions available, the methadone and buprenorphine or buprenorphine naloxone maintenance has the largest effect size of all treatments, including and also in terms of injectables, the cost really does not support, is not really corresponding to the outcome that we get. This is all about the effectiveness type of issues. I will finally conclude with some of the ethical issues surrounding these forms of treatment. This particular opinion piece, I found it very interesting, which said that long-acting naltrexone offers the fantasy of being drug-free, but that's not the most important thing in tackling addiction. And many of the even professionals, mental health professionals, have this misconception that the idea of addiction treatment is making people drug-free. The idea is to keep people drug-free as well as productive, happy and comfortable in their daily lives. That's what the treatment is all about. These authors have argued actually that in the center should be the patient, and the treatment which the patient actually gets is decided by a complex interaction between what is the research evidence, what is the policy environment, and what are the market forces sorting for. The example we can get is from the Russia's example, where the most effective treatment is simply not allowed, and that's why evidence in a way is manufactured to demonstrate which of these treatments would work and which of these treatments would not work. Or the policy environment. If the government decides to provide only one kind of treatment through its insurance model and not other kinds of treatment, then the patients will be forced to choose the lesser of the evils. So the idea is that as health professionals, we should keep the patient's best interest at the forefront, and rather than being influenced by the policy environment or the market forces around us. There are some obvious advantages of long-acting preparations: reduced travel time, no peaks and troughs, adherence, compliance, risk of diversion is minimized, and also there is no need for patients to motivate themselves every day take the pill, take the treatment. And this is what some experts have argued for. Some activists from the drug-using community have also voiced this, that basically when you say long-acting preparation, it's really the wolf of your traditional drug control, which is dressed in the sheep's clothing of medicine. What you are trying to do is, again, displaying your mistrust of patients, your need to control your patients somehow. कैसे नहीं लेगा दवाई? एक बार तेरे अंदर डाल देंगे इंजेक्शन, एक महीने तक अब तेरे अंदर पड़ी रहेगी ये दवाई, right? That's what the idea is behind these kinds of treatment. And some of these ideas we can see the echo of these in terms of our antipsychotic long-acting preparation system. Patient is reluctant to take daily daily antipsychotics, inject them once, and then see the magic of the medicine working. These are the common features of addiction treatment programs, and what they argue is that long-acting preparations are just an extension of the similar philosophy. And the one example of this is in the USA, the government and in the pharma industry are directly collaborating on this. In fact, in more than 43 of the US states, the prison programs offer Vivitrol as the treatment and not the agonist maintenance treatment in the jails, in the criminal justice system, officially. In fact, the manufacturer has a website, providing all these details here. So people have said that the sustained release naltrexone is a form of carceral prescription, where the user is not locked, but her receptors are blocked. So in a way, it's a prison on your receptors. Prison, not your whole body is not being kept in the prison, because this is the single most treatment option offered by the criminal justice system there. With long-acting buprenorphine also, there is some criticism that many of these treatment programs do not involve patients adequately in the decision making, and their own subjective accounts of the drugs effects, craving control, etc. are not taken seriously. And there is some research work on this as well, where actually patients' feedback, patients' account of being on these treatments, they have been taken, studied, documented, and analyzed. And in this context, I am just reaching the end. In this context, I came across a very interesting piece by our own Dr. Shubho Chakravarti from PGI. Basically, the very advanced long-acting preparations can actually be used as coercive intervention, which are then packaged and marketed as technological advancements. We know that compliance, adherence, they are the buzzwords in mental health and particularly in addiction treatment. But they do not adequately address the issue of patients' autonomy and choice. ethical treatment system must include accurate information to the patient of advantages, disadvantages, availability all possible options, and access to option of opting out. Now, opting out itself is a costly and difficult phase in case of implants, in of depot injections. If I am on oral tablets, I can month and day decide not to take the medicine. But if something has been inserted in my body, I do not want it, then I need to get it removed, which can be cumbersome and painful procedure for me. So hence, it has been said that besides compliance and adherence, we should also think about what is known as concordance. And Dr. Shubha Chakravarti actually defines concordance as an open discussion with the patients regarding their medicine taking, what are the advantages, disadvantages, etc. So, and in the concordance approach, the patient's view need to be respected, even if patients are choices which are in conflict with the clinician's choice. If we say taking this medicine is good for you, patient says no, I don't, then somehow a middle way need to be found out, rather than doctor forcing their choice on the patients and injecting them with this choice, which the effect of which would last for a long term. So to conclude, we know treatment of opioid dependence is challenging, but what we also need to remember is technological advancements in treatment do not necessarily represent any improvement. New is not necessarily always better. More resource-intensive treatment options cannot be a substitute for challenges which are related to restrictive policies. If there are policy environment which is restrictive for treatment, that should not be the excuse for pushing a non-inferior type of treatment. We need to ensure that what constitutes optimum treatment must be decided by patients and their doctors, and not by your policy system or criminal justice system or in any way influenced by your pharmaceutical industry. Thank you very much, ladies and gentlemen. I invite you to join APSI as well as the annual conference of APSI Edicon 2024 in Srinagar, Jammu and Kashmir this year, 3rd to 5th October. Thank you for your patient listening. I'll be happy to answer questions.
Thank you, Atul. That was fabulous. That was fabulous. So intricate and so well covered. Thank you so much. First, let's see if there are clarifications about what you have said so eloquently, and if there are comments from our senior colleagues about the content of what you have said. And then the second part, maybe we'll open it out for discussion amongst the colleagues here. First, clarifications from postgraduates for Dr. Atul Ambedkar. Okay, that was so lucid, I guess, Atul. So can we move to, are there comments or observations from our colleagues or our younger colleagues about what Atul has said? Essentially, what he said is, as he summarized also so well, that it may be a good promising direction, but there are a huge lot of medical, biomedical, and psychosocial and ethical human rights issues. I want to add to that. What about the Mental Health Care Act provisions of capacity, AD and NR about depot preparations? Atul, you or any one of us here. And I have an answer to that, possible answer to that. But Dr. Atul and anyone here, please, a lot of experienced colleagues here. How does depot or implant or LAI treatment for opioid or any substance use disorder sync or not sync with the MHA provisions? Rajshekar, any thoughts? Michael?
No, sir, I think if the concept of actually representatives, everything we really take in spirit, and I think if they are willing, then we should be giving it.
No, but what about the capacity being restored or not restored? See, the UNCRPD MHA also provides that if the capacity changes, then the decision can change. Now, how do you do that with these preparations? As Atul was saying what he was saying.
We cannot remove it
Hello, sir.
at that point of time.
Correct, Atul Dos?
Yeah, absolutely, sir, absolutely. And then that's one of my important ethical concerns about these forms of treatment. What if a family sort of brings a person under pressure and forces a person to take the long-acting naltrexone preparation in the doctor's clinic? doctor obviously will have a sort of commercial advantage of putting that injection in the patient's body, even if the patient is not willing.
Or as you
the
said,
risk of the yes.
Sorry, go on.
So the risk of, number one, there is the obvious ethical risk of human rights violation here, but there is a biomedical clinical risk also of overdose, because patient will lose tolerance, and once they relapse, they will experience high dose of opioids and have respiration type of this.
Yes, and like you said very well, besides the commercial advantage for the doctor, also the unconscious issue of control.
Yeah.
You know,
yes,
and we will control your life, family, and to that extent you have said it, CRPD is correct. If the family and doctors get in collusion about controlling person's life, then this is a good instrument for that misuse, as you said so well. But I have two possible reflections on that. One is a possible solution. Our colleagues here and those you. One, I'm not holding a brief for those agonist LAIs being dispensed in prison settings in the US that you described. But I can be a little more open to it, because if the society decides that there is a whole lot of, as US does have, whole lot of access to personality disorder, criminal activities, drug user, that as a policy with due attention to ethics, if you introduce. So there can be some merit for the American situation. Second, I want you and others to respond to that. Few countries have a very good provision of compulsory treatment order by the court of law. Community-based compulsory treatment order. So all of what we are saying here, you and I and Rashekar and others, one possible way out is a due clinical and legal process for long-term community-based compulsory treatment order, including LAIs.
Yes.
What would you say, or anyone else here, please? Because to me it makes a lot of sense, especially for dual diagnosis. And actually, if I might say, you restricted yourself to opioid and excellent details about that. But one major clinical and public health issue that we are not looking at is long-term management of dual diagnosis.
Yeah.
Cannabis with schizophrenia, bipolar with alcoholism.
Yes.
And there, even the atypical LAIs, antipsychotic LAIs may be useful.
Right.
For dual diagnosis.
Okay, agree.
CTO, I'm very fond of CTO. If at least in India we should try CTOs.
So basically, in cases where patient's capacity is really impaired, adjust to be impaired, there can certainly be a place for these type of treatments in the larger benefit of patient as well as the community and the society. That I agree with, and for dual disorders, poor insight patients, I totally agree with this. Was simply for patients with just poor compliance for their addiction, poor inadequate control of their craving, and then we seek to lock or block their receptors forcibly by long-acting preparations is something ethical dilemma. And once they are introduced in our country, I'm sure the industry is going to push it down our throats.
That's also true, yeah. But my concern, if I might say to you and all the others here, is also for a step further. We rarely talk about the rights of, especially after UNCRPD and MHA, rights of the family-based carers and those nameless, faceless victims. Untreated schizophrenia, untreated dual diagnosis, with a dagger, with a pistol, killing people at the street corner.
Absolutely.
I mean, the rights of those potential nameless, faceless victims also matter.
Definitely.
And CTO, I find, I want to throw it out because there are a lot of senior colleagues here. Compulsory community-based treatment order is an idea that might work well. System करना पड़ेगा. That's good. Okay, that's much part from me. Any other thought from any one of us here? Any contributions? Yes, sir, please. Dr. Ashok Reddy.
This is in relation to the subcutaneous implantation of naltrexone. All psychiatrists are bachelors of surgery. So what is the practice now either implantation done by psychiatrist or surgeon? What is the practice guidelines? What is the legal position?
Atul sir, you first.
Yeah, so as I said, my presentation was not really going into the details of clinical practice guidelines here, but even in those settings where it is practiced, there is no bar on psychiatrists putting these implants or injections. So this can very well be done by trained professionals. Importance given for training, and there is no really a legal sort of limit on whether or not you can put these implants. So I'm not sure that, I'm sure that's not going to be the limiting factor for us anyway, right? Those who want to practice it, they will find a way to put the implants in patients' bodies.
There is no limitation as of now until our friend in Pune finds a clause to be added to the MHA.
Sir, I'm saying even if that clause is added, those of us with ingenuity, those of us with enterprise, will find a way around.
I agree. I don't know how many of us here are aware, or Atul, if you, there are colleagues in Bombay and Delhi at least that I know who have been doing diaphragm implants for years.
Yeah, yes.
You know, psychiatry colleagues. But yes. I want to go out on a limb and say something else there, Atul. Again, you and I don't get too much of a chance to interact, so these platforms are good, and all with other colleagues. I think diaphragm is anyway a drug to be out by now, individually. So, no, at least I want to say this, diaphragm implant should not even be a consideration by now in genuine ethically correct practice.
I totally agree with you, sir. I'm not totally discounting diaphragm as an oral medicine, but diaphragm implants, I have very serious reservations against it.
Dr. Atul, just one query. There were a lot of things going on about the vaccines in relation to use of drugs. Any update on that?
Yeah. So some work has been conducted on two issues. One is nicotine, and second is cocaine, to develop some kind of effects, which will, particularly in cocaine, some in vitro progress has been made of molecules which can bind with cocaine molecules, preventing it from attaching to the receptors. But its clinical translation still appears to be far ahead in the future.
One follow-up to that, Atul, with you and others. The two drugs for which we use substitution agonist successfully is opioids and nicotine, right?
Yes, sir.
These are two substances where the agonist approach is by now well accepted.
Yes, sir. Yes.
And you covered so well about the long-term preparations for opioid. Any ideas on long-term preparation for nicotine NRT?
No, sir. Basically, people have the patch comes closest.
I know.
The nicotine patch comes closest to that description.
It should be, no?
But more than that, yes, sir.
I know why the industry is not doing that, because then it might be another mischievous idea. This is purely mischievous. Any long LAI depot idea on alcohol agonist substitution?
Sir, the group of Professor David Nutt, known as Drug Science, they are actually actively working in UK on developing an alternative to alcohol. So they are actually preparing a beverage, herbal and chemical mixed beverage, which approximates some psychoactive effects of alcohol, though it is purportedly, it doesn't cause as much toxicity. So we need to wait and see what happens there. But all the fun will be gone. Half the fun of alcohol is about the glamour and the paraphernalia associated with it. So it's the fun of alcohol is about enjoying it in company of friends in nice glasses.
And I kept looking for you last night here at dinner for that, but you were not here.
Next time.
You decided to come on time, right? I think we'll end there. The time is also nearing done. But one thing Dr. Abdul pointed out, I would reiterate, because that's really very close to my heart, mind, soul, everything. Most of research in this area and many other areas is not independent. pharma industry supported research is something that we really need to look at very differently, and you will not possibly have in current times very independent, objective research, non-pharma supported. So as clinicians or as public health policy, we need to be really very careful about accepting any of these data very readily. Can I, Atul, on behalf of all of us, give you a big round of applause, big thank you. And always nice, always nice. Thanks. Sir?
Thank you, Dr. Atul Ambekar, sir, for delivering the session despite your busy schedule and commitments. Your session has also enlightened our PGs to think beyond regular drugs. So, to felicitate the speakers and speaker and the chairpersons, I invite Dr. Ashok Alim Chandani, sir, President.
You can give me Atul's staff, I'll give it to him in Delhi.
Sure, sir. Dr. Ashok Alim Chandani, sir, President of IPS Telangana State Branch, onto the desk, sir. And Dr. Narayan Rao, sir, Vice President of IPS Telangana State Branch, and Dr. Vishal Akula, sir, onto the stage.
I know.
Dr. Atul Ambekar, sir, the felicitation memento and other felicitation material. Dr. Ambekar, sir, the memento and the other felicitation material will be sent to you, sir, shortly. Please kindly accept them, sir. Thank you, sir. So, unfortunately, we are lagging behind the time. We are not having any tea break, so the tea will be served here in the hall itself. So, with the same enthusiasm, we shall continue to the next session. The topic is substance use among pregnancy, a community perspective study by NIMHANS and UNICEF in Telangana. Speakers are Dr. Sundarnath Ganjekar and Additional Professor, Department of Psychiatry, NIMHANS Bengaluru, and Dr. Khyati Tiwari, Nutrition Specialist, UNICEF Office for Andhra Pradesh, Telangana and Karnataka. So I invite chairpersons, Dr. P. Lokesh, Dr. Rajshekhar Baipeta, sir, Professor of Psychiatry, IMH Usmania Medical College, Hyderabad, and Deputy Superintendent, Institute of Mental Health, Hyderabad, Editor-in-Chief of Indian Journal of Psychological Medicine. And I invite the other chairperson, Dr. P. Lokeshwar Reddy, sir, Professor of Psychiatry, Andhra Medical College, Visakhapatnam, and currently the Honorable General Secretary of IPS South Zonal Branch, who has done his MBBS from Kurnool Medical College in Andhra Pradesh and MD from Usmania Medical College, Hyderabad. And Dr. P. Lokeshwar Reddy, sir, has held the following posts in the past: the Honorary Editor of IPS AP State Branch in 2015 to 17, and Honorary General Secretary of IPS AP State Branch 2019 to 2021, and he was elected EC member of IPS AP State Branch. On to the chairperson, sir.
Respected seniors and dear friends, only when I was asked to chair this session did I know that this project actually happened in Telangana. So it's a very good initiative actually, where NIMHANS has taken this study.
We invite Dr. Khyati Tiwari also onto the stage. Dr. Khyati.
We know that pregnancy and lactation are very important aspects of human life, especially women. And it is really pertinent to see this particular aspect about the prevalence and other aspects of substance use in this particular vulnerable population. So I don't want to talk much. I want to listen to the speaker, and I request Dr. Lokesh to introduce the speaker.
Good morning, everyone. At the outset, I thank the organizers for giving me this opportunity. It's my privilege to introduce the speaker for today, Dr. Sundarnath Gajekar, who is currently the Assistant Professor of Psychiatry at prestigious Institute Nizamabad, Bangalore, whose areas of interest are women's mental health, perinatal psychiatry, and consultation license psychiatry and neuropsychiatry. I don't think we have any other better speaker to talk on substance abuse, especially during pregnancy. So over to you, sir. Thank you.
Thank you so much, organizing committee for inviting me to talk on. I want to say regret Dr. Jyati Tiwari could not come. So instead of her, I am doing both the part of the presentation. So hence there will be two presentations. One is the substance use disorders in during perinatal period, that is pregnancy as well as during lactation. And this is, we felt that this is a kind of a forum where we can introduce some work what we are doing around the perinatal period in Telangana, especially screening for mental health disorders. Right now it does not include substance use, but it includes common mental disorders like anxiety and depression during pregnancy, which has very high prevalence. Okay, so now coming to the substance use disorders during pregnancy and lactation. So what I am going to cover is the current prevalence of various substance use disorders during pregnancy, what impact the substance use can cause pregnancy, for example, its effects on pregnancy, its effects on the neonates, and long-term effects on the child. Then subsequently I am going to cover the management of substance use disorders during pregnancy, screening for substance use, what are the general principles of management of substance use disorders during pregnancy, breastfeeding, and finally I would like to briefly brush upon the well-studied the substance use disorders, that is fetal alcohol spectrum disorders. Okay, let's start what information we have regarding the use of various substances during pregnancy. Let me admit that the data what we have is predominantly from survey conducted from high-income countries, Canada, Korea, UK, US. So if we look at substance use disorders during among the pregnant women is around 9.3 alcohol use, 4.6% of binge drinking of alcohol, and around 0.8% of heavy drinking. The highest prevalence is in nicotine use disorders, which is almost like 15.4%. Cannabis use around 10.1%, opioid use around 1.7%, cocaine is around 1%. So there is one a kind of a report which was published by WHO on women and alcohol use in India, and what they found was it is in the general population the use of alcohol is around 5.8% in the general population, and there are a lot of variations. If we look at the literatures, say the use of alcohol among women is higher in northeastern states compared to say some of the states where alcohol use is higher, like say for example Kerala. So there the use of alcohol is more in men than in women, but in northeastern states the use of alcohol is also very high in among the women. So these are all some of the important findings. Particularly, in terms of pregnancy, these whatever the percentage data what I have put is predominantly from the data from the countries which I have mentioned just before. So what impact can substance use or substance use disorders can cause during pregnancy. See, there is a bottom line. See, any exposure during pregnancy can result in harm, and substance use, even in the absence of addiction, is a matter of concern. So, the impact can be it can be medical, it can be obstetrics, it can be on the neonate or the child, on the fetus, and even the psychosocial factors also. There is an impact on the psychosocial factors. So, when I said substance use during pregnancy can have medical, obstetric, fetal, neonatal or psychosocial impact, can I be certain that substance use is the etiology for these kind of impact? There are a lot of paucity in the in the information. And there are a lot of confounding factors also. Say, for example, the substance use commonly seen in in the women who are in the poverty, and there is a kind of poor nutrition in them. Whether the nutrition has an impact or the substance use has an impact, we don't have an exact idea. And many a times it is a polysubstance use, not a single. To demarcate, okay, the alcohol has caused, say, impact like preterm birth. No, we cannot certainly say that. And apart from that, there are comorbidities, medical comorbidities, say, or the substance use among women is commonly associated with comorbid psychiatric conditions. Say, for example, anxiety, depression, and these women also seeking the healthcare is also limited because of the stigma associated. They do not communicate that they use substance to the clinicians or the obstetricians or the frontline workers like ASHA and AM. So, just to give a kind of what review articles, predominantly published review articles says what impact can each substance has. Say, for example, alcohol use during pregnancy can lead to small for gestational age, low birth weight, congenital malformations, pre-eclampsia, gestational diabetic mellitus. In neonates, a well-studied information is fetal alcohol spectrum disorders. In the long term, when these children grow older, they can have intellectual disability, learning disorder, ADHD, poor academic performances. In terms of tobacco use, there are a lot of review articles which mentions that it can cause, apart from that, what mentioned in the, say, alcohol use, the preterm premature rupture of membrane, then placenta previa, abruptio placentae, preterm birth, congenital malformation, preeclampsia, and gestational diabetes. In neonates, it can cause irritability, insomnia, hypertonicity. In long-term consequences, sudden infant death syndrome has been noted among women who uses nicotine. Apart from, say, ADHD, short stature, atonia, poor academic performance. Cannabis, few of the previous authors also mentioned, they were talking about cannabis use. Cannabis use during pregnancy can cause small for gestational age babies, low birth weight, preterm delivery. In the neonate, there is an increased risk of death during the first year of their life. And in terms of long term, they have poor neurocognitive outcomes. Opioid use, again, the opioid use during pregnancy can lead to abruptio placenta, preeclampsia, preterm premature rupture of membrane, preterm birth, low birth weight, septic thrombophlebitis, especially when women use IV opioids. In neonates, there is a NOS, that is neonatal opioid withdrawal syndrome, that has a lot of the symptom clusters from irritability, atonia, up to the seizures, depending on how much dose the mother uses during her pregnancy. In terms of long-term neurocognitive impairments has been noted. The stimulant use or cocaine, again, during pregnancy, use can lead to abruptio placenta, preterm premature rupture of membrane, preterm births, small for gestational age babies, low birth weight, neonate, irritable, difficult to quit, feeding difficulties, and long-term neurocognitive impairments. I must also admit that even though there are short-term adverse consequences has been noted, but there are certain long-term studies which has been conducted, which is two studies which I come across is maternal lifestyle study, a prospective longitudinal study of infants with prenatal exposure to cocaine and other substances. When they looked at, there was a kind of a control group, in this study. They compared with the mothers who were not taking the substances, and what they found was there are not, major statistical difference in terms of, say, their cognitive development. They looked at around 7.5 years of age. And similarly, the ideal study, which is an infant development environmental lifestyle study, which is a longitudinal control cohort study on effect of prenatal methamphetamine exposure on neonatal outcome at birth and over time, where they also found that in terms of the neurocognitive, not much difference. There can be a lot of confounding factors as well. Maybe when you look at these women, they might have had regular contact with the clinicians, so that somewhere they as a ethically we need to intervene also. So there is a conflicting result. Okay. Now coming to the most important part, which is the management of substance use disorder in pregnancy. So here, say in psychiatry we have experience, say as soon as women come to know that she is pregnant, she tend to stop most of the medications which she is taking for her psychiatric disorders, either antidepressants or mood stabilizer. So similarly, even in substance use disorders, there are chances that they can spontaneously stop using the substances. Around 87% of women who drank alcohol before pregnancy, they stop drinking during pregnancy as soon as they come to know that they are pregnant. And a small percentage, around 6.6%, is they have reduced the alcohol use, and another small percentage of 6 point, they have not done any reduction in their usage. In terms of, say, smoking, so around 35 to 75% of pregnant women completely stop smoking by the end of the pregnancy, and most women who are able to quit smoking by themselves during pregnancy, say they do it prior to their first visit to the antenatal care. So a kind of, as soon as they learn that they are pregnant, this kind of they stop substances in some others. Okay. So, but having said that, some women can continue to take. So the screening is important for most of the mothers, say in an area where the substance use disorders are much more prevalent in reproductive women. So they tend to underreport that to their healthcare workers or to the clinician because of the associated stigma or maybe fear of legal consequences, especially in substances like cannabis, cocaine, and see, in such cases probably what best help is to use screening questions and even use urine toxicology has been shown to be effective. But having said that, many a times the women can be manipulative also. Say she may refuse to give urine for toxicology screening, and she may take a lot of kind of water to prior to the testing, so that the rate of detection is low, and or she may use some other person's urine. That kind of has been documented, especially for the women who use substances. Okay. Now, certain we all know that these are all commonly used screening tools. Say the PAs, that is tolerance, annoyance cut down, eye opener, tweak, that is tolerance worry, eye opener, amnesia cut down, audit, that is alcohol use disorder identification test, audit C, which we use commonly for hazardous drinkers or those who actively use. Then assist, that is alcohol, smoking and substance involvement screening test. So the 4 P's which are most important while screening is that, not only we need to the current use, but also to the past use, as well as the partner's use. Some of the use of substances in the partner can be kind of a maintaining factor for her or in her peer group or in the parents. So all all these 4 P's needs to be kept in mind while doing the screening. So once the clinicians are aware that there is a substance use in pregnant women, there must be a thorough evaluation for substance use, as I said, in their male partner, and we need to take the pregnancy related considerations. Apart from that, as we know that the substance use also comes with some kind of abuse. It can be emotional abuse, physical abuse, sexual abuse. It may be a kind of her own way of stress management using substances. She may be suffering from psychiatric conditions like anxiety, depression, or any other major psychiatric conditions. There can be physical comorbidities like hypothyroidism or diabetes. There can be psychosocial factors like poverty, lack of healthcare availability, and so we also need to evaluate for what is the mother's perception towards the pregnancy, as well as whether she is able to feel for her baby, that is maternal fetal bonding, or if she is a postpartum maternal mother and child bonding. So those things also needs to be evaluated in women who uses substance during pregnancy as well as during the lactation. There are certain general principles which we need to follow while treating substance use disorders during pregnancy. It should be individualized, and in cases like opioids, so the treatment management can get complicated. So a specialist in the addiction treatment should be we must be made available to encourage and engage in the prenatal care. Okay, so and even after the delivery, there must be kind of a support to children who are born with pregnant women who uses the substances for in terms of their assessment for early postnatal complications and assessment and treatment of long-term complications. Okay, so coming to pharmacotherapy, usually if there is a substance use during pregnancy, generally recommended that these women are receive inpatient care. The thiamine and the folic acid supplementation should be provided, depending on the scales which you have used for so alcohol withdrawal, the CIVA, that is clinical institute withdrawal assessment. This scale, especially the alcohol revised, has certain items like agitation, anxiety, auditory disturbances, clouding of sensorium, headache, nausea or vomiting, paroxysmal sweat, tactile disturbances, tremor, visual disturbances. So depending on how much symptoms, we need to treat the acute, that is the detoxification, using the commonly used drugs are the diazepam or chlordiazepoxide in the first trimester. So you may argue that why can't the lorazepam? So the exposure to a kind of lorazepam, there is a study that it has shown that the first trimester exposure leads to anal atresia. So, but diazepam and chlordiazepam oxide that has not been much associated with congenital anomalies. Oxazepam in the third trimester. There are even, though clonazepam can be used in the third trimester. Okay. Now in terms of pharmacotherapy, so disulfiram. The disulfiram, they say that best to avoid because of disulfiram ethanol reaction. So not to use the disulfiram during pregnancy. Acamprostate, naltrexone and gabapentin, they may be considered. But say if we look at opioid disorders, so they do not prefer naltrexone. So it is there in my, because there are better options which are available. So most of these drugs comes under the category C, which means that there are animal studies with adverse effects. However, there are no controlled human studies. Given that safety and efficacy of medication for treatment of alcohol dependence has not been established in pregnancy, and it's a kind of an individual risk-benefit analysis the clinicians needs to make, and that needs to be communicated with the pregnant women. So, that's why I said in the general principle is that it should be individualized treatment. We cannot have a kind of a blanket treatment for pregnant women. So, in terms of say tobacco use, in terms of pharmacotherapy, nicotine replacement therapy, even though it is in the category D, appears to be safe and maybe efficacious in increasing the quit rate in the later part of the pregnancy. Bupropion, which has moved from C to B, appears to be safe, and even though there are not much evidences on the efficacy, although small studies have shown positive result. Varenicline, that it has not been studied well in the during pregnancy. So the bottom line is nicotine replacement and bupropion treatment may be considered during pregnancy after again the individual risk benefit analysis. So opioid use disorders in terms of pharmacotherapy, naltrexone they do not prefer because of the say when women are they are taking opioids. Initially we might need to do the the detoxification that itself need to use lot of other medications, and if we use very early, it itself can precipitate the a kind of withdrawal. So they don't prefer naltrexone. Rather than that, buprenorphine or and methadone are much more preferred. So they say that buprenorphine and naloxone best to be avoided. It's kind of a conflicting kind of results are there. So hence, pregnant women with opioid dependence should be advised to continue or commence opioid maintenance therapy with either methadone or buprenorphine. The other important intervention which works very well is the brief interventions, which you all Dr. Shailesh has spoken about it, and some kind of Cochrane review also suggests that there is a kind of a small effect in kind of reducing the hazardous or harmful use of alcohol during pregnancy. Motivation enhancement therapy that also Dr. Shailesh spoke about. These two kind of interventions, the pregnant woman must receive, say if there is substance use disorders in them. So I'm not going into this slide because already Dr. Shailesh has covered this slide. But what is important here is to psychoeducate on pregnancy, nutrition and substance use. How the substance use can have impact on immediate impact, the short-term impact and the long-term impact on her child. That information needs to be given to the mother, and she needs to be encouraged to stop the substances here, or if it is not, then harm reduction is the is the choice. Okay. Now coming to the substance use and the breastfeeding. So many a times, many mothers, they do not breastfeed their their babies because they are using substances, but maternal substance use is not an absolute contraindication for breastfeeding. Okay, so in terms of alcohol use during lactation, it is associated with altered milk taste and smell, and there is a kind of a reduced amount of milk production among mothers who uses alcohol, and it can affect infant sleep pattern. The amount of milk consumed during the breastfeeding session, and it can have an impact on the early psychomotor development. Abstinence is recommended, if possible, but however, if she continue to use alcohol, then the amount should not cross more than 2 units, and she should wait 2 hours after drinking to resume to the breastfeeding. But as far as possible, encourage mothers to abstain from alcohol during the breastfeeding period. In terms of tobacco use and lactation, again the tobacco use is associated with decreased milk production and lower milk fat concentration, and because of there is a decreased milk production, the lactation duration can be shorter in these mothers. Infants of mothers with breastfeeding after smoking slept less compared to those who are abstinent from the smoking. So, and there are the reports of, as I presented there, the sudden infant death syndromes has been noted within first year of their life when the mothers uses the smoking. Mothers, the bottom line is mothers who smoke may breastfeed, but ideally it should should try to be on smoking cessation aid, as I showed in the nicotine replacement therapy or bupropion. Okay. Coming to cannabis use and lactation, the active component tetrahydrocannabinol, it is it gets concentrated in the breast milk up to 8 times, and say it can have kind of the low to moderate doses can have impact on the brain development, leading to say potentially long-lasting effects on the cognition, emotion, as well as on the behavior. And the cannabis use is also a kind of a risk for sudden infant death syndrome, especially in the first year of life. Better to reduce or eliminate their use and avoid exposing the infant to the cannabis through breastfeeding. Coming to opioid use, they recommend that if mother is on say opioid replacement therapy during pregnancy, that needs to be continued throughout the postpartum period, and the breastfeeding needs to be continued so that there are minimal neonatal opioid withdrawal syndrome. Okay, neonatal plasma concentration of methadone is not related to the maternal methadone dose, and buprenorphine poor availability when taken orally means unlikely that it has a significant absorption will occur from the intake of breast milk. So bottom line is to encourage the mothers to continue breastfeeding and continue the substitution treatment. So a few lines, we all aware of this, the conditions in neonates and child exposed to substance in utero, that is neonatal abstinence syndrome. So they may develop certain withdrawal symptoms, especially which is more common in the opioids, but even in nicotine, the alcohol, if mothers continue to take alcohol during pregnancy, the neonatal abstinence syndrome can be observed. So it depends on the amount of how much amount of substance the mother uses, the duration, and the maternal, renal, and hepatic function, and whether in terms of the delivery has happened in the full term or the preterm. Depending on that, the symptoms may vary from, say, simple irritability, agitation, then hypertonia, difficulty in feeding, or difficult to soothe the child, and to the seizures. So it is important to liaise with the neonatologist to the same. So coming to the fetal alcohol syndrome, we all much aware of this condition, which is seen around up to 5% of the say women who take substances. So apart from that, the fetal alcohol spectrum disorders are associated with some of the conditions, like highest condition is attention deficit hyperactivity disorder, then subsequently the intellectual disability, learning disorders, ODD, depression, and psychotic disorders. So to conclude my substance use disorder during the perinatal period, that is pregnancy and postpartum, it's a very complex, and the information, we don't have lot of research-based information, and it's a multifaceted issue. So the early identification and early intervention is always good. So interventions must address the substance use, but also we need to take into consideration the medical history, obstetric, and comorbid other psychiatric conditions, as well as the social aspects. The interventions which we begin during the pregnancy should continue during the postpartum period, and also should encompass the screening of the children for for say anomalies, the comorbid learning disorders, or other conditions which I have said in the last slide. Shall I continue? Okay, so this is a kind of programmatic study. I would like to say it is a kind of a program which we are conducting in the state of Telangana. So, which is the integration of mental health screening and intervention during perinatal period as a part of maternal and child health program. So, maybe if you go back and especially for PGs, if you go back and read about antenatal depression or antenatal anxiety, postpartum depression, the prevalence is very, very high. So in 2017, there is a Ravi Prakash Upadhyay has published an article, review article, and the prevalence is almost like 22.1%. Like almost like 1 in 5 postpartum mother can have depressive disorders, and so another untapped area is say antenatal anxiety and antenatal depression. So so this journey started in just before the COVID, almost in 2019, where UNICEF has taken a kind of a program where they were focusing on the maternal nutrition. In spite of so much of intervention on nutrition, maternal there was not much improvement in the anemia. There was a program called Anemia Mukt Bharat. So in spite of supplementation, the mother's nutritional state was not improving. So they try to look at what is that, which we are, what is the barrier. So they found that the mental health of the mother was not looked at, and that was a kind of a barrier for even as simple as maternal nutrition. They have published an article. Women eats last and the least. So in a family situation, she eats the last and the least. So that's where they started whether we need to have kind of an intervention to the depression part also. So initially they associated with us. Initially we worked in the Chhattisgarh. So NIMHANS has certain role in terms of say giving a kind of a scientific basis for the programmatic study, some kind of digital solution, as well as the training of frontline workers on mental health assessment and screening. So, we approached to a different ministry in the Chhattisgarh, but it did not take off. So then the Telangana came into the picture. So Telangana, say Ministry of Health and Family Welfare, especially the maternal division of maternal health division of Health and Family Welfare, they took this initiative and they started incorporating. So because of that, we developed certain IC material on say mental health assessment. What is the importance of mental health during pregnancy, and how she can improve her mental health during pregnancy. What are how to identify? Women herself can identify different emotional conditions. So those are it started with so all the IC material started developing, and it was launched in 16th July 2022 in one of the hotels in Hyderabad. So UNICEF was kind of supporting that. So slowly we also developed a kind of say the training materials for the medical officers, say in terms of say importance, then clinical evaluation for parental mental health, then what intervention, psychological intervention, how can they do, and then including the medications. Then we kind of developed a protocol for say ANMs and ASHAs, so what they should ask, and if mother says yes, then what is the next step, so what intervention she can do, what intervention, say if she's not able to do, so she can bring it to the attention of the medical officers. So if it comes to the medical officers, so what they should be doing. So and then if it is difficult for them to say treat, then how can they involve the psychiatrist in the loop? And that's where we brought the DMHP into the loop. So these are all some of the glimpses of say hands-on training which was done by Dr. Naveen Singhagari and Ravina Kirimi. They are there here. Then subsequently Naveen joined IMH. So we took Nitin into this program. Then he went to different districts in the Telangana. So sorry, this is the slightly older image where. So these 4 districts were not done, but I think now they have covered that also. So in terms of training wise, so most of the medical officers, around 700 medical officers, including obstetrician underwent training between July 23 to January 24. We also conducted training for supervisors, ANMs, ASHAs. So almost like 180 hours of total training was conducted. So the other important initiative was including the screening questions in, so it is called MCP card, Maternal Child Protection Card. Here it is called as KCR kit. So that in terms of her visit, how many visits she has, each time the assessment can be done. And if she has any anxiety or depressive issues, simple square breathing techniques she can adopt. So that has been and as a part of this initiative, the commissioner has say he kind of made the DMHP psychiatrist available or TVVP psychiatrist available on the day of ANC care. And so some of the screening which has happened in the district, the numbers are very less, even though there's has a portal on the MCH kit, has questions for ANMs to fill. The same which is there in the say KCR kit is also reflected in the e-hospital management system. Then if she flags some cases, it gets reflected to the medical officer. Then he needs to do his screening in terms of say so even though we said it's a PH2, it's like a clinical interview he or the medical officers needs to conduct, and then say if there is no depression, the medical officer can declare no depression, or whether if there is a mild, moderate, then he can put his what advice he gave, whether he has done a brief intervention in terms of psychological intervention, or whether that mother required kind of medication. That can be entered. And if he is unable, if mother continue to be symptomatic, then he can also refer this to a psychiatrist, where psychiatrist, the DMHP psychiatrist can decide whether she requires an outpatient-based treatment or an inpatient-based treatment. So this is, I thought that this is the best forum where we can say. So what work in Telangana is going on. So thank you so much. Any questions on substance use?
Thank you very much, sir. Thank you very much for the enlightening lecture. I think it's open for discussion. Any questions, clarifications, sir?
Substance abuse during breastfeeding, lactation. There is literature which says that the preference of the child for food substances or taste depends a lot on the food consumed during lactation by the mother if the child is breastfed. So in that context, if the mother is using substances and breastfeeding a child, there are chances, and it is hypothetical, I don't think there are any studies on that, chances that such children would develop a taste for that substance which the mother used during breastfeeding. In that context, don't you think it is advisable not to breastfeed at all?
Okay. See, the advantage of continuing breastfeeding. Okay. Say it is lot more. Say for example, even when mother are suffering from HIV, if she is HIV positive, that condition, that infection condition also, we the WHO recommends that the mother breastfeed the child.
Here we are talking about the substance being secreted into breast milk and fed to the child.
Yeah, no, I got your question, but the advantages of continuing breast milk to the to the infant is a lot more than that pathway. We don't know whether say it brings some of the changes in the in the receptor level or the brain development. So, but having said that, the advantage of breastfeeding is much more than not to breastfeed the child when even mother is using the substance.
Good morning. First of all, I want to congratulate Sundar Nag sir for giving an excellent presentation on the project which is going on in Telangana. So the main idea of keeping this presentation is everyone in Telangana, they should know what exactly the government is doing and what kind of work is going on. Because suddenly if a paper comes in a different journal that this study had happened, we may not be aware. So that was the idea, and we want to congratulate you, sir. Adding to Chandrasekhar sir's question, as you had worked in ground root level with your team, so what exactly you had faced with the rural clients when you had encouraged for breastfeed? Generally, whenever we say to breastfeed, we even with the antipsychotics also, they'll say, no sir, we cannot use it. They have their own challenges. So can you enlighten us how you had motivated the rural clients? If your team is present, who had talked with the rural clients or the rural people? So you were the trainer. So if your team is there, you can share that insights for us, sir.
So, in terms of say the
breast milk, particularly breast milk, buprenorphine, methadone, you said you can continue. So, how you had enlightened in the rural clients?
I don't have much experience in the Telangana, but I would rather say my experience in the mother baby unit where I work. So, in terms of say substance use, it's not like we commonly see substance use during pregnancy and postpartum, but there are cases which we handle with the addiction medicine team when such women come for the consultation. So say we actually encourage them. Say for example, say we have the daily infant monitoring chart. So where each of the symptoms of either the withdrawal or any other symptom we enlist, and when we tell them that say you can continue the breastfeeding, we give them kind of an individual feedback. What symptoms this baby has. So if usually we have not experienced any of kind of symptoms, and that feedback helps the mother to continue breastfeeding. So
one last question.
My question is to Dr. Sundar. My simple question is, if a lady who is pregnant in term and she comes in alcohol withdrawal, should we do the normal detox or do you suggest anything else? We do benzodiazepine detox. Do you suggest that, or do you have any new insights for us regarding this?
No, especially when she comes to the term or at the time of delivery. We need to keep many things in mind, say in terms of her medical history. So, but the treatment wise, there is not much change in terms of say benzodiazepine use. But having said that, we also need to keep the neonatal adaptation syndrome also in the mind. So better to have a kind of a clinical chart to check for any withdrawal in the say in the infant as well. So after the birth of the child, so that needs to be done.
So one last one, please.
Good morning, sir. I'm Dr. Rajshekar, Assistant Professor in Nizamabad, sir. This is not a question but more information, sir, regarding the cultural practices in this part of the state. Especially, as your presentation says, most of the pregnant women stop substances during pregnancy. But here, especially in this part of our state, once there is strong cultural belief that toddy is very good for the pregnant woman. So once a woman is known to be pregnant, she is encouraged to have toddy and even sometimes even forced to take toddy, which is heavily adulterated with benzodiazepine. So from here we are regularly seeing patients who are coming after they even denied during pregnancy. When we are during the screening, they deny any substance use, but once delivered after second or third day of delivery, they are presenting with seizures, and we are most commonly called for the obstetric ward. So this is regarding because you are talking about the program which is being done. This is very common problem, sir. Even we are doing a paper which is we are presenting. Most cases with postpartum depression and anxiety, they have very much linked to this use of this benzodiazepines during pregnancies. This is just for information.
No, this feedback was also given when we went for training the obstetricians. Because our training part did not cover the substance use. So, but obstetricians brought to our mind, sir, there is a lot of toddy use in the in some part of Telangana, and how do we manage that? So we have told them what needs to be done. So maybe as the program say goes on in the state of Telangana, maybe we can include that part also, the screening for substances during pregnancy and its management.
Like, what I really liked about your presentation was those 2 slides where you had told that probably during the first trimester we can possibly or probably prefer diazepam and chlordiazepam. That was a new learning. Now, also third trimester oxazepam. And this safety aspect of de-addiction treatments in lactation, that was very good. Thank you very much.
Not wasting much time, I will hand over the proceedings to the organizers. Thank you, sir. Thank you.
Thank you for the valuable session, sir. Now I invite Dr. Nagendra, sir, Senior Psychiatrist, and Dr. Rajshekhar, sir, Psychiatrist and Organizing Committee Member, Assistant Professor of Government Medical College, Nizamabad, to felicitate the speakers and chairpersons, sir. Please welcome, sir. Thank you, sir. Now we are moving to the next session. The topic is cannabis-based medications and synthetic cannabinoids, status and future directions. The speaker is Dr. M.S. Reddy, sir, Senior Consultant Psychiatrist from Asha Hospital, Hyderabad. And the chairperson is Dr. K.K. Mishra, sir. He is a professor and head of psychiatry from MGIMH, Sevagram. Previously experienced, he had 24 years service in armed forces in different academic and administrative capacity. And areas of interest are child and adolescent mental health, substance abuse, psychiatry education, stigma reduction, psychoimmunology, suicide prevention, etc. And he has more than 70 publications, 110 presentations in national and international conferences, 6 book chapters, 15 multicentric projects, awards, commendations by Flag Officer, Southern Command for Medico-Social Relief at Sri Lanka, which is post-tsunami, and Dr. G.C. Boral Award, Industrial Psychiatry, Dr. A.B. Datta Award, and Dr. Indla Ramasubba Reddy Award, IAPP, Dr. Sumalulla Oration, Dr. L.P. Shah Oration, and Marfatia Award. And he has many societal activities like immediate past treasurer of IPS. He is a treasurer and EC member of IPS, EC member of IASP, IAPP, and IAPP, IAGMH, and ISEAM, and he is a past treasurer of ISEAM. And coming to the next chairperson, I invite Dr. Anishakti Vishweshwar Rao, sir, MBS, MD, and DPM in Government Medical College, Guntur, and he is ex-senior resident in IMANS, and is a faculty of Chelmadanandra Institute of Medical Sciences, Karimnagar. He is ex-medical director of Singareni College, director of Vishwahita Neuropsychiatric Hospitals, Manchira, Telangana State, and he is also the founder of Arogya Vikas, a voluntary service organizations. On to the chairpersons.
Yeah, Ravi, thank you for the long and introduction. Thank you at the outset. I thank Vishal, Rajendra, and all the office bearers of Telangana Psychiatry Society and the organizing committee for giving me this opportunity. and I have been to Nizamabad, I think twice or thrice. So I always cherish the memories of Telangana, the spirit of Telangana Psychiatry and the Nizamabad. So I think Dr. M.S. Reddy does not require any introduction. I can take the opportunity to introduce, to just to speak about the subject for 1 minute or so taking from your permission and your time. So cannabis, if you talk about cannabis, it has long been used and abused in our community. Cannabis is considered one of the gateway drugs in the pattern of substance abuse. From the morning we are listening about the all varieties of substance from alcohol to opioids. And if you find out, I think when Dr. Sundar was speaking, and if you find out, you must have seen the trend. We are finding more and more number of cannabis abuse among females nowadays. At least we see 3 to 4 cases per month, cannabis abuse. And one aspect, a very important aspect of cannabis is legalization of cannabis in India, where a lot of debates are going on. In this context, the cannabis and the synthetic cannabis has already reached the Indian market for use for the several neurological conditions, in the malignancies. So in that context, and we would like to know what are the ethical issues, what are the legal issues on use of those substances. I think who can the better person than Professor Reddy to speak about this thing, who has got a lot of experience in this area, including his areas of choice of bipolar disorder. So I will request Dr. Rao if you want to have 1 or 2 words in the beginning.
Thank you all. No introduction regarding Dr. M.S. Reddy sir. He is a student-friendly professor. Since I know him last 25 years, my first experience with SAR is during 2005 in WPA, World Psychiatry Association. I was forward these things. SAR was helpful to me by the time. I don't know personally, but by telephonic conversation, he was given his reference and mail to the WPA. So, at the same time, his MS Reddy sir is a super male express in his subject, especially సార్ యొక్క ప్రసంగం కనుక మనం వింటే కనుక అరటిపండు వచ్చిపెట్టినట్టుగా మృదుమధురమైనటువంటి స్వరంతో మనకి ప్రసంగం ఉంటుంది. అందరం కూడా ఆస్వాదించాలని కోరుకుంటున్నాం. మన శ్రవణానందకరంగా ఉంటుంది. సార్ మాట్లాడుతుంటే ఇంకా మనం తెలుసుకోవాలనే కొత్త విషయాలు తెలుస్తుంటే, ముఖ్యంగా మన తెలంగాణ బోర్డర్ జిల్లాల్లో కెనాబిస్ ప్రాబ్లం చాలా ఉంది. మహారాష్ట్ర అండ్ తెలంగాణ బోర్డర్, అండ్ మహారాష్ట్ర, ఛత్తీస్గఢ్ అండ్ తెలంగాణ అండ్ కర్ణాటక, తెలంగాణ బోర్డర్స్లో ముఖ్యంగా ఈ ప్రాబ్లం ఎక్కువగా ఉంటుంది. సో దీని మీద మనకి సార్కి అవగాహన ఎక్కువ ఉంది కాబట్టి ఈ ప్రోగ్రామ్ మనకి చాలా ఉపయోగకరంగా భావిస్తున్నాను. సార్ ప్లీజ్ స్టార్ట్.
Thank you. Thank you so much. I think it's a very kind words and then really overwhelmed by what the chairpersons have talked about. And he remembered what happened almost 20 years back. I think my sincere thanks to that. It's so nice. I really thank the office bearers and organizing, especially Dr. Vishal, who called me and said that you have to come and speak on this topic. I don't know, like Nance, he was telling that I'm supposed to be talking well and then getting people addicted, and then the topic is cannabis here, and then I don't know whether there's some similarity between that. I'm fortunate that from morning I am sitting here. The very first lecture was alcohol addiction, that brief interventions, and then the second was something about the opioids where they talked about. Brief intervention was very good. I really liked the topic. The second topic when it came to opioid, maybe I think Atul almost I was sold out to opioid agonist maintenance. They forcefully talked about antagonist maintenance and maintenance. But now like the last topic was something about like a pregnancy and then different substance abuse. Maybe on the lighter side, with all due apologies to the lady delegates here, No, like what I learned from is that the best way to make a woman stop alcohol is making her pregnant. 85% of them stop alcohol the moment they become pregnant. That's a very, very positive news. I don't know about that. But one thing I was wondering was, the topic is cannabis-based medication. Can we ever talk about alcohol-based medication and the opioid medications? Is there something going to come up, or it's going to be only for the cannabis? Is something specific is there? And then abuse has been talked about. And before that, one point when somebody was talking about in the previous lecture was about the effect of alcohol on pregnancy. Generally, then no test will be done, no RCTs or anything will be conducted regarding the effect of a particular substance. But in Telangana, I think one of the delegates was saying that it's a regular practice. Whether you accept it or not, whether you talk to them or not, they take toddy. At least one naturalistic study, if it can be done, toddy free of benzodiazepine, for a period of time, we can get a huge data on the effect of, whatever the crude form of alcohol in pregnancy, we can have a data on that. With this brief introduction, now let me go to the topic. And also I thank Sai Krishna for getting me on the stage almost about 10-15 minutes before my time. I have a lot of time now. Cannabis-based medication, synthetic cannabinoids. I think there are a few interesting things which are going to come up here. When you talk about cannabis, how long it has been there? If you look at this picture, this is the first thing which comes to our mind when we talk about cannabis, at least in India. How long cannabis has been there in the society? I don't know whether I can say that. Maybe as long as sadhus existed in our society, there would have been cannabis. The first descriptions were 2800 BC. There are descriptions about cannabis being used, maybe abused, but more for the healthcare thing. So it's almost about 5,000 years when some of us believe that that is the period when there existed Vedas. When we talk about Vedas, we talk about 5,000 periods before that. From that time onwards, cannabis has been. And this is, I think, in a lot of South India may not be, I don't know about Telangana, but North India, this is a very common thing about bhang. I think some of the seniors would have seen the movie, Rajesh Khanna's movie, Jai Jai Shiva Shankar. I think it's a wonderful song. That's a song, the whole thing is about bhang, how it's being prepared. It's very clearly described in this. From this stage, if you are going through, cannabis, I think there are quite a bit of interesting points when you look at cannabis. Actually, I must thank Dr. Vishal. I didn't have much of an idea about this. I think it was a lot of learning experience when I was preparing for this topic. This is the plant, cannabis plant. These are natural products, cannabis derived phytocannabinoids we talk about. This is what we talk about, synthetic cannabinoids. Morning, as I told you, when Atul was talking about opioid addiction, I think he has almost sold out to opioid agonist maintenance. I don't know if later we can use this as a theoretical possibility in the so-called management of cannabis addiction, if at all there is. This is broadly the plant from which we get the cannabinoid products. This is about the cannabis plant, sativa, and then two well-known cannabidiol, and then tetrahydrocannabinol. Cannabis derived from the plant, naturally occurring, cannabidiol and then tetrahydrocannabidiol. This is mainly synthetic compounds which have come after this. Looking at the history broadly, I'll just some of the historical points. As I told you, the first record was 5,000 years back, and even 12,000 years back there was some record about cannabis. That was a period, and the first time, I'll show you in one of the latest slides, for the first time, THC, tetrahydrocannabinol, has been isolated from the plant in 1964. That's the first time we know that there is something like this compound. I believe this plant is a kind of a wonder plant. It's almost about 500 different kinds of cannabidiols that can be extracted, chemical compounds from this plant. See how it goes. I think there is something about like how much of studies and scientific data. 64, first time TH was isolated from the plant. First synthetic cannabinoid has come in 70s. Within 6 years, the pharmaceutical industry, there was a lot of talk about pharmaceutical industry. Within 6 years, the industry has jumped into that and made first synthetic cannabinoid. You know, when the first endogenous endocannabinoid has been identified? 1992. It's almost 3 decades later, the scientific community found out that something like this exists in the body. But within 6 years, pharmaceutical companies, whatever the companies, the business lobbyists got out the synthetic cannabinoid. I'm going to show the details later. 2016, WHO declared the most commonly cultivated, trafficked, abused illicit drugs. This is a huge number. My God, 147, 14 crores population all over the world seem to be using or abusing whatever it is. It's a huge number, quite a big number. Now, is marijuana and cannabis are the same? It's a terminology same. Cannabis, anything, everything which comes out of cannabis, whatever is cannabis, I believe almost over 450, 540 chemical substances from this plant. It seems to be like a chemical lab, almost like an industry. Cannabis, whatever plant seems to be a whole industry of like a chemistry. Marijuana is something which has got a significant amount of THC, only then you call it marijuana, otherwise it is cannabis. Imagine about 500 compounds from a single plant. This is something which is very, very less industrial, but the two main cannabinoids are tetrahydrocannabinol, cannabidiol. The next of the topic, the next 20 minutes, 30 minutes, is going to be predominantly on this, but I wanted to focus this. One single plant, cannabis sativa, which has been there for millennia. There are more than about 500 chemical compounds which can be extracted. This is broadly the classification. This is going to be very, very interesting. I don't know, I don't think anybody talked about alcohol, different types of alcohol, or opioids, maybe different types of alcohol. Here it is, something comes in the plant, phytocannabinoids. This is what we are making synthetic in our chemical lab, synthetic. There's something in between which is very, very interesting. Endocannabinoids. Our own body produces cannabinoids which are exactly similar, physiologically they are exactly similar to phytocannabinoids. This first extraction 1964, this came in 1970 within 6 years, but this came only in 1992. The mechanism of action is CB1 and CB2, cannabinoid receptor 1, cannabinoid receptor 2. To sum up, cannabinoids, tetrahydrocannabinol, the predominant mechanism of action is action on the receptors CB1 and CB2. This is the whole thing about. Here, this is something which our body produces. I don't think we have any control on that. It produces. It's like maybe you talk about a hormone or neurotransmitter, it produces. This is something we can extract from the plants. It has been going on, as I told them, millennia, not like decades. This has come into for the last half a century which has come. The whole problem is with this. Not with this, not with this. Now looking at, there's an interesting, nice paper in 2020 talking about endocannabinoids, endogenous lipids, anandamide, AEA, second thing is 2A, ethanolamide and glycerol. Endogenous lipids, physiological properties are very similar to natural ones. Synthetic we don't talk about now. Anandamide, it has been named as anandamide based on Sanskrit word ananda. So this particular product, what is endogenously secreted, it is supposed to give us some kind of anand. I'm not experiencing something. It may be an inbuilt thing which is going to come up. That's why it's been named as anandamide. Very interestingly, these are neuromodulators, retrograde neurotransmitters. Again, the receptors are there. This retrograde neurotransmitter, I'll just explain to you a little bit later about this, what exactly it is. These are like neurotransmitters, endogenous, endocannabinoids and neurotransmitters. First time in 1992, here I want all of you. Anandamide is AEA. It's endocannabinoid synthesized in the body. Here you look at it. Synthesized in the brain predominantly. the levels are controlled by tightly regulated degradation pathways. I don't know what it means. It's supposed to give us some kind of happiness, but the production is tightly regulated by it's an inbuilt homeostatic mechanism in the body itself. Why its body is tightly regulating a compound which is going to give us happiness, I don't know. The effects in the brain are extremely localized. Retrograde neurotransmitters, I think we need to understand that. It's like we all know the pre-synapse, synaptic cleft and post-synapse. When, whether it is serotonin or dopamine, when it comes to the synaptic cleft and occupies the neurotransmitter, the effects are downward signals. Post-synapse and that. Here I believe, especially for cannabinoid, ADA, anandamide, the effects are only local. It's not beyond that post-synaptic receptor, post-synapse, but only around the synapse. That's why it's called retrograde neurotransmitter, where the effects are very, very localized. No downstream effects are seen with this particular neurotransmitter. It doesn't affect the organism systematically like exogenous, but it's mostly localized. And also this another thing which is, the secretion is supposed to be, it's acting in bursts, clusters. It's not a continuously secreted. That's why it's called more of a chronic phenomenon. Now look at it, summarize, briefly coming back to that. Anandamide, endogenous cannabinoids, first time detected in 1992. It's supposed to be a neurotransmitter, but neurotransmitter which is retrograde, acting is very locally, not on the downstream, very tightly regulated, easily degraded in the body, and it's a stress responsive. So it's almost like whenever the person has some kind of a stress related, whether you allostatic or homeostatic, you have the release of AEA, which takes care of as a kind of neutralizing effect for the body's stress system. That is what generally what happens in you and me like that. But very interesting phenomenon. Normally in adult person it's a chronic kind of secretion, but during development it's tonically. When I say tonically, it's a continuous development. This is very, very interesting. The same cannabinoid or whatever the neurotransmitter in the adult population or in persons, it's only comes in the burst, but during development, during the time of fetus development, it's more of a tonically active. Function during this period is not as retrograde, but an important promoter and regulator of neuronal development. So, during the time of fetus development, this is a continuously secreted and supposed to be one of the very important neurotransmitter which is essential for the development of neurological system. At this point, I hold, I'm not suggesting anything, I'm not saying anything. So when this is supposed to be such an important neurotransmitter for the development of fetal neurological system, consuming of a phytocannabinoid during pregnancy, I'm not suggesting anything. I'm being very, very careful. Very, very careful. No. Margarete, don't put the sense. I'm not saying that. No, thinking about it. So sometimes overdose, but does it? Can we talk about being a completely no? Like alcohol, like opioid. It's completely, it's not going to. Here, whether it can have possibilities, theoretical possibilities, whether it suggests something. I'm not advocating like taking cannabinoids during pregnancy. No, no sir, please. That's why I'm repeating that. But this is what thought I got. And then generally, they're supposed to be like regulatory functions. We know that sleep wake cycle, pain, memory, and then regulation of egg implantation, which is a very, very important thing, like the reproductive system, and also sensory motor and motivation aspects. This is about the endocannabinoids. Broadly, we know about two, anandamide and then 2-AG. Once again, I repeat, secreted within the body, phasic, generally, stress buster, sort of looking at, anandamide has come there, but during like a development, it's supposed to be very important for the neuronal development, and it regulates these functions, which all comes as a very positive thing in the human body, endocannabinoids. Now, phyto. These are all again, like tetrahydrocannabinol, cannabinol, cannabidiol, these are some other which are plant-based products. These are plant-based. We talked about like our own system inbuilt. So far we talked about fairly healthy, non-problematic, no disease-producing kind of a cannabinoids till now we talked about. When we talk about phyto and then endocannabinoids. Now from here we move to synthetic cannabinoids where the whole problem comes. When we talk about addiction, toxicity, illicit drugs, the whole thing seems to be mostly related to the phyto. I'll come back to it a bit later. Nice review article in 2019. Somebody from the Usmania College published almost about 450. More potent in generating intoxicating effects. And another thing is difficult to be detected in the routine screening test. That's what one of the problems with the synthetic cannabinoids, which are almost about another 500. Look at these are all the different names of this. You name it, they have a name for this. Like K and then Black Mamba and then Blue Lotus, Moon Rock. These are all the names of synthetic cannabinoids. Now what are the fancy names? The reason they kept it like that. This is what the problem. This is why we are discussing today. Cannabinoids is here. This is a part of a CME mainly focused on addiction, de-addiction program. The reason why we are discussing is mainly this, the kind of de-addiction. Let me here said that more potent in generating intoxicating effects and then more problematic. But the last sentence, they also found to be very effective in many health conditions. That is a kind of a dilemma here. That's where I was asking about, is there anything like medicinal alcohol? Is there anything like medicinal opium? Maybe some morphine, pain relief, some other things. Is there, I don't know, medicinal LSD? Medicinal phencyclamine is coming up, like it's coming, but not like that is where cannabis different medicinal cannabinoids, even the synthetic cannabinoids are supposed to be very effective in many health conditions. That is where for us to know, we need to know about it. Another very interesting article, I think all of you must read, that synthetic cannabinoid menace, review of health risks and then toxicity, European Journal, the latest, 2024. This is mainly about the different groups, naturally, identical and then structurally, nothing much. But this is something which is important. These are picking up. This is something called a new psychoactive substances. That is all the substances, like starting from your ecstasy, LSD, amphetamines, and the whole group, which are broadly called new psychoactive substances. I believe SC, what I talked about as synthetic cannabinoids, 25% of them this. So that means the amount of addiction drugs or illicit drugs, synthetic cannabinoids occupy in this space. It's a large space they are occupying. Significant harm and several deaths because of the illicit use, because of this synthetic cannabinoids. Ultimately, mechanism of action is the same. Whether it is a phyto or endo, like a synthetic, CB1 and CB2. Cannabinoid receptor 1, receptor 2, and also some non-cannabinoid like G. Look at this again, this is European monitoring. This is year-wise. Every year, the number of new SCs which are coming up. See, in this period, 2014 and then 13, every year this year about 30 new compounds, synthetic cannabinoids. That shows there are two things. The kind of usage in the youth, the kind of abuse which is going on, the kind of more potent drugs. This is where the synthetic cannabinoids industry where almost about 500 products are available now, where it's finding it difficult to detect, leading to harmful use and sometimes death. This is broadly, when you give whatever the cannabinoid, K2, this is what is called a synthetic cannabinoid, if you administer that, what are the broad effects which are talked about as cannabinoid withdrawal? Broadly, hypothermia, pain relief, catalepsy, and locomotor suppression. These 4 symptoms are called cannabinoid withdrawal. When you give any kind of synthetic cannabinoid or administered, these are broadly clustered of features which are seen in the human body. This is where the whole problem comes. I talked about endocannabinoids which are supposed to be safe, phyto which are supposed to be safe. When it comes to synthetic cannabinoids, the mechanism of action when it comes to that, this is going to directly affect the mitochondrial activity and mobility, which we all know that mitochondria are the powerhouse of cells. That is where the whole lot of multi-system damage can happen there. They also can produce dopamine release. When we talk about any kind of substance using the increasing the dopamine release, the first thing which comes to it, whether it is going to precipitate psychosis, whether it is going to be causative factor schizophrenia. I'll just come to it a bit later. These are the different, the negative consequences of synthetic cannabinoids. I told that mitochondrial activity, dopamine more release, and they interfere with inflammation, metabolism, and oxidative stress. Now the most important point which we all have to, I don't know how many with me, there can be some debate about it, there can be some controversies about it. This is going to be the most important point. Psychosis. Is there something like cannabis? I'm not talking about synthetic cannabinoids, plant-based. Cannabis sativa, plant-based, somebody smokes cannabis. Somebody takes bhang, not synthetic cannabinoid, plant-based products. Can it produce psychosis? For a long time, you don't think that drug-induced psychosis. I think if you look at DSM-5, under every category, there is one substance-induced, where it is depression or bipolar or schizophrenia, substance-induced. For a long time, you are thinking that cannabis can be the causative factor, sole causative factor, which now says that serious toxic effect of long-term use of SC-soon-Lee is not reported with natural cannabinoids, maybe due to the protective factor of it. Sometime back, I heard one lecture by Debashish Bhatt, Chandigarh. The title is nice title about the cannabis, the joker in the pack, where he categorically said that in a person who is not otherwise vulnerable, cannabis alone can never be the causative factor for causation of schizophrenia. I think this is something which we have to understand. Maybe not the schizophrenia, but even psychosis also. If it is synthetic cannabinoid, definitely there is a chance. But if somebody just smoking, somebody using bhang, by itself you can't say that you are taking cannabis and that is the reason why you are having this schizophrenia psychosis. Long time back, we all read about amotivation syndromes and all the things, that is which is accepted. But for schizophrenia psychosis, this is the only single factor. Doesn't seem to be. This is, I think, one of the important things which we have to, I don't know how many of us agree with this, disagree with this, there can be a discussion about it, it may be too early to comment on this. I think morning, Dr. he was talking about, why don't you try cannabis, it looks, a lot of times our youngsters tell us that, why are you talking about cannabis? There are cannabis cafes outside in US, opened up. You're talking about asking me not to take cannabis. So that's the kind of discussion which comes into that. This is what Dr. Debashish talked about very clearly. Only with synthetic cannabinoids, not with phytocannabinoids, you can have psychosis. It's one important message. If you look at the receptor distribution, this is just a slide to show that cannabinoid 1, you see the brain is mostly cannabinoid 1, the red is cannabinoid 2, the black it shows both CB1 and CB2 receptors. If you look at it mostly, it's peripherally mostly absent. Most of the CB1, CB2 are centrally distributed. The entire cannabinoid system, whether it is endo, phyto or SC, synthetic, They're working mostly on this, plus maybe, as I told, there's some non-cannabinoid also, the protein linked receptors. This is broadly the mechanism of action, cannabinoids, receptors, and adenine cyclic AMP. I don't think I will go into the details of it right now, it's not required. This is the metabolism. Whatever is inhaled from the lungs, and then hydroxylation, then gluconated product. This is the metabolism broadly of the cannabinoids. This is once again to show that not only the parent compound which we have done, even the metabolites are very active. Downstream cellular signaling activity is also very, very effective. It can be quite toxic when it comes to synthetic cannabinoids. That is what they show about. I was talking about mitochondrial dysfunction. Synthetic cannabinoids, CB1, CB2, and also non-cannabinoids, they're everywhere, whether it is liver or kidney function or cardiac. Mitochondrial dysfunction, oxidative stress is a common mechanism. SCs are functioning, and that is where you are having multi-organ dysfunction leading to solution, which being sold all over across the world and even for us also. Significant therapeutic effect in epilepsy, Parkinsonism, pain, Tourette syndrome, and pain. One more. Medical cannabis is a broad term. Any kind of cannabis-based medicine used to relieve symptoms. It can come any of these forms, tablets, liquid, oil, powder, any of these forms. And mostly we have the oil form. This is what is being sold. Here, maybe some of you may argue saying that even morphine, opium, it's been medically used for relief of pain in the terminal stage cancer. That's been sort of approved. But the one thing which distinguishes cannabis is that I also showed that appetite increase in pain and the nausea, vomiting in the patients who are undergoing chemotherapy and radiotherapy. In the last resort, that's been approved. Maybe now it's not the best choice, but the last one. But the beauty of cannabinoid thing is that it's not just for pain relief, not for the vomiting and the terminal ill patients. It's for epilepsy. Resistant epilepsy is one of the indications where it's finding more and more useful. That is where it's become now actually very, very useful. Treatment-resistant epilepsy, spasticity in multiple sclerosis. So this is where NICE guidelines in 2023 August guidelines for the use of cannabidiol in the medicinal use. So it's not just a last resort for pain relief or increase in appetite, terminal inpatients. For a child, Lennox-Gastaut syndrome, Down syndrome, when everything else fails, this is coming as a medical drug which is improving that. This may be the one of the first of which can, maybe there are some other drugs which are till yesterday substance of abuse coming into this kind of an acceptance. I do not know. That is where the beauty of this cannabinoid system, the whole way come a full circle on that. Anyway, this slide was just to show that different compounds like dronabinol, nabilone, and then cannabidiol, what are the different indications. Broadly, I will show the indications. They are all listed and which particular condition, which cannabidiol is more useful. Starting from pain, spasticity, there are a lot of things, amyotrophic retinal sclerosis, Huntington's, dystonia, epilepsy, glaucoma, I can read out, multiple sclerosis, IBS, Parkinsonism, ADHD, anxiety, dementia, depression, all this, the list, once again, if you go into the list, it will look like entire psychiatry and neurology and medicine. I'm not looking at this, but very specifically certain conditions. This is an important slide. I showed you about 20 conditions there, but if you look at this is the evidence. If there's a green, it's a high evidence. Then all you know the colors, orange, moderate, low, very low, and then single RCTs, that's a blue. This is looking at the different conditions where there is more evidence. If you look at this, it's only for the epilepsy, there's the green. The high evidence is for as an anti-epileptic, especially in certain conditions, especially in the pediatric conditions. That is where the highest evidence, but the rest of it is all, not like we have different colors. Single RCTs are quite a few here, but single RCTs generally you take it with not just a pinch of salt, use a ton of salt. But morning I was surprised when Dr. Atul was talking about based on a single RCT that too conducted in a different country, FDA gave approval to one particular drug. So that means even single RCTs are sometimes can be very, very powerful and then useful also in getting the drug commercially possible. But here again, if you look at it, it's only for the epilepsy. But there are indications, maybe another decade down the lane, it may change, the colors may change, we don't know. February 2023, FDA is now slowly coming to increasing the interest in the potential utility of cannabis. WHO, United Nations, now FDA. Slowly, one after the other, they are trying to recognize that there seems to be something positive about cannabis. This is I think this is a US-based product. The brand name is US brand name. These are the drugs, cannabidiol. Treatment of seizures with Lennox-Gastaut and Dravet syndrome. This is another thing which is, the other drugs are for weight loss and then anorexia, nausea and pain. This is if you see that 2 years of age and older. Does it give us a message? Generally, most of the drugs, when it comes to approval, it's between 18 to 55 years. That's a standard thing. If you go either below or above, you have to conduct another trial for approval because, unlike the age group, a lot of other factors. But if you say that, let's look at it. If this particular drug is safe for use in persons above the age of 2 years, we take it as something safe. Safest, I don't know, I can't call it that. You can give it for a 2.5-year-old child. Absolutely, the safety wise, especially cannabidiol, what we talk about cannabidiol, even for the age of 2.5 years, it is supposed to be very safe. So safety wise, I think there is one of the good indications where we say that it can be reasonably safely administered. Maybe, I don't know, this may be one of the first drugs I came across saying that which is straight away approved below the age of 18, maybe because the conditions demand, that is the age group where, like this particular substance is more useful. These are the list of side effects we have to be aware of. In all systems, there are reports of acute MI, myocardial infarction, in some of the young patients like 18, 19-year-old who have taken a slightly overdose of synthetic cannabinoids. So it's not all the, when I talk about safe, safer, safest, I'm only talking about number one, straight away phytoendocannabinoids which have some other medically accepted synthetic cannabinoids, not broadly as a group. No, definitely no. There are a lot of like in the dosage and potencies we don't know. We cannot take it as a group. One important thing, now I think it's available all over. I think maybe all of us are going to prescribe. The one thing which is important is that hepatic dysfunction. It's a mandatory that you have to do a liver function test before you administer this, and the dosage has to be attested. Because the most common enzymes elevation is seen. If you look at this compared to placebo, this is one of the most common things, and other is this is one, somnolence, and then the infections, I don't know, like this one, and these are some other things, like the rash seems to be another important, some other factors which compared to placebo. So this is something which we have to be careful about. Hepatic impairment, this is how the dose adjustment, generally the dosage is 2.5 milligrams or 2 milligrams per kg, but so after that you keep building up the dosage, it's made as a liquid. This is something I thought I will share with you, the risk of suicide cause or behaviors, whether cannabidiol by itself or it's only in the trials with epilepsy. I just want to show the slide, not very sure about whether this has got any relation to the increase in the suicide behavior. This is a long story, at least long story in the last 6 decades we know about. As I told that 64 tetrahydrocannabinol first isolated, then within 10 years, first synthetic cannabinoid, 92 only endocannabinoid. This is how, as and today, as I said, that almost about 550 compounds are there, synthetic cannabinoid products, which are being illicitly used all over the world. In summarizing, the mechanism of action is mainly on these two, whatever the category you take. Endocannabinoids, body is the manufacturing unit. Phytocannabis sativa has been there around for a few millennia. Synthetic started in 70s. The last point what I wanted to share is that is it a story of upgrading a substance of abuse to substance of medical prescription? But this is only a short story. If I am only focusing on the last half a century or 1 century, this is true. Last half a century, from the time I know about cannabis, I know this product only as a substance of abuse. I started my, maybe in the medical graduation, cannabis means substance of abuse, nothing else. I started my career, I started my life in the last half a century, substance of abuse, and maybe for the first time a product from being a substance of abuse, it has come to substance of medical prescription, very valid and useful in the treatment of refractory epilepsy. But if you look into the literature, 5,000 years back, this was mainly used in several management of several conditions as one of the, you call it health supplement or whatever it is, historically. As I told that 2400 or 800 BC, the reports are that a particular emperor, this product, cannabis products are being used in the management of several health conditions. Maybe by saying this, I'll give one more stick to. We have a lot of people, anything we say, you talk about a missile, they say that yes, missile was there, Brahmastra was there. You talk about air, yes, there was a Pushpa Vimanam that time. All people, knew everything about a few years back. Now they may say that yes, cannabis was there that time, you people are rediscovering that. I don't know, maybe I'm giving another to them. But whether this is the only product which is the only one and only phenomenon, I think, or we don't know, the another pharmacological ecosystem which may be. I don't see tomorrow someone saying that medical alcohol, medicinal alcohol, maybe I would love it, maybe some of you love to have that medicinal alcohol, and I don't say medicinal opioid. So generally what happens is that you have a substance, you come with benzodiazepines, medically prescribed. First is substance of prescription, then downgrade to substance of use in addiction, which we see in benzodiazepines, amphetamines and other drugs. But this is what the reverse has happened here. Maybe the one and only product, at least as of I know, cannabis is the only product where it's a reverse, from abuse to prescription rather than from prescription drug abuse it has become. That's one important thing about it. And lastly, as I told that from abuse to prescription has become. But the whole story will not be so simple. We have this, we have this much of money is there. That's why there are 500 products, much of illicit use, maybe short-term abuse, and that is where we have to be careful. Now there are the journals, exclusive cannabis digest, there are a lot of information coming out on this. And now we have products here available, cannabidiol is available. I don't know for psychiatry how is it going to be, but definitely for epilepsy. But I hear people writing it for treatment-resistant depression, using it as for treatment-resistant sometimes anxiety. how carefully the potential of abuse as on today we do not know about it. Fortunately, the drug is very costly, 9,000, 10,000 rupees. It's beyond the reach of some people. But the risk of abuse can be there. We do not know about it, but seems to be useful at least in certain conditions. Regarding pregnancy, I think like he talked about like the use of the pregnancy. I will not go into that. So with this, thank you very much for a very patient hearing. Thank you all. Thank you.
Extensive presentation on a substance of abuse to substance of medications. So this can raise a lot of questions in the younger minds and the so-called older younger minds. So we can have a lot of questions and discussion. If I only got 10 to 15 minutes of time, and we can start with one.
Sir, it is as usual an excellent presentation. There's no surprise in that. So my question is, you already said that natural cannabis doesn't cause psychosis according to one article. So my question is, like in my clinical practice, in our clinical practice, we often see patients coming with antisocial personality disorder plus cannabis abuse, then presenting with psychosis. So most often the culprit looks like cannabis-induced psychosis. So it's common to see such kind of patients. So my question is, like time and again it was proved that cannabis causes psychosis and it is a gateway drug for psychosis and schizophrenia-like symptoms. So is it a single article or is it many studies have proven that? So I just want your inputs on that, sir. And my second question is, you said that it is mostly used for medical indications, the synthetic cannabis. So, and sometimes I do see patients self-medicating for depression with cannabis. That is one observation, sir. And second thing is, can be used for anorexia nervosa because their patients have depression and then they don't consume. That is one thing. Because cannabis is associated with munchies where they have high carbohydrate craving, and many patients report that they will have increased consumption of carbs. So can we consider as an indication any literature on that? These two questions.
Maybe out of the three, the third last one seems to be a little bit easier. I have put in one of the indications is to improve the appetite. That's also can be, but no, like how frequently can we use it? Because otherwise the risk of whether it is addiction or illicit use being high, but that can be an indication. That's definitely. The second thing is that you talked about
cannabis-induced psychosis.
That's going to be, see, that's what we all believed all along.
Yes, sir.
The first time when I heard this, as I told you that from that lecture, it was a bit of a surprise also, but more and more evidence, we even otherwise also, as a literature, as I talked about, chronic cannabis use can produce amotivational syndrome. And then that time we had a diagnosis of simple schizophrenia, and then we are trying to equate with that. Other than that, cannabis directly being the one and only cause, like amphetamines can produce a paranoid schizophrenia like that doesn't seem to be. But you said antisocial personality. Now, like cannabis may not be the only one. Second thing is, already a person is vulnerable
to different drugs.
Right. The kind of psychotic condition, whether this is only going to precipitate. That's the only answer today. And then synthetic cannabinoids are not only for the medical use. Synthetic cannabinoids are they are using it as a medicinal use, but most of the out of the 500 products, I think 495 are used for the illicit drugs rather than this. Only approved are only 3-4 products. So that is where the danger comes. That is definite.
Okay, sir. Thank you, sir.
Shivajana.
Yeah. Thank you, sir. That was an excellent lecture. I was working in a collaboration in a project with Yale University. Dr. Deepak D'Souza, who writes a lot about cannabis and psychosis. So they have conducted a lot of trials where they have injected THC in healthy volunteers and seen psychosis happening. And he is a very strong proposer that yes, indeed, cannabis causes psychosis, and also a strong voice in the Yale, in and around New York. And the reason why New York is still not legalized cannabis. If you put it up in an opposite way, are we ready? If you say, for example, if you say it doesn't cause psychosis, so probably that will lead up to that slippery slope where it will lead to legalization of cannabis for recreational use. Are we ready for those, even in those who are vulnerable? They smoke cannabis for recreation and then have psychosis and the burden of psychosis. Are we ready for that?
Yeah, I think the point what you told, the so-called normal person being injected tetrahydrocannabinol. I think that's what the slide also I mentioned, that the psychosis this almost never occurs with the so-called phytocannabinoids, because it seems to have a natural protective cannabidiol in that. That is what I am talking about. Synthetic cannabinoids, it is known. Psychosis is known. But when we talk about this, completely from the plant-based use project, not like now people smoke cannabis, not like most of the times we get patients smoking cannabis. Majority of our patients are smoking cannabis. Trying to link that to, because you are smoking marijuana and you are having this. He is having bhang, that's why psychosis. That link does not seem to be. What you said may be right. THC, there is a big tube, cannabidiol, in this, not like a phytocannabinoid, that is why it is. Synthetic are known to, it's very clearly that, yes.
They also show that over time, the THC percentage in the cannabis products in the US and elsewhere also,
it's increasing. That's the main reason why so many different compounds are coming. The next compound has got much more. That is why CBD1, that affinity is increasing. That's exactly, yes.
Sir, one question is regarding cannabis oil in sleep. Pharma companies, they started promoting that we are using this in sleep medications. One question, sir. Second question is regarding cannabidiol in off-label prescriptions. Pharma companies start saying that, sir, the senior doctor had written for depression, OCD. You also prescribe. I will take your feedback regarding that.
The second question I answered, I will consider you a senior doctor side. So I think
my hair is still not white, sir. So they are saying.
I don't think this will ever be. A senior doctor has done this, and then I don't think we need to even bother about it. You need to even think about it. That's never. Second thing is, another affects. So, but like this product can be used as and today. Intractable in children, especially Lennox-Gastaut and then and severe pain and then loss of appetite in patients going through chemotherapy. These are the two indications for which drug has been released. Off-label indications, if patients start misusing that, then it's always a problem. As of today, let's not talk about it. There seem to be, that's where I said that pain relief, even morphine group of patients. Epilepsy, that's where this particular cannabidiol seems to stand out as a specific medicinal product. Other things, I don't think, then I think you better ignore those seniors. Yeah, please don't bother with the seniors.
So quickly, thank you very much, Dr. Reddy, for...
No, I don't think. See, cannabinoid, I think we have to deal with it with a lot of respect. Especially plant-based endocannabinoid, it's inside us. You don't have control, I don't have control, but his body is regulating. Body is regulating very strictly. Phyto, as of today, that's where I said that we have to differentiate. In the professional group, maybe I talk about, but in the layman's group, I don't think I am going to talk about this. Plant-based seem to be reasonably safe without any toxic effects, short-term, long-term. Synthetic, no. Definitely no, unless it is very clearly medically indicated. Clear-cut distinction.
Dr. Reddy, thank you very much, and you never shy away from controversy. That's beautiful to have this capsule of information very concisely put in. Indulge me in a little question. Historically, like Atharva Veda, Panga you mentioned, like historically there's been a mention of Indianness about the whole thing. and the presence of anandamaya receptor in the brain and the current policy. I mean, Indian Hemp Act is not primarily about being good to people, but it was started with the Opium Act of Britain. Later, Indian Hemp Act came. Are we ready now? I'm thinking, Sai Krishna's question. Are we ready in India at a point like, perhaps it's time to change the policy and outlook on cannabis? Are we ready for dysregulation or deregulation or liberalizing cannabis?
Do you think I'm competent to talk about, are we ready also? It may be more of a policy decision, but from the data what I have given, from the information what I have given, I think reasonable, at least maybe if I miss some point, it's okay. The data shows that the plant-based so-called phytocannabinoids are safe. They have been in use for millennia and they have been used. So, starting from WHO, United Nations, they are changing the policies. But the point is that, as I told this in the group of professionals. Suppose tomorrow I go to for a lecture in town hall, I think I am going to cut down more than half of it because I have to look at the risk benefits of. Doctor, you don't know anything. There are cannabis cafes in US. That's what we need to understand. I think they have to look at the larger public health benefit also when they have to take a call.
Yeah, we can have only two more questions, one from Professor and one from Professor.
Congratulations, Professor. I can call you Professor Emeritus, Dr. M.S. Reddy. See, one of the lectures of Devashishu was, it was said, the endogenous production of anandamide also acts as aphrodisiac. So have you heard of, or have you read about, are you confirmed? And what he also said, and cannabis saliva, I think there is two different, one small variation is there, and a long-standing lack of libido people can be used that one as which might stimulate the anandamaya for sexual agreeability in the males. Let's explain this.
I think already I got into a bit of a trouble when I said that the so-called anandamide in the fetal development, it has got a lot of positive effect in the neurodevelopmental. So can pregnant woman use it? I stopped it there. This is again definitely. So I am extending it to a little bit more than that. For the woman who has sexual libido, they can take this, they can become sexually active, they become pregnant and continue to take pregnancy during pregnancy also, so that the fetus will have a better neurological development. That can be theoretically, but let's not go into that. Yes, that is one of the indications. I mean both the sexes, but when it comes to a female also, yes, both the sexes. Yeah, aphrodisiac. Yes, it's been reported. Yes.
As I understand, see, different parts of the cannabis plant has different concentrations of these alkaloids. So there are certain parts of the plant which has got more of THC, and hence probably consumption of the plant product is not without dangers, because if you consume those parts where there is more concentration of THC. Cannabis is the THC, which is the psychoactive substance, because of which you get
already the cannabis plant products in Ayurvedic preparations and Ayurvedic doctors they are describing, and homeopathy also. Regarding allopathy, whether it is in India legally approved, if approved, the only product is getting special permission to take the prescription.
I think cannabidiol, it has come 2 months back. I think 2 or 3 companies have introduced and an oil liquid form, etc. 100 milligrams per ml. It's mainly promoting for the epilepsy. They are also talking about some anxiety, treatment-resistant depression, but predominantly as a refractory epilepsy in those 2 particular conditions. The safety, I don't know, extrapolating whether we can take a little bit of an Pandey saying that even 2 years old child it was being given, so the safety wise maybe, but it's allopathic medicine, it has come as well. Cannabidiol has been introduced. No, it's a liquid, it's an oil, which you have to give by the droplet.
Sir, is a scheduled extract cannabidiol, medical cannabidiol?
I'm not aware of that. Possible, because it's not being liberally given, that very strictly coming into that. Yeah, very clear indications.
The pharma companies doesn't mention, sir, whether it is a scheduled extract or it's a scheduled H drug.
Not aware of that. It's mainly regarding the way pharmacies keep on that and we use that. But as of today, I know that single prescription, you don't need to have a triplet prescriptions and all those things for that. But which indication you have to use it, you have to be very careful.
We are promoting for ADHD as well, sir.
See, it's like this. When the drug comes, they may talk about anything. A company, I may talk about anything, but what is the evidence based on that medical practitioners have to have an understanding and then prescribe accordingly. I think that's a rule there.
Yeah, I think we should come to the...
Thank you, sir.
Yes, MSR has got a lot of clarification. You can further clarify during the last time or some more presentation during the local meetings. Thank you, sir. I just conclude in one line. We have heard a lot about cannabis, and when sir was talking about medicinal use of opioid, we are using opioids in drug scenes as morphine, spasmopressor, pentazocine, and we have got dependence to those also. They are not in the name of medicinal opioid per se, but those are the medicines of extract of opium which have been used, and we have a lot of dependence, lot of abuse in those medicines. So this is just out of thinking. Can these cannabinoids, synthetic cannabinoids, one be the substance of abuse? Like we are not able to legalize cannabis due to a lot of debates what is going on, and it can be, I think, for the richer people who can afford, because it's almost 10,000, 9,000, 10,000 per bottle. The poorer may not able to go for the synthetic ones. They may go for the phytocannabis, but they can go for all these substances, and this can be backdoor entry for the substance of abuse. So you have to look the legal implication, you have to see the ethical implications. And I think it's one day going to be the backdoor entry from use to abuse to dependence. Thank you very much. Thank again the manager, like George Bhai and Vishal and Minaj Bhai and all the people for giving us the opportunity to share such an important session. Thank you very much. I'll be grateful.
Thank you for the wonderful session, sir. Now I invite Dr. Praveen Chintapati and Dr. Mazhar Ali to felicitate the speakers and the chairpersons.
I request Dr. George Reddy sir and Dr. Vishal sir also to join. There is a small announcement from the organizing committee. Now we are having lunch break, but I request all the students who are part of Dr. B. Anand IMH alumni posters to come back by 1:30 by finishing their lunch a bit early, so that we can start the poster presentations in the main hall. All students had prepared the printouts, so we had provided posters in the frames just beside the Sun Pharma stall. They are ready with the posters also. I request whoever finished their lunch to come back early, so that it will be a real appreciation situation for all the students. Thank you. Please come back soon so that we can start poster presentations on time.
I think just have a last word for our younger generations. because a lot of IPS guidelines have been made and we are not using it properly. So I request all our dear friends, we have got a very good IPS publication on the substance abuse and on cannabis. The topic was written long back by Professor Dalal and Professor M.S. Reddy sir has been one of the publisher of that book. So I request all my PG friends to go through that book, get a lot of information on cannabis, because when you hand out a normal talking to the PGs or to the examination point, they don't have even normal basic idea what the source of cannabis. So I request all, this is a green cover book available in the IPS office. You can go through that books and there will be a lot of information about all the substances including cannabis, opiates. So please go through that book once.
Lunch is ready. I request all the delegates to please join for the lunch and come back a bit soon. Back by 1:30.
AV team to be back by 1:30.
Francis Catatonia rating scale was applied, which is a 23-item scale, and 1 to 14 includes a screening, which was positive for screening, and that importance of considering dissociative stupors in a differential diagnosis of catatonic states. Patient was also provided with psychoeducation, and he was also given psychotherapy, supportive psychotherapy was given. After that, a significant improvement was seen in affect and communication. Thank you.
Any questions?
It is the study of consultation license referrals to Department of Psychiatry in a tertiary care hospital setting, and the study of referral patterns to psychiatry actually helps us to understand the type of patterns and the rate of referrals from individual departments, and understanding the referral patterns, diagnostic trends among patients seeking psychiatric consultation is very essential for optimizing patient care and resource allocation. This helps us to understand the need for consultation license services, thereby strengthening the general hospital psychiatry units. And our aim of the study is to study the pattern of referrals to the psychiatry department in a tertiary care hospital setting. And the methodology, the study design is a cross-sectional study, and the study setting is in a tertiary care referral center. The study sample are the outpatients and inpatients referred to psychiatry from various departments. The study period is from February to March of 2024. The sampling was a convenient sampling over these 2 months, and the method was a semi-structured intake proforma with profile of reference consisting of source, reason for referral, and department from which they were referred were there. and the psychiatric diagnosis were made as per ICD-10 criteria. And like after this study, the results were like most of the referrals done. The patients belong to the age group of 20 to 40 and 20 to 40 years of age, and it was a majority consisting of about 54%. And the background, like most of the patients referred to the referral psychiatric clinic were from urban centers. And the most common referral reasons in this tertiary care hospital setting was alcohol withdrawal, which amounted to around 22%. And disturbed sleep was also one of the important reasons for this referral. And the most common, majority of the referrals were made from departments like general medicine and neurology, like consisting of general medicine like 40% and neurology around 15%. And the diagnosis, like the most common diagnosis which were made during this in this consultation license clinic was alcohol dependence syndrome, which consisted around 32%. And the second common diagnosis was a depressive episode consisting of 25%. And the next one was generalized anxiety disorder. And in a study, in a similar study of the referrals done to the consultation license psychiatric clinic, the majority of the referrals were from medical branches, which consisted of 62%. And our study has the majority of referrals from general medicine, which consisted of around 55%. And from surgical departments, it is 22%, which is in line with our study. And a systemic review shows that there is very limited studies on referral patterns, and they all show different heterogeneity. And there is paucity of studies on specific age groups, which our study has tried to do. Like we have tried to classify the patients in age groups of up to less than 20 years, 20 to 40, 40 to 60, and more than 60 years. And the overall referral rate in this systemic review was in a range of 0.06 to 7.17%, and our study it is 0.12%, which is in line with our study. And the prevalence of alcohol dependence syndrome and mood disorders has been more compared to other diagnoses which was made in this consultation license clinic. And these findings emphasize the need for multidisciplinary efforts to optimize management of patients with psychiatric comorbidities. Like we can conclude by saying that, like, by recognizing and addressing these challenges, healthcare institutions can strive to enhance the quality of care and improve patient outcomes in consultation license psychiatry. And the limitations are, the study was conducted in a single tertiary care hospital, so the generalizability is limited, and the study did not explore patient outcomes on long-term follow-up data. Like this would warrant further research to assess the effectiveness of the consultation license interventions. And further recommendations are, like, future research should involve multi-center studies so that the study can be even more generalizable. And efforts should be made to enhance communication and collaboration between medical specialties, facilitating timely referrals and integrated care delivery. And like interventions should also be aimed at improving the psychiatric education and training of non-psychiatric healthcare providers. And yeah, that's all. Thank you.
Any one question? No, you have made inferences that you need to have better communication and that you need to train manpower. How do you get those inferences from your study?
Sir?
The inferences that you have given, how did you infer those from the study, which is just a statistical collection of data?
Like not from this study, but we've been seeing like people with sleep disturbances getting prescribed low-dose benzodiazepines, or people with mood disturbances being prescribed escalopram or any other SSRIs. So like if we actually put some effort in educating non-psychiatric healthcare providers regarding this, maybe we can improve the...
No, my question is, yes, you have made those inferences, but how did you arrive at those inferences from the data you have got?
No, sir, like that inference was not...
not from the data.
Not from the data.
This presentation will be good if we present non-psychiatric groups. It will be useful for them.
Next present.
ముంగటేయమంటున్నాను ఇది నూకటి ఇవి ట్రైపాలు అన్నకి వినేదా వస్తలేదు తీసుకోగా అన్న కాలు కొంచెం కాలు కొంచెం వెనక టేబుల్ తీసేయాలి ఇది చేంజ్ చేసి ఇది తింటావా ఇది 2 పాయింట్స్ ఉంది ఇది ఎత్తే నేనేమంటున్నాను నువ్వేమంటున్నావు ఎంపీ అయితే అలా పడేసిన ఛార్జింగ్ పెట్టలేకపోతా అది నాకు 2 పాయింట్లు వస్తా
Good evening to all. Today we are coming to the last part of the 10th decennial conference, panel discussion on drugs in our youth, a matter of burning concern. For this presentation, panel discussion, now I invite Dr. V. George Reddy sir, moderator of the session. He is also organizing chairman. We welcome you sir, Dr. V. George Reddy sir. Thank you, sir. Next, I invite Kanakadurga Madam, Additional District Judge, Nizamabad, to come onto the stage. Next, I invite Praveen Chintapati, sir, Consultant Psychiatrist, Tranquil Minds, Hyderabad, onto the dais. Next, I invite S. Kiran Kumar Garu, Additional Collector Nizamabad, onto the dais. Sir is on the way, he'll join for the panel. Next, I invite R. Jagadishwar Rao Garu, Advocate and President, Chamber of Commerce, Nizamabad, onto the dais.
తాగను.
Next, I invite Sri Siddhaya Garu, Secretary, Sneha Society, Nizamabad. Our additional district judge, M. Kanakadurga Madam. She was born in 1964 at Bapatla. She studied at Vijayawada and Visakhapatnam Law at NVT Law College. In 1989, she started practice at Vizag and joined judicial service in 1998 as junior civil judge. She subsequently served as senior civil judge and district judge at various places. Presently, she is working here as additional district judge. The NDPS Act comes here in jurisdiction of Madam's Court. She is dynamic judge with humanitarian approach in her judgments. She is having wide vision over the judiciary and social service. Welcome, Madam. Now I hand over to Dr. V. George Reddy, sir.
Good evening. I should say good afternoon. Thank you, dear postgraduates, consultants. On behalf of Indian Psychiatric Society, Dr. Ashok Chandani sir, President, entire team from Nizamabad. The very purpose of this panel discussion, Madam, we wanted this. The conference is all ours actually. All we psychiatrists, we sit, we talk about the updates, and we have a lot of postgraduates. We are seeing Madam, they present their posters for awards and all this. So usually our conference goes in this way, but the theme of the topic, the theme of the conference is addiction psychiatry. So our scientific committee wanted the actual problem from the other intellects of the society, like you, to give your valuable inputs to all our audience psychiatrists, because I think we are doing a part, like you all are doing the other parts. So I think all our young psychiatrists, consultants and postgraduates, so if you really know about what are the other angles we need to really know, I think it will be very helpful for us to deal with the addiction in the society. And we put the topic as drugs in our youth, and it's definitely a matter of burning concern. I think we all know, and we have seen the government's initiative, how we have to eradicate this menace of drugs and the addiction part. So quickly, we have in the panel Dr. Praveen Chittaparty sir. I think you all know him, a very popular psychiatrist, and he's into real therapy and management of drug addiction. We have Madam Kanakadurga. She's a dynamic personality. I think we will really we're waiting to hear from him. And in the morning we have seen R. Jagdishwar Rao sir actively participated with us in the awareness for drug addiction with all the children and all the excise departments. Sir, thank you. And we have another eminent personality, a very calm, silent person, Mr. Siddhaya Garu, and he is really actively doing his part in rehabilitation with the Sneha Society. I have my co-moderator, Dr. Sai. I think he will just give a small presentation about the data of what we have, so that we all are aware of. Sai.
I know that all of you are exhausted by a lot of statistics, but as this is a panel discussion, I want to project the statistics which we are having. Early drug abuse correlates with substance abuse problems later in life, and the most significant increase in destructive behavior generally it takes place once it starts in the older adults or young teenage. And this is one of the latest statistics which is taken from the government website. So according to this, 8.33% of young adults, they are taking drugs in the last 1 month. And among that, majority of them are taking marijuana. And additional statistics clearly say that 5,91,000 are using some kind of drugs other than marijuana. And if you go to the 8th graders, at least 8.7% are using some kind of illicit drugs in the last 1 month. And 21.33 had tried at least once. By 12th grade, the percentage had increased. Please allow me to correct that spell error. 14.66% had tried by 12th grade. And if it goes to 18 to 25, it had increased, and 11.89 million are using, and approximately 4,777 people had died from drug overdose in the last 1 year. Coming to the particularly youth and alcohol, it is one of the most commonly used substance among adults because of the wide availability. Between 12 to 17 years, the statistics clearly is saying that approximately 1.19 millions had reported binge drinking, so excess drinking, and 9.15% are using in the last 1 month, 12 to 17 years, and daily use among 8th graders is 0.4%, and by 10th it is increasing to 1%. Between 18 to 25, it is increasing to 11.72 million, so approximately 10 times there is a rise of alcohol usage. And between 12 to 20, 60.2% are having binge drinking period also. And coming to the alcohol use disorder, between 12 to 17, 4 lakhs people are approximately meeting the criteria. They are not in binge or they are not using trying. They are meeting alcohol use disorder criteria. And if you go to the other substances, they are also using cocaine, methamphetamine, heroin, pain relievers, and illicit drug use. And they are also trying tranquilizers, hallucinogens, and LSD. Thank you.
Thank you, Sai. I think we will start the panel discussion. We will start with Dr. Praveen Chittapati, sir. So, from your clinical practice as a psychiatrist, what are the common presentations you see these youth coming to your clinic with drug addiction, and what is the common age group of this youth where you see the drugs, like it could be marijuana, it could be any kind of illicit drug, it could be for that matter alcohol. What kind of presentations you see, sir?
Thank you very much, Dr. and I congratulate Dr. Vishal Garu for organizing such a beautiful thing, and I love the format which we stand. George, I congratulate you. Gatam, if we were to go back over 10 years ago, the ideal index patient should have been in his 20s, mid-20s, young male, son of a rich man, doing some cannabis, caught, and then he's brought in, and you try to tell him, now, you get to see a 7th class child who is hardly 12 years old. He's brought in, and then parents say, we found this little packet in his, polythene packet in his pocket, back pocket, and now we don't know what it is. Leaf undi, and every bathroom this trend, and now, we thought, there's only boys now. And a friend's daughter, one of my friends called up, this is 4 years ago. And he said, Arjun Gochen, Dr. Garu. And this guy is a senior bureaucrat. Dr. Garu, this girl has smoked something in the bathroom. She's fallen unconscious. You need to come in. And this girl was hardly 18. So the age of presentation is gradually coming down. And earlier, you would find an adolescent, sneaking into his father's bar and having a little drink, or going out with friends and having a beer in the outside dhaba of outskirts of the city. Now we find young girls getting intoxicated. I got a call from one of those public school that she had a bottle of gin half emptied in the back of the class. So the demography and the presentation is changing. And I'm not talking about esoteric things. One of my friend received a post mail, and mother opened the mail, and there was a printed kitchen towel type paper which had dots printed on it. It was a LSD strip, couriered to home by the vendors. So the perspective is changing, the economics of drug usage is changing, and the average user is much, much younger. And if you want to destroy a nation, introduce drug use at a very young age, I think our nation's future is at stake because of the young demography of usage. Dr. George.
Thank you, sir. Madam, first, madam, we want to know your opinion regarding this panel discussion, because we are having a personality like you, so we want from your perspective how you see this topic going on here.
Thank you so much for inviting me in this panel discussion. My topic is entirely different from yours, and now we are seeing so many drug addicts and the culprits who are coming to courts are different from your topics, because I have learned I have seen in newspapers and things, especially media, some girls are, this is because of manufacturing defects. Whenever manufacturers are there, there is every possibility of consuming the same things. Now, the thing is, only the infants are underage group people. Still, because of so many factors. One is parental care. Where there is no parental care, they used to take drugs, and they used to attract some more things which are not beneficial to them. And first one, not parental care, because of lack of parental care, and availability of money, and pampering by children, by the parents. Second thing, both parents are engaging in their own career establishments. They are not caring for their children, what they are doing, what they are not doing. Because of micro families, they are not cared by anybody. So they have every chance to go anywhere and take chance of other than which is not useful or beneficial to their career. And peer group. Next, behavioral patterns. So many factors are there. Because of these factors, they are under influence of these drugs, which are not benefited or not advised them to take so many such type of medicines and drugs. Whenever we find manufacturer is there will be a consumer. So this is a manufacturer defects. First of all, we have to rule out the manufacturers whoever taking part about the drugs manufacturing, and they are whenever they manufacturing the goods are substitute these things drugs, they used to sell away. They supposed to sell away for their benefits, for which the manufacturer should be punished severely. So how we can detect these manufacturers? Because of especially in Telangana and some other states, there is a cultural things also there. From infant stage to adult stage, they used to consume different types of drugs, such as alcohol, toddy, and everything. Parents themselves they used to give. In one case, both parents are employing and they're prosecuting their career. they are entrusted the duty of caring of their infant to one servant maid. She administered a dosage of some heroin or I don't know what drug she had given, but that said infant soon after leaving the house by the parents, she started to that infant used to go to sleep till their parents comes. In such a way, some days gone. After that, the mother detected why this way child is behaving like this. Then they immediately contacted doctor. They said that some drugs were administered to that infant. In such cases, if there is possibility of like this cases, they have to institute a case against that servant maid in a criminal case like homicidal murder. It is not amounting to murder, but it is a homicidal case. So the very much punishment is life imprisonment. So that type of stringent punishments should be given to those persons who are giving and manufacturing this one, so that this problem would be curbed. My opinion. And Supreme Court has given so lot of guidelines to the central government for formulating different aspects of to the society, to the different governments wherever the drug menace is very much rampant. And even in small children cases also, the Bachpan Bachao Andolan versus Union of India, in which also some guidelines was given to the society, the state governments, central governments, non-governmental organizations for curbing this menace. So everybody should follow those guidelines so that it would be curbed.
Thank you very much, madam, for the great insights from your practice, madam. Welcome, Dr. S. Kiran Kumar sir. Sri Kiran Kumar sir, thank you. Thank you for the correction. Next, sir, Jagdishwar Rao garu, from your experience, Andy, you would first want opinion about our program and then about the MDPS Act, sir.
Respected Dr. Jargar and dignitaries, and Dr. S, or psychiatrists. Really, it's an appreciable that you have taken up a very good cause, and I congratulate the organizers for taking up this popular social problem, which may enlighten many and may be a torchbearer in search of solutions for this social stigma of drug abuse. Unlike and indiscreet of age, many are being victimized to this abuse, paralyzing a good portion of society and nibbling the lives of youth. In the government enacted many stringent laws to eradicate this abuse, but the execution mechanism shall be so vigilant to implement and achieve the target. For example, Narcotic Drugs and Psychotropic Substance Act 1995 was enacted with the stringent provisions to curb this menace. Policymakers' intention was to chase away this drug abuse from our country, and the punishment is very stringent. And recently, the Amendment Act also gave scope for death punishment also. And the Section 59 of this Act, it imposes 10 years rigorous imprisonment with fine of 1 lakh, extendable to 20 years rigorous imprisonment and a fine of 2 lakhs. Section 15 to 31 of this Act provides punishment up to 20 years. And though the Act is there, the implement part, it is somewhat we are in backward. And youth who persistently abuse substances after experience array of problems, including academic, health, poor peer relationship, indisciplined family deterioration, social backward, etc. In the way to get drug substances, the addicted will choose to commit crime to obtain drugs. That is by reselling of drugs, by making some other as scapegoat in the chain of this crime. assault other for money or other things, intoxication of drugs, burglary, robbery, dacoits, rape, assault, whatnot. Every crime in IPC is being done by the drug addicts. In fact, the criminal acts of all sorts are being committed to this drug addicted youth. Society has signals of the danger to its existence by the drug abuse. The juvenile judicial data says that the drug addicts increased by many folds during these 10 years in youth, particularly adolescents. The drug menace to be curbed and nippled in birth stage in youth. The earlier speakers pointed out correctly that the abuse must be identified at school levels and college levels. In fact, the management of education institutions, parents and students shall form monitoring committee to watch the surroundings. They shall watch nearby establishments, surroundings to weed the peddlers of substances of many sorts. They should constantly watch the peddlers and students, their extreme behaviors and study patterns. It has become dire necessity of the society to ward and watch the young generation for their safer society and better future. Everyone of society shall hold the addicted with concern and console without hating them. The stigma can be eradicated by our consciousness and stricter legal system. Criminal law on this aspect is perfectly enacted, but the enforcement authority should be much stronger to weed the abuse. So, first, the government should make strict implementation of acts and focus on reduction of supply of harm reduction. Government can achieve supply reduction of substance on univocal concentration of all departments. Secondly, the demand reduction sector works for prevention, easy identification of those with a drug use problem, social awareness and restraining the youth from drug addiction. Our ultimate goal shall be eradication of drug abuse and rehabilitation of the youth, such youth with love and affection. So, what we think is the acts are very stringent, but only the implementation part is somewhat we are impacting. That's why it is very necessary for all of us to take it to the higher level, and we have to act upon for betterment of society. Thank you for having me.
Thank you, Andy. I think, sir, the last word which you said is very right, sir. Might be we see when youth coming to our clinics, first of all, we doctors, first of all, we don't report adequately. Because, and even if they go to the police, they're caught a drunk driver, they're driving, I don't think the police are going to be strict with them. Or neither when they come to you also, I think somewhere, I feel the concern is they are, young. So might be they have to be given a chance to live. So I think that's where, that's one factor I feel. Thank you, sir, for that valuable input.
In proper way, in a univocal way, definitely is workable. Because, for example, this polio is there. But polio, in fact, polio was a very dire disease spreading over the world. Once it was taken up by government, international these clubs and road. In fact, each drop is prepared by Rotary Club of International, and that is being supplied by the government. Yes, in everywhere, throughout the world. Now, the entire world is without polio. I think this year it will be announced.
So yes, I think like that you mean to say we have to
it is stringent. Necessary that it should be advertised in that way.
Stringent act, yeah.
It must be, the committee should be formed in each college and school level, like anti-ragging act. An act should be framed and formulated, so that a committee is there in wherever college or school level. Then they will find out whether the boy or girl consuming the drugs or not, and finding out and giving and sending them to rehabilitation just like rehabilitation center. Because if we not curb at that stage, they may lead to so many complications to the society, such as they become antisocial elements. Under the guise of the drugs, they used to do unnatural events, unnatural things. So that is the thing. It is very much necessary at this stage. The government has to formulate an act to form a committee in each level, that is a school and college level, so that it would be covered. Because the ragging act is most prevalent before 10 years back. Now there is no ragging in any of the colleges or schools. So it would be covered in such a manner, and the others, so that it would be for detecting these things to prevent the children or those who are drug abusers can be detected and can be prevented. So that type of some teams should become and it should be governed by non-governmental organizations, governments and everything. This is my suggestion, because we have seen the ragging act in such very drastically changed. Because of ragging act, so many behavior patterns were changed, and in such a way a committee should be formed and an act should be framed for this one.
Thank you, madam. I think that's very valuable. Before that, I'll go to Siddhay Garu. Siddhay Garu, I think you are into a lot of rehabilitation activities, right from children with intellectual disability, mental retardation and all, sir. How is your take, sir, on de-addiction centers, particularly NGOs like you? Do you think the government is giving adequate number of from the government, or are they able to provide you adequate funds to run these licensed rehabilitation centers? So your take, and before that, sir, about this today's program, we would like to know your opinion.
Andarki namaskaram. నేను 1992 నుంచి స్వచ్ఛతా సేవా సంస్థ నిర్వహిస్తూ ఉంటాను. ఎక్కువగా వికలాంగుల పునరావాసం, అదేవిధంగా మహిళా సెక్స్ వర్కర్ల పునరావాసం, ఎవరైతే మహిళలు హింసకు గురైనారో వారి పునరావాసం, ఇలాంటి అంశాల మీద మేము పనిచేస్తూ ఉంటాము. మరి ఇప్పుడు పరిస్థితి చూసినప్పుడు, మరి నేను 1995లో ఒక మానసిక వికలాంగుల పాఠశాల పెట్టినప్పుడు నా దగ్గర ఉన్న పిల్లల్లో చాలా మంది ఫిట్స్తో బాధపడుతూ ఉండేవాళ్ళు. వాళ్ళకి ట్రీట్మెంట్ ఇవ్వడం కోసం మేము హైదరాబాద్ వెళ్ళాల్సి వచ్చాను. సో ఎవరైనా ఒక వ్యక్తి మానసిక రోగిగా మారినా అది మానసిక రోగం అని తెలవక వాళ్ళు బాబాల చుట్టూ, గుళ్ళ చుట్టూ, గోపురాల చుట్టూ తిరిగి ఆ రోగాన్ని పెంచుకొని నయమలేని స్థితికి మారిపోయేవారు వాళ్ళంతా. సో వాళ్ళందరూ కూడా ఏమయ్యారంటే వాళ్ళు సరైన సమయంలో వాళ్ళకి చికిత్స ఇవ్వలేక మరి వాళ్ళందరూ కూడా సీవియర్ మానసిక రోగులుగా మారి వాళ్ళు సమాజానికి హానికరంగా మారడం జరిగింది. సో నేను ఎప్పుడు కూడా నన్ను ఏ కార్యక్రమంలో పిలిచినా నేను ఫస్ట్ అందరూ ఎడ్యుకేషన్ గురించి మాట్లాడితే నేను మెంటల్ హెల్త్ గురించి, మెంటల్ హెల్త్ ఎడ్యుకేషన్ గురించి ఎక్కువగా మాట్లాడుతూ ఉండేవాడిని. సో అయినా కానీ మనలో మార్పు లేదు. మరి ఇప్పుడు పరిస్థితులు చూస్తే మనకి ప్రతి దగ్గర ఒక సైకియాట్రిస్టు అందుబాటులో ఉన్నారు. మరి నిజామాబాద్లో చూస్తే మంచి సైకియాట్రిస్టులు నిజామాబాద్లో అందుబాటులో ఉన్నారు. మా మానసిక వికలాంగుల కోసం మాత్రం తప్పకుండా ప్రతి చిన్న సమస్యని పరిష్కరించడం కోసము సైకియాట్రిక్ వైద్యం అనేది అందుబాటులోకి వచ్చింది. సో దాన్ని పక్కన పెడితే మరి నేను ఈరోజు టాపిక్ ఏదైతే డ్రగ్ అబ్యూస్ ఉందో దాని గురించి నేను 2 విషయాలు మాట్లాడాలనుకుంటున్నాను. సో మనకి నేను ఒక ప్రభుత్వాన్ని విమర్శించడం కాదు, మరి మనకు ఒక ప్రొహిబిషన్ శాఖ ఉంటుంది. ప్రొహిబిషన్ శాఖ ద్వారా వాళ్ళు మద్యం నియంత్రణ, మద్యం నివారణ, మరి ప్రజా ఆరోగ్యం, మరి ధనసేకరణ అనే 4 అంశాల మీద మామూలుగా ప్రొహిబిషన్ శాఖ అనేది పనిచేస్తూ ఉంటుంది. కానీ నేటి పరిస్థితుల్లో మరి ప్రభుత్వాలు వాళ్ళ యొక్క బడ్జెట్ అంతా కూడా మద్యపానం ద్వారానే మరి సేకరించుకోవడానికి కేవలం వాళ్ళు మద్యపానం మీద ఆధారపడి కూడా బడ్జెట్ తయారు చేసే పరిస్థితుల్లో మరి ఈరోజు గవర్నమెంట్లో ఉన్నాయి. కావున వారు అక్కడ ఏం జరిగిందంటే మరి ఏదైతే మనం నియంత్రణ నివారణ మీద శ్రద్ధ పెట్టాలో నియంత్రణ మీద నివారణ మీద శ్రద్ధ తగ్గింది, ప్రజా ఆరోగ్యం మీద కూడా చాలా శ్రద్ధ తగ్గిందని చెప్పుకోవచ్చు. మరి ధన సేకరణ మీదనే అంటే ప్రభుత్వానికి ఆదాయం సమకూర్చడం ద్వారానే మరి ఈ మధ్య ప్రొహిబిషన్ అంటే ఎక్సైజ్ శాఖ అనేది పనిచేస్తుంది. సో నిజంగానే చెప్పొచ్చు ఏంటంటే వాళ్ళ దగ్గర ఉన్న మ్యాన్ పవర్ కూడా చాలా తక్కువగా ఉంటుంది. మరి ఈరోజు మేము చాలా ప్రదేశాల్లో మేము సర్వే చేసేటప్పుడు మరి చిన్న చిన్న పిల్లల్ని మరి ఈ డ్రగ్స్ సప్లైలో భాగస్వాములుగా చేస్తున్నారు. మేము నిజామాబాద్ జిల్లాలో స్ట్రీట్ చిల్డ్రన్ కోసం సర్వే చేసినప్పుడు కొంతమంది స్ట్రీట్ చిల్డ్రన్ ద్వారా తెలిసింది ఏంటంటే వాళ్ళు ఎవరైతే ఈ గాంజా సో ఏదైతే ఈ డ్రగ్స్ ఉన్నాయో డ్రగ్స్ సప్లైలో చిన్న పిల్లలు నీ వాడుకొని వాళ్ళు డ్రగ్స్ అనేది సప్లై చేయడం అనేది జరిగింది. సో ఈ విధంగా కూడా పిల్లల్ని ఇందులో ఇన్వాల్వ్ చేశారు. ఇన్వాల్వ్ చేయడం అదే కాకుండా మరి ఇందాక మేడం గారు చెప్పారు ప్రతి కాలేజీలో ప్రతి స్కూల్లో మానిటరింగ్ కమిటీలు అనేది పెట్టాలి, నిఘా కమిటీలు అనేది పెట్టాలనేది. అదే కాకుండా మరి ప్రభుత్వం నుంచి ఉత్తర్వులు ఉన్నట్లయితే ప్రతి పాఠశాలలో కూడా మరి అసెంబ్లీలో పొద్దున్నే ప్రేయర్లో 2 నిమిషాలు మరి ఈ ఏదైతే మత్తు పదార్థాల సేవనం గురించి దానివల్ల వచ్చే అనర్థాల గురించి కూడా పిల్లలకి చెప్పినట్లయితే బాగుంటుందని నేను అనుకుంటున్నాను. సో అదేవిధంగా మేము సఖీ కేంద్రం అనేది నిర్వహించడం జరుగుతుంది. మరి నేను 2017 నుంచి దాదాపు ఇప్పటి వరకు 7,000 మంది మహిళలకు మరి వాళ్ళు మా సఖీ కేంద్రానికి వచ్చినప్పుడు మేము వాళ్ళ దగ్గర నుంచి సేకరించిన సమాచారాన్ని బట్టి మరి వాళ్ళ మీద హింస ఎందుకు జరుగుతుంది అని అనుకున్నప్పుడు మాకు తెలిసిన విషయం ఏంటిదంటే దాదాపుగా 90% మంది వీళ్ళు మద్యపానం వల్లనే అనర్థాలు అనేది మద్యపానం సేవించిన తర్వాతనే వాళ్ళందరూ కూడా హింసకు గురవుతున్నారు అనేది. సో అప్పుడు మరి తెలంగాణ ప్రభుత్వము చాలా రిగరస్ గా ప్లాన్ చేసింది. మరి ప్రతి సఖీ సాఫ్ సెంటర్ కి ఒక డ్రగ్ డి అడిక్షన్ సెంటర్ కూడా ఇస్తే, ఎందుకంటే మరి సాల్వ్ అంటే ఏదైతే సమస్య వచ్చిందో ఆ సమస్యని పూర్తిగా పరిష్కరించాలంటే డ్రగ్ డి అడిక్షన్ సెంటర్స్ ప్రతి జిల్లాలో ఉండాలి. మరి దాన్ని సఖీ ఆధ్వర్యంలో నిర్వహించాలని చెప్పేసి కూడా కోరడం జరిగింది. కానీ మన దగ్గర ఉన్న ట్రైన్డ్ మ్యాన్ పవర్ అందుబాటులో లేకపోవచ్చు. సో దాన్ని నిర్వహించడానికి అనుభవం ఉన్న కౌన్సిలర్స్ కావాలి, అనుభవం ఉన్న డాక్టర్లు కావాలి. కాబట్టి ఈ స్కార్సిటీ వల్ల మరి ఏ ఎన్జిఓ కూడా ముందుకొచ్చి డ్రగ్ డి అడిక్షన్ సెంటర్స్ అనేది నిర్వహించలేకపోయింది. సో అదేవిధంగా మరి ఫండ్స్ విషయానికి వస్తే మరి మేము మానసిక వికలాంగులతో పనిచేస్తూ ఉంటాము. మేము కొంత లోకల్ కాంట్రిబ్యూషన్స్ తోటి మేము ఈ కార్యక్రమాలు అనేది నిర్వహించడం జరుగుతూ ఉంటుంది. సో మాకు సమాజం ద్వారా వచ్చే విరాళాలు కావచ్చు, మరి కేంద్ర ప్రభుత్వం నుంచి వచ్చే 70% గ్రాంట్ కావచ్చు, దీంతో మేము ఈ కార్యక్రమ పాఠశాలని నిర్వహిస్తుంటాము. ఈ మానసిక వికలాంగుల పాఠశాలలో కూడా మరి వాళ్ళకి చాలా బిహేవియర్ పరమైన సమస్యలు ఉన్నా, ఫిట్స్ ఉన్నా, లేకపోతే హైపర్ యాక్టివిటీ ఉన్నా, మరి ప్రతి చిన్న విషయానికి మేము ఒక సైకియాట్రిస్ట్ ని కన్సల్ట్ చేయడం అనేది జరుగుతుంటుంది. మరి ఒకప్పుడు చాలా ఇబ్బంది పడటం జరిగింది. ఏంటంటే మరి సైకియాట్రిస్ట్ సర్వీసెస్ జిల్లాలో అందుబాటులో లేక, మరి ఇప్పుడు చూస్తే మరి ప్రతి ఒక్కరు కూడా అందుబాటులో ఉండేది. మరి నేను 2002లో మరి వీడియో మెడిసిన్ అని చెప్పేసి మరి మా నిజామాబాద్ జిల్లాలో ఉన్న పిల్లలకి ఏదైనా ట్రీట్మెంట్ ఇవ్వాలంటే మానసిక వికలాంగులకి మరి హైదరాబాద్ తోటి వీడియో కాన్ఫరెన్స్ ద్వారా మరి ఆ రోజుల్లో 2002లో ఇంట్రొడ్యూస్ చేయడం జరిగింది. సో అప్పుడే మేము ఆ పిల్లలకి వీడియో మెడిసిన్ ద్వారా హైదరాబాద్లో భానుమతి చారిటీ హాస్పిటల్ సైకియాట్రిస్ట్ గారితో మరి లింకప్ చేసుకొని ఆ రోజుల్లోనే మేము వాళ్ళకి వీడియో కాన్ఫరెన్స్ ద్వారా ట్రీట్మెంట్ అనేది చేయడం జరిగింది.
కిరణ్ కుమార్ గారు, ఫ్రమ్ అడ్మినిస్ట్రేటివ్ పాయింట్ ఆఫ్ వ్యూ సార్, మీరు ఇప్పుడు యూత్లో ఈ ది డ్రగ్ అడిక్షన్, ది బర్డన్, హౌ డూ యూ టేక్ ఇట్ సార్? అండ్ how are the challenges? What are the challenges you are facing in the administrative part, sir, regarding the drug addiction in the youth?
అందరికీ నమస్కారాలండి. ముఖ్యంగా డాక్టర్ విశాల్ గారు నన్ను ఇట్లా మేము ఆర్గనైజ్ చేస్తున్నాము ఒక కాన్ఫరెన్స్, దానికి మీరు రావాలని చెప్పేసి ఒకసారి నన్ను అడగడం జరిగింది. కానీ యాక్చువల్గా ఆ టైంలోనే మనం కొన్ని మన నిజామాబాద్ పరిసర ప్రాంతం అంటే సరౌండ్ డిస్టిక్లో ఈ డ్రగ్ అబ్యూజ్ కొంతమంది కాలేజీ అమ్మాయిలు వాడతారని అట్లా దృష్టికి రావడం జరిగింది. అటువంటి టైంలో దాని గురించి ఎక్కువ న్యూస్లో ఉన్న టైంలోనే వీళ్ళు కాన్ఫరెన్స్ గురించి ఆర్గనైజ్ చేయటం, అది నిజామాబాద్లో చేయటం, అది నాకు చాలా సంతోషంగా అనిపించింది. సరే మీరు ఇప్పుడు చాలా అవసరం అండి ఈ కాన్ఫరెన్స్ కూడా, మీరు అందుకని చెప్పేసి నేను అటెండ్ అవుతానని చెప్పాను. అయితే ముఖ్యంగా ఇది 10th యాన్యువల్ కాన్ఫరెన్స్ ఆఫ్ ఇండియన్ సైకియాట్రిక్ సొసైటీ అని చెప్పారు, స్టేట్ బ్రాంచ్ వాళ్ళు కండక్ట్ చేస్తున్నట్టున్నారు. వాళ్ళకు ముఖ్యంగా నా అభినందనలు తెలుపుతున్నాను. తర్వాత మా డిస్ట్రిక్ట్ అడ్మినిస్ట్రేషన్కి వస్తే ఈ డ్రగ్ కంట్రోల్ గురించి కూడా ఒక డిస్ట్రిక్ట్ కమిటీ ఉందండి. డిస్ట్రిక్ట్ కమిటీ ఫామ్ చేయడం జరిగింది. ఆల్రెడీ దీంట్లో మన కమిషనర్ గారు, కమిషనర్ ఆఫ్ పోలీస్ అండ్ డిస్ట్రిక్ట్ కలెక్టర్ గారు ఇద్దరు కూడా ఉన్నారు ఆ కమిటీలో. ఈ కమిటీ మీటింగ్ కూడా మేము డేట్స్ కోసం సర్క్యులేట్ చేయడం జరిగింది. జస్ట్ 2 days బ్యాకే నేను ఈ డేట్ కోసం కలెక్టర్ గారికి కూడా సర్క్యులేట్ చేయడం. అంటే ఎప్పుడు కూడా పిరియాడికల్గా రివ్యూ చేస్తుంటారు. మన ప్రతి డిస్టిక్లో ఉంది, డిస్టిక్లో కూడా ఏ విధంగా డ్రగ్ అబ్యూజ్ అనేది ఉంది, దాన్ని ఎట్లా కంట్రోల్ చేయాలి, ఏంటి దాని ఇంటెన్సిటీ ఎట్లా, దాన్ని కంట్రోల్ చేయటం ఎట్లా, ఆ విధంగా డిస్ట్రిక్ట్ అడ్మినిస్ట్రేషన్ వాళ్ళు దానిపై దృష్టి సారించడం జరిగింది. ఇట్ ఈస్ ఏ జీవో ఇష్యూడ్ బై ది గవర్నమెంట్. దాని ప్రకారంగానే మనం డిస్ట్రిక్ట్ లెవెల్లో కమిటీలు ఫామ్ చేసి మేము రెగ్యులర్గా మానిటర్ చేయడం జరుగుతుంది.
థ్యాంక్ యూ అండి. డాక్టర్ ప్రవీణ్ సార్, sir, the acceptance of cannabis is legal in some states, and by some government they are encouraging its use. So now some argue that it should be legalized in India too. Now the new evidence clearly supports its role in causing mental illness like psychosis and many others. Now what should India do? Should we encourage to legalize it, or how do you see this? So because many times people using cannabis, they come to the clinics, they argue with us that it is legal. They quote some states in the US or some parts of Europe or somewhere, and now they portray as if it is also wise to take in this country. How do you take it, sir?
I'll take a safer stance. We had a lengthy lecture today this morning by Dr. Nizamabad about medicinal use of cannabis and similar substances. US, in certain states, it's decriminalized, that means people can use it, but it's not a crime. In some places, it's legally sold in different ways, in different forms. And certain states, it's still not legal yet. In our country, we are very clear. NDPS states cannabis possession for usage, the punishment is this. Cannabis usage for supply, the punishment is this. That's the law of the land, and we should stick by the law of the land till the law of the land is changed. And people might have a personalized view, but we all in our practice, in our day-to-day things, we do see people developing really miserable behavioral issues while smoking cannabis or something, similar substances, like it could be cannabis or cannabis-related substances, marijuana, whatever. People might have different names. They might call it ganja, bhang, or whatever. I think it's very evident that it causes problems, and the current law of the land says that it's illegal, and it is illegal till we have more evidence that there is certain parts of the plant which can be used as medicine. Ayurveda uses it, and it's been using, Ayurveda uses it since millennia, and people still use it in medicines from Ayurveda in a licensed form. There are approved farms which are developed and cultured by the government, which are licensed. Similarly, we eat khaskhas every day, and it's an opium extract. There, again, licensed cultivation of khaskhas is there. approved, licensed in specified secret zones. I think that's how the government functions. And government probably, if it has to make a policy shift, it needs lots and lots of evidence. And we are a huge country, so if it's a small country with small state, it can take a U-turn very quickly. If it's a very long, huge ship like India with 1.4 billion population, I think we're going to make a very gentle shift, gradual shift, and that might take a long while, perhaps a decade.
Thank you very much, sir. Madam, from your experience, madam, let's say youth is caught using substance or any drug. So, what are the legal consequences? The youth, if it's a minor or if a major, and what the family has to go through. Would you throw a light on the punishment the court of law can impose on this youth?
Yes. One thing I want to say, these drugs are rampant since 20 years onwards. Before that, there is no such type of drugs in our country, especially in our country. All foreigners came to India for taking these spices only. Out of that, they detected. Now, just doctors get cuscus. They detected. Till then, nobody is using such type of things. Drugs. So it is a foreign culture. It is an acquired syndrome. It is not a born syndrome. So we have to curb from country level. Now, after consuming, what is the effect of consuming alcohol? Nowadays we are seeing, under the guise of alcohol, a man kills his wife, children, for spur of moment without having any of the patients in facing the problems in the family. They are doing so many what we call it, the punishable acts they are doing, such as murder, rape, everything. So under Juvenile Justice Act, there is a provision is there, Section 77 says a juvenile should be taken care with care and protection is there. Under Section 77 says that a small child, juvenile means under the age of 16 years, must be taken care of by the society, the children, the parents and everybody. This is because this is a behavioral pattern. The first is behavioral pattern, and the second one is lack of caring, emotional abuse, and loss of self-confidence, and so many factors, behavioral patterns and everything. And boredom. If both parents are engaged in some their career establishment, the children will feel boredom. They have no sense of sharing their feelings and everything with parents. First of all, family is only the platform for sharing their sense of their some emotions and everything. But they have not. There is no platform here. That's why they are doing. They are choosing, not doing. They are choosing to do some acts which attracts their attention by the parents as well as the society. Under the guise they used to some acts which are punishable under the IPC and some various acts. So this is the problem we are seeing nowadays, and especially in children at the infant stage. That is the main thing. So that in IPC there are several acts are there, several sections are there for punishments. For rape, gang rape, committing, theft and everything. Every forbidden act is to be punished by the government, courts of law. So this could be only, the remedy is stringent punishments should be given. For that, state mechanism is also should concentrate on that. Nowadays, I have been seeing, I should not say about the excise department. They are bringing only alcohol cases. alpha-zolum, except that no other drugs are they are not detecting it, they are not bringing the reports. And they are not collecting the evidence, they are not in a position to follow the procedures which are envisaged under the Act. So when the procedure lapses, what the courts will do? If procedure labs are not there, the disciplinary punishment will be given for 20 years and or so. My personal opinion is, what is my personal opinion? Instead of giving punishments, we should give training, proper training in perspective, proper training to each and every individual. Then only it is not a jail bharoka programs or these things. First we have to train them, and then later they are not in a position to listen or follow the procedures, then we have to opt for punishments.
Thank you very much, madam. Thank you. Jagdishwar.
Drug అనేది 100% it has to be eradicated. Drug cannot be carried out and it cannot be transported. అయితే ఇప్పుడు కొన్ని కమ్యూనిటీస్ ఉన్నాయి, కొన్ని రూరల్ కమ్యూనిటీస్లో వాళ్ళు గంజాయిని దే ఆర్ యూజింగ్ ఇట్ యాజ్ ట్రెడిషనల్. అది కూడా తప్పని మనం ప్రూవ్ చేయాలి. ఇప్పుడు రీసెంట్గా నేను ఒక ఇన్సిడెంట్ చూశాను, మేడం గారు కూడా చెప్పాను. ఒక అంటే మేము క్లబ్ నుండి సోషల్ రిసార్ట్ వెళ్తున్నప్పుడు ఒక ఊర్లో వెళ్ళినప్పుడు వాళ్ళు ఏం చెప్పారంటే, ఒక అమ్మాయి విచిత్రమైన సిచ్యువేషన్లో షీ నాట్ కమింగ్ టు ది స్కూల్. ఎందుకని మేమంతా కలిసిపోతే ఒక చిన్న పిల్లాన్ని అక్కడ షీ కీపింగ్, అక్కడే ఉన్న ఆ పిల్లను చూస్తున్నాను తమ్ముంటే. ఎందుకనంటే మా అమ్మ నాన్న ఊరికి పోయారు, పోయేటప్పుడు వీడికి డ్రగ్ ఇస్తారు, మరి వాళ్ళు ఏం గొడవ చేయకుండా మేము వచ్చేదాకా మళ్ళీ నాన్నమ్మ వచ్చేదాకా వీడు అట్లా పడుకొని ఉంటాడు. వాడిని చూడడానికి నేను ఇంట్లో ఉన్నాను. సో దిస్ ఇస్ ది మెయిన్. అందుకని గవర్నమెంట్ ప్రాపర్ వేలో తీసుకుంటే 100% ఎరాడికేట్ అవుతుంది. తర్వాత చిన్న అప్రిషియేషన్ సార్, అప్రిషియేషన్ టు ది సైకియాట్రీ. మీరు ఎందుకంటే యువర్ స్పెసిఫిక్ డాక్టర్స్, మామూలుగా డాక్టర్లకి మీకు చాలా డిఫరెన్స్ ఉంది. Because I used to visit Dr. Vishal and recent Day-3 center open చేశారు. I used to see so many patients వచ్చి కొడుతుంటారు, గొడవ చేస్తుంటారు, అలా చేస్తుంటారు. బట్ పేషెంట్స్ ఈ డాక్టర్స్ కి ఈ పేషెంట్స్ ఎంత ఉందో నిజంగా మిమ్మల్ని అప్రిషియేట్ చేయాలి, అసలు మొక్కాలి. ఎందుకంటే వాడి ఇంట్లో వాళ్ళు ఎవరు వాళ్ళు పట్టించుకుని వాళ్ళతో కాక ఇక్కడ పడేస్తున్నారు డిఎడిక్షన్ లో. మీరు దాన్ని వాడిని మొత్తం మెల్లిమెల్లిగా ట్రీట్ చేస్తూ వాడు చెప్పిన దాంట్లో ముందు వాళ్ళ దాంట్లో మీరు పోయి తర్వాత వాడిని మీ దాంట్లో తీసుకొచ్చి ఈ మందులు ఇచ్చి రియల్లీ అప్రిషియబుల్ సార్.
థ్యాంక్ యూ అండి, థ్యాంక్ యూ వెరీ మచ్. సిదే గారు, లాస్ట్ క్వశ్చన్ ఫర్ యూ. ఈ ఫ్యామిలీ మెంబర్స్ సఫరింగ్ విత్ అడిక్షన్ అండి. సో ఇప్పుడు ఈవెన్ ది మెంటల్ హెల్త్ కేర్ యాక్ట్ కూడా addicted person in addiction, if he wants treatment, he can take treatment. If he doesn't want this, he can deny. So, but in Indian context, you see the family's role in patient care or any problem. So, in addiction lo we see the mothers, the fathers, the family members suffering more. So, వాళ్ళకి మనము ఒక రీహాబిలిటేషన్ సెంటర్ నుంచి వాళ్ళకి సపోర్టివ్ కౌన్సిలింగ్ మీరు ఎలా దీన్ని తీసుకుంటున్నారండి?
సో యాక్చువల్గా నేను ఇంతకని చెప్పడం జరిగింది, సఖీ సెంటర్లో దాదాపుగా ఒక 90% మంది, అంటే దాదాపుగా 6,000 మంది మహిళలు హింసకు గురయ్యారు. వాళ్ళు కేవలము ఈ ఆల్కహాల్ మూలంగానే మరి భర్త మమ్మల్ని హింసిస్తున్నారు అనే మాట కూడా చెప్పడం జరిగింది. మరి అది అఫీషియల్ రికార్డే కాబట్టి వాళ్ళకి కౌన్సిలింగ్ ఇవ్వడమే కాదు సార్. సో బేసికల్గా డ్రగ్ డి అడిక్షన్ అనేది కూడా కంపల్సరీగా ఉండాల్సిన అవసరం ఉంది. సో ఎవరికైతే ఇప్పుడు అంటే ఆల్కహాల్ సేవించి అంటే ఇంట్లో కుటుంబ సభ్యుల్ని హింసిస్తున్నారో వాళ్ళకి డ్రగ్ డి అడిక్షన్ సెంటర్ ఉండాలి. వాళ్ళకి ప్రాపర్ కౌన్సిలింగ్ అనేది ట్రైన్డ్ కౌన్సిలర్స్ ద్వారా కౌన్సిలింగ్ ఇప్పించాల్సిన అవసరం ఉంది సార్. సో
thank you very much. So we all know that the drug addiction in youth, it's a long journey. Might be many times it's a continuous journey. The youth might stop, again they go back. As today our General Secretary Dr. Lokesh was telling in the youth awareness program what we did, let's not treat them as something they're aliens. Like we all have health issues like hypertension, diabetes. Anybody is into addiction, I think it is our role as empathy to help them and see that they get proper counseling and definitely treatment required by a psychiatrist, if required admissions, if required long-term rehabilitation. And we know many popular or many famous personalities who were into this addiction and they came out of addiction. Some were there for months in rehabilitation, some for years in rehabilitation, and that's how these young fellows, many movie stars, there are so many popular people who are into this. So it's like, again, it is a never-ending topic, and it's, I think we should thank all the panelists for their valuable time, and I really appreciate that. Thank you for making us a part of the society, madam, sirs, and Praveen Chitapati sir, all of you from this Kiran sir, Meru Sitaya garu, Jaineshwara garu, and definitely Sai, thank you. And I wish I'll ask you one last question, Sai. Dr. Sai is again, is an active practitioner at Karimnagar, and he's into a lot of general practice. So I think I should really ask you, how is that we psychiatrists, how are we going to take this problem, and your message to the youngsters who are going to practice and who will definitely take up this problem in a bigger way, because it's a big menace.
Whenever a young person comes to me, first I will motivate the family members. Why? Because the problems as discussed by all the panelists, it starts from the family. So I'll spend a lot of time with the family, and I'll give 1 or 2 counseling sessions to the child or also a youth person. కరీంనగర్లో అందరికీ గీతాభవన్ తెలుసు. నాన్న నువ్వు గీతాభవన్ సెంటర్లో కూర్చొని నువ్వు ఏదైతే తీసుకుంటున్నావో ఒక 10 మంది ముందు నువ్వు తీసుకుంటున్నావు అంటే అది అప్రిషియేట్ చేస్తారా చేయరా? అది సిగరెటే కావచ్చు, బీర్ కావచ్చు, ఇంజెక్షన్ కావచ్చు, కెనాబిస్ కావచ్చు, ఏదైనా కావచ్చు, ఒక 10 మెంబర్స్. అదే పరిస్థితి మీ ఇంట్లో మీ బంధువులందరూ ఉన్నప్పుడు ఓపెన్గా నువ్వు చేస్తే అది అప్రిషియేట్ చేస్తాను. లెట్ ఇట్ బి ఎనీథింగ్, అది పార్న్ అడిక్షన్ కావచ్చు, ఏదైనా లేదు సార్ యాక్సెప్ట్ చేయాలి. వెన్ ఇట్ ఈస్ నాట్ యాక్సెప్టెడ్ యూ ఆర్ నాట్ సపోజ్ టు డూ. దిస్ ఈస్ హౌ ఐ నో. అండ్ ఫ్యామిలీ మెంబర్, సార్ వీడికి ఎంత చెప్పినా వీడు ఇంటర్నెట్ సార్ వీడిని వదిలిపెట్టేస్తాం సార్. నో, దిస్ ఈస్ ద ఫస్ట్ పాయింట్. మీరు మళ్ళీ రీలైఫ్ స్టార్ట్ చేశారు. సో ఇక్కడ నుంచి జర్నీ స్టార్ట్ అవుతుంది. అది 6 months, 1 year, 2 years. సో రికవరీ అనేది ఒక ప్రాసెస్. మధ్య మధ్యలో కింద పడతా ఉంటారు నడుస్తూ ఉంటే. సో వెన్ ఎవర్ దే ఫాల్ డౌన్, ప్రాబ్లం ఏం జరిగింది దాన్ని అడ్రస్ చేద్దాం. సో యాజ్ వి స్టార్ట్ అడ్రసింగ్ దోస్ ఇష్యూస్, మెల్లిమెల్లిగా రికవరీ అనేది వస్తూ ఉంటుంది. దిస్ ఈస్ హౌ ఐ మోటివేట్ ద ఫ్యామిలీ మెంబర్స్ టు టేక్ అగైన్ దిస్ యాజ్ ఎ రీలైఫ్ దాన్ దిస్ ఇస్ ద ఎండ్ పాయింట్ అనే బదులు అలా చేస్తుంది సార్. థ్యాంక్ యూ సార్.
Thank you, sir. Madam, I think we are not only into counseling, we are not only into talking, motivating them, madam. Now, lot of new drugs, new medicines. When I say drugs, it's again the medicines. Lot of medicines, lot of newer molecules, medicines have come where they're doing a wonderful role in detoxing the addicted person. They suffer from acute withdrawals, and we want to quit them from this addiction. They face a lot of withdrawals, as you know, madam. And we have wonderful medicines where many times we can do it on an outpatient basis. It's not that we need to admit them and go through the laborious process of time and money. So that's to your submission, madam. And lot of drugs have come where these medicines work as anti-craving. Means you keep them for some time on these medicines. They neutralize the craving part to take these drugs, and many times when we do the medication and the counseling, the psychotherapy, it gives much better results, as Dr. Sai said, to the person and the family. It's giving us a lot of results. With this submission, I thank all of you for your patient listening, and we would end this panel discussion. Once again, I thank all the dignitaries for taking your valuable time. Thank you.
I request all the panelists to stay on the stage. Now I invite Dr. Vishala Akla sir, Dr. Kishan sir, Dr. Ashok Kalimchandani sir, and Dr. Ashok Reddy sir to felicitate the panelists.
మీకు అర్థం వస్తుంది ఇక్కడ చైర్ కాడ ఉండే బెటర్ ఇంకా ఇక్కడ చైర్ అది ఇంకా నీకు స్ట్రైట్ అవుతుంది ఇక్కడ ఉండే చైర్ కాడ ఓకే ఉండు ఏం
Request Praveen Chindapati sir to please kindly accept our felicitation. Next I request Additional Collector Kiran Kumar garu to please kindly accept our felicitation. Next, I request Dr. Jagadishwar Rao garu to please kindly accept our felicitation.
Okay, sir, ready?
Next, I request Siddhaya garu to please kindly accept our felicitation. Next, I request Dr. V. George Reddy sir to please kindly accept our felicitation. Thank you all. In 5 to 10 minutes, we will go for the valedictory. I request Udita and team to be ready for the violin drill. Good evening to all. Every program should come to an end. From past 3 days, we are working on TSPSYCON and addiction psychiatry. This is the 10th state conference of IPS Telangana state branch. Now we are going into the valedictory. Now I invite Dr. Ashok K. Alinchandani sir, President IPS Telangana state branch. Next I invite Dr. Kishan sir, Chief Guest of today's valedictory. Next I invite Madam Kankadurga Garu, Additional District and Sessions Judge, District Court Nizamabad, as Guest of Honor. Next I invite S. Kiran Kumar Garu, Additional Collector Nizamabad District, as Guest of Honor. Next I invite Dr. B. Lokesh Reddy Garu, Secretary IPS South Zone, as Guest of Honor. Next I invite R. Jagadishwar Rao Garu, Advocate and President Chamber of Commerce Nizamabad, as Guest of Honor. Next I invite Rasul B. Madam, District Women and Development Officer, as Guest of Honor. Next I invite Dr. K. Narayan Rao Garu, Vice President IPS Telangana State Branch. Next I invite Dr. Vishal Akalas Garu, Honorary General Secretary IPS Telangana State Branch, Organizing Secretary, the man behind the show, TSPSYCON-2024. I invite Anita Rairala Madam, Honorary Treasurer IPS Telangana State Branch. Next I invite Dr. Fanikant Kondaparthi, Honorary Editor IPS Telangana State Branch. Next I invite Dr. V. George Reddy Garu, Organizing Chairman, TSPSYCON-2024. Thank you. I hand out the proceedings to Chandani sir, IPS Telangana State Branch.
Good evening to all of you. As I say, all good things must come to an end. So, I'd like to address first the dignitaries. Dr. Kishan, Chief Guest, seated on the dais. Srimati Kankadurga Garu, Additional District and Session Judge, District Court Nizamabad, Guest of Honor. Sri Kiran Kumar Garu, Additional Collector Nizamabad District. Sri Jagadishwar Garu, Advocate and President Chamber of Commerce, Guest of Honor. Dr. Lokesh Reddy, Secretary of the South Zone, Guest of Honor. Dr. K. Narayan Rao, my fellow office bearers, Vice President. Dr. Vishal Akula, Honorary General Secretary. Dr. Fanikant Kondaparthi, Mrs. Rasul B., District Child Welfare Officer on the dais. And Dr. Fanikant Kondaparthi, Dr. George Reddy, Organizing Chairman of the conference. It has been a wonderful 3-day event. We have all enjoyed ourselves immensely. We were surprised, and the conference was held at a level far beyond our expectations. Dr. Vishal has raised the standards of the conduct of conferences with a well-organized, whether it be the stage, the venue, the various programs, the selection of speakers. In all respects, it has been a wonderful experience for all of us in the Indian Psychiatric Society, Telangana State Branch. We all know the theme of the conference, de-addiction. It's a very important topic, and we all go home from here with important take-home messages that we not only need to be well versed in the medical management and keep updated with the latest developments in the field, including cannabinoids and other things. But this is drug addiction being a social problem also, we also need to network with the society, and that is an example that Vishal has set for all of us, and I think it is worth emulating, that we all need to emulate it in our respective places. A big hand for Dr. Vishal Appala, please. So with these few remarks, I think we can quickly go into the next step. Next, I call upon the General Secretary, Dr. Vishal, to give his remarks.
Good evening all, respected dignitaries on the dais. IPS, Indian Psychiatry Society, Telangana State Branch President, Dr. Ashok K. Alimchandani sir, and today's chief guest, Dr. P. Kishan sir, is a National Executive Council member of Indian Psychiatry Society, and Professor and HOD Department of Psychiatry, Kaduma Institute of Medical Sciences. And today's guest of honor, Kanakadurga Madam, and our additional district judge. One more guest of honor, Dr. Kiran Kumar Garu, additional collector, Nizamabad district, and one more guest of honor, Dr. P. Lokesh Reddy Garu, Secretary, South Zone, and one more guest of honor, Dr. R. Jagdishwar Rao Garu, President, Chamber of Commerce, and Ms. Srimati Rasul B. Garu, District Women's Child Welfare Officer, and our President-elect, Vice President, Dr. Narayan Rao sir, and President Dr. Anita Rairala, Editor Dr. Fanikant Kondaparthi, and Organizing Chairperson Dr. James Reddy sir, and all the senior members of Indian Psychiatry Society. So first of all, I would like to thank you for your all support. I would like to update I would like to give brief update about TSPSYCON. It's a 10th decennial conference of State Branch. So we received almost more than 600 registrations in this conference. It's a theme, addiction psychiatry, and the detailed scientific schedule actually and one more thing, we received free papers. We received free papers, 15 free papers and posters, 31 posters. And so main attraction in this TSPSYCON-2024, there was a pre-conference workshop for healthcare workers and volunteers. 55 people had attended this pre-conference workshop. And just now we had a panel discussion with psychiatrist and additional collector, district additional judge and advocate and NGO and other important dignitaries. So it's a wonderful experience. And on behalf of organizing committee, I would like to thank all the psychiatrists for your support and encouragement. Thank you very much.
Like some feedback from the attendees, the EC. Anybody would like to give some feedback for the overall conference and its proceedings?
think the 10th conference, annual conference, has far excelled all the previous 9 conferences what we had after the formation of the system. We had a lot of learned very good skills from the experts from throughout the country. We are carrying a lot of knowledge on how to treat our patients who are mainly suffering from addiction disorders. And during the conference, the organizing committee has put an effort to increase awareness about the mental illnesses and especially the addictions through the marathon walk conducted. I think it's one of the objectives of the IPS Telangana State Branch is to serve the people and increase the awareness in the community. That objective is fulfilled by the organizing committee by arranging the walk yesterday from the district collector office, collect drops. And all the arrangements made are also wonderful arrangements here. So we have learned things, we have enjoyed, we have reached the public, and we have also received the message that it's our responsibility to help our fellow citizens in improving their mental health through our services. Thank you.
Proceed. Next is a brief address by Dr. Narayan, Vice President of the IPS TSP.
Good evening all. Generally in valedictory function we see a lot of empty chairs, but as Ashok Reddy sir said, it is par excellence and we see a full hall here. Congrats and best wishes to Dr. Vishal. Everything was excellent, food and talks and ambience, everything was here. I like to thank Dr. George Reddy sir, Dr. Kishan sir and my Khammam Psychiatric Society who made me stand here as Vice President. I use this opportunity to thank them and thank all who have voted me and made me stand here. Thank you. And next time also we are conducting the TSPSYCON in Khammam. I will once again use this opportunity to invite you all to Khammam and we will try to at least match this ambience and all in Khammam. We promise you that we will put a lot of efforts to match this and welcome you all. Thank you, sir.
Next, we have call upon Dr. Fanika Kottapati, our editor of the IPS TSP, to give his address.
Good evening, everyone. Happy to see a full crowd in the hall. It was a nice experience, and I thank the organizers for giving me the opportunity to conduct the pre-conference workshop on Friday, which was received well by the participants, and the objective was fulfilled. And coming to the scientific sessions, according to the theme, it was designed nicely. The speakers were selected, and they did their job well. Well supported to the chairpersons, and I must congratulate all the postgraduates who have presented the free papers, award category, award papers and award posters. They were excellent. It was a cutthroat competition among all the postgraduates, but it's end of the day, the best performance wins the prize. But I should appreciate that everyone has done a good job, and I thank the office bearers and organizing committee for giving me this opportunity. Thank you.
Thank you, Dr. Pani. I next call upon the organizing chairperson, Dr. George Reddy, another dynamic person, the duo of Vishal and George. I like any filmy hero duo.
Thank you,
It's a wonderful job.
Thank you, sir. Respected Chief Guest, Dr. Kishan sir, all the guests of honors, particularly Dr. Lokesh, my buddy, coming all the way from Vizag, and you're taking care of 5 states, Dr. Lokesh Reddy. Nice to see you here on this conference valedictory. As everyone said that yes, the hall is full. Thank you for your energy. I think you are all very responsible, and this gives the energy for the organizers to do this kind of activities. And I think I was only trying to guide Vishal. I think he did everything, but I think we could really, this should be a kind of model kind of conference, I feel, because we not only saw that we psychiatrists learned something, we had good time, we met all our colleagues all across India, Telangana, but I think the theme for, I think we psychiatry have that advantage of going into the public. As Ashok Reddy sir said, our constitution, our association is, first our objective is to serve the public. Our awareness activities have to go to the public. Along with that, we have these conferences. I think as our Ambedkar or our Guru of our constitution, Dr. Ashok Reddy sir said, thank you for those kind words, sir. And definitely, all of us should do this kind of activities. The pre-conference workshop was, madam, it was only to see that our colleague doctors know about, the medical officers at PHCs know about drug addiction and how to deal with it actually, how to handle them, and there were ANMs, other paramedics, they also should know about how to deal this problem. That was our agenda, and thanks to all the people who were there, who were behind Vishal for organizing a wonderful walkathon. I think it was above 500 attendance, the auditorium was full, and I think it will be all in the news tomorrow. Thank you, Nizamabad Psychiatric Society and all the members of the Indian Psychiatric Society who are here, and I would end by thanking Dr. Sai and his team for the wonderful scientific activity, and you have seen how Sai and team are doing from the end. I think Sai will, Vishal will mention their names. Really thanks to all of you youngsters, and you have made it, because it's like initially I think the young team also has to come and they have to take up the responsibility of taking up the scientific activity and doing this conference like this. Thank you, one and all.
Our next time we call upon Srimati Karnadurga Garu, Additional District and Sessions Judge, District Court, Nizamabad, to address the gathering, our guest of honor.
Good evening to all the dignitaries on dais and off the dais. I'm very much fortunate to participate in this type of conference, and I'm listening to everybody now just at present here, and it is a kind of awareness to other than doctors who are present here. It is very much needed nowadays, and it is very much useful to all, and I'm very much thankful to all for giving me this opportunity to participate here. Thank you, one and all. Thank you.
Thank you, madam, for your kind words. May I next call upon Sri R. Jagdishwar Rao Garu. I'm sorry, Sri Kiran Kumar Garu, Additional Collector, Nizamabad District, to address our guest of honor, to address the gathering.
అందరికీ నమస్కారం అండి. ఈ సెమినార్కి వచ్చినందుకు మాకు చాలా సంతోషంగా ఉంది. యాక్చువల్గా చాలామంది ఇక్కడ ట్రైనింగ్ కూడా అయ్యారో చెప్తున్నారు. వాళ్ళ ఒపీనియన్స్, డాక్టర్స్, లేదా పీజీ స్టూడెంట్స్ కూడా ఉన్నారట. వాళ్ళు దీనివల్ల చాలా ఉపయోగం ఉంటుందని చెప్పి నేను అనుకుంటున్నాను. అయితే చివరిలో మీరు దీనికి ఒక కాంప్రహెన్సివ్ ఆస్పెక్ట్ కూడా ఒకటి ఇచ్చారు. ఎందుకంటే ఓన్లీ అంటే మీరు క్యూర్ చేస్తారు వాళ్ళకి ఎఫెక్ట్ అనేది, కానీ అది ఆ డ్రగ్ అబ్యూజ్ లేకుండా కూడా ఇట్ ఈస్ ఏ కాంప్రహెన్సివ్ థింగ్. యాక్చువల్లీ అడ్మినిస్ట్రేషన్ కానీ, తర్వాత లా కానీ, అంటే పోలీస్ కానీ, తర్వాత కోర్టు కానీ, ఈ విధంగా అన్ని రకాలుగా మనం యాక్షన్ తీసుకుంటేనే దీన్ని మనం కంట్రోల్ చేయగలుగుతాం. మీ పార్ట్గా మీరు ఒక పర్సన్ని మీరు ఆ డ్రగ్ అడిక్షన్ నుంచి పడేయగలుగుతారు. అదేవిధంగా ఒక పర్సన్ బయటకు వచ్చాడంటే ఒక కుటుంబం బయటకు వచ్చినట్లే. అది చాలా మీ డాక్టర్ అంటేనే ఇట్స్ వండర్ఫుల్, అంటే దేవుడితో సమానం. మీరు ఆ విధంగా ఒక కుటుంబాన్ని మీరు బయటకు తీసుకొచ్చినట్లయితారు. ఈ సింపోజియం మీకు చాలా హెల్ప్ఫుల్గా ఉండి చాలా ప్రజలకు చాలా మంచి జరుగుతుందని చెప్పి నేను భావిస్తున్నాను. థ్యాంక్ యూ.
Mrs. Rasul B, our District Women and Child Welfare Officer, our guest of honor to address the gathering.
First of all, good evening, sir, all the dignitaries, and at the same time, before my stage, all the doctors and different department officials, and even the press, everything, Mahi, mother and all, everybody, good evening, sir. I am DW from Nizamabad district, where we see all children, women, disabled, senior citizen and transgenders. I look after the welfare of these people, different 5 sections. Especially, I have attended morning session also, a walk and then a meeting. It's a wonderful work. All the coordination with the police department, excise department and different departments we have come across there. Now what I feel is, we are identifying the malnutrition only so far in every part of the villages. We feel importance in nutritional status only so far. But earlier in Sanskrit we used to say, Sarvendriyanam Nayanam Pradhanam. But what I feel after coming to this workshop is, Nayanam kante kuda every part of the sense organs we can reorganize by the technical inputs now. But Medo Shakti, మెదడు కనుక, I will continue in Telugu, if మెదడు కనుక ఖరాబ్ అయితే పాడైతే దాన్ని ఎట్లా రిప్లేస్ చేయలేదు. We are looking after so many institutions, disabled institutions in Nizamabad district. There I see వాళ్ళకి ఎంతో చేయాలనే తపన ఉంటుంది, శ్రద్ధ ఉంటుంది, శ్రమ ఉంటుంది, కానీ మెదడులో ఏ కాస్త దెబ్బతీసినా అది పూర్తిగా బాడీ మొత్తం కూడా అసలు ఏమీ పనిచేయలేని స్థితిలో అవుతున్నారు. ఇటువంటి డ్రగ్ అబ్యూసెస్ వల్ల, తినడం వల్ల చాలా కేసెస్, మాకు ట్రాఫికింగ్ కేసెస్ ఎక్కువ మాకు ఎదురవుతుంటాయి. ఇటువంటి కేసెస్ అన్నీ కూడా చాలా వరకు మాకు ట్రాఫికింగ్ అంటారు. ఫస్ట్ ఈ డ్రగ్స్ యొక్క అబ్యూసెస్ వల్ల మత్తు పానీయాల్లో పడి అలవాటు తెలియని వయసులో తెలియకుండానే దాంట్లోకి జారుకొని పోయి ట్రాఫికింగ్లో పడిపోయి కుంపిలోకి రోగిలోకి వెళ్ళిపోతుంటారు. అటువంటి వారినందరూ రిహాబిలిటేషన్ చేసే బాధ్యత మా ఉంది. ఎంతోమంది మేము చూస్తున్నాం కాబట్టి మొదట అసలు ఆ డ్రగ్ అబ్యూసెస్లో కానీ, డ్రగ్స్లో కానీ, మత్తు పానీయాల అలవాట్లో కానీ దాంట్లో పడకుండానే చూడడానికి మేము ఎంతో ప్రయత్నం చేస్తున్నాం. స్టిల్ యాజ్ ఎ డాక్టర్స్గా మీరందరూ కూడా, ఇప్పుడు నేను కింద ఈ ప్రజెంటేషన్స్ కూడా విన్నాను. అసలు ఫస్ట్ స్టేజ్ నుంచి ఎట్లా మీరు దీని కిందకు వచ్చే స్థాయిని వాళ్ళు చాలా క్లియర్గా, డీటెయిల్గా తెలియని వాళ్ళకు కూడా అర్థమయ్యేటట్టుగా చెప్తున్నారు. డాక్టర్స్కి అందరికీ, స్పెషల్లీ వారికి అందరికీ కూడా మరోమారు ధన్యవాదాలు తెలియజేస్తున్నాను. ముఖ్యంగా ఇటువంటి చక్కటి ఆర్గనైజేషన్ ఏర్పాటు చేసి ఇటువంటి ఇంటర్నేషనల్ సెమినార్ని మా దాకా నిజామాబాద్ దాకా తెచ్చినందుకు మన విశాల్ సార్ గారిని, వారి టీంని అందరినీ కూడా మరోమారు ధన్యవాదాలు తెలియజేస్తూ, నాకు ఈ అవకాశం ఇచ్చినటువంటి పెద్దలందరికీ థ్యాంక్స్ తెలియజేస్తూ సెలవు తీసుకుంటాను.
First of all, I congratulate the organizers of this conference, who has made the success of this conference. Today, in the morning, they have conducted a successful rally. Again, this conference is also very successful. I have been observing Dr. Vishal since 1 month. మొత్తం దీంట్లోనే మునిగి ఉన్నాడు ఆయన. ప్రాక్టీస్ పక్కన పెట్టి టోటల్ ఇదే పని చేస్తున్నాడు. We appreciate him. ఇప్పుడు ఏదైతే ఈ డ్రగ్ అబ్యూస్ ఉందో దీనిపైనే సెన్సిటైజ్ చేస్తూ రకరకాల ప్రోగ్రామ్స్ చేస్తూ మనము ఫస్ట్ ఒక తెలంగాణను మీరు ఒక శాంపిల్గా తీసుకొని ఇక్కడ డ్రగ్ డిగ్రేడ్ చేస్తే అప్పుడు మొత్తం టోటల్ ఇండియాకి కూడా ఇది ఒక టార్చ్ బేరర్గా మనం ఉంటే బాగుంటుంది అనుకుంటున్నాను. మీరందరూ కూడా ఆలోచించి దానికి సంబంధించిన ఆర్గనైజేషన్ అందరినీ యూజ్ చేసుకొని చేయాలని అనుకుంటున్నాను. అదేవిధంగా ఇంత పెద్ద కాన్ఫరెన్స్ నిజామాబాద్లో సక్సెస్ కావడానికి, ఇంత మంచి అంబియన్స్ కావడానికి కూడా ఈ హోటల్ కూడా కారణం అనుకుంటున్నాను. మధు గారు ఉన్నారు ఇక్కడే. థ్యాంక్స్ అండ్ కంగ్రాచులేషన్స్. మంచి అంబియన్స్ మెచ్చుకున్నారు ఇప్పుడు దాకా చాలా మంది. సో అంటే హైదరాబాద్ లెవెల్లో ఇక్కడ ఒక అతిథులకి ఇంత మంచి సత్కారం చేయడానికి ఇంత మంచి హోటల్ ఉందని చాలా మంది మెచ్చుకున్నారు. సో నాకు అవకాశం ఇచ్చినందుకు కూడా థ్యాంక్స్.
Next may call upon Dr. P. Lokesh Reddy, Secretary South Zone, Guest of Honor, to give his address.
Respected President Dr. Ashok sir and other dignitaries on the dais and off the dais. Though I came from out of Telangana, I think I have a very close connection with Telangana because my relation with Telangana has started as a student in 10th class. Intermediate I studied in Telangana and I did my post-graduation in Telangana. I really thank my teachers, my institute and this land for making me what I am today. And when Vishal has requested me to the guest of honor, I initially felt little inconvenient because I felt it was my own land from where my academics have started actually. So being a guest, rather than being a guest, I felt that I would be a family member of this and attend this particular conference. The other thing, the 2 to 3 days programs, I think with the theme topic of addiction psychiatry, the deliberations were so knowledgeable and it has given new insights starting from basics and to the advanced in this field of addiction psychiatry. And in this process, and it is not surprising to say that in the process of learning the skills to be addict, we got addicted to the love, affection and hospitality shown by the organizers, especially Dr. Vishal and Dr. George Reddy. So with this, I thank once again for inviting me as a guest for this valedictory function. Thank you one and all.
Thank you, Doctor. Okay. The next item is distribution of prizes, medals, certificates. May I request Dr. Sai to take over? The next item, distribution of prizes.
Awards Committee Chairman George Reddy sir.
Awards Committee Dr. George Reddy.
Thank you. First, I would request the winners for the Mavaluri Shivakumar Memorial Postgraduate Quiz winners, Dr. Amulya and Dr. Arbaz from Kakatiya Medical College. If you are here, please come and collect the cash of 3,000 rupees and a certificate, or somebody can collect on their behalf. The runners from AIMS, BB Nagar, Dr. Sushant Tej and Dr. Ajay. Somebody is there, on their behalf they can collect, or the organizing committee will give it to them. Then we have Kodugu Chinnareddy Venkat Ramamma Award. This goes to Dr. Nivedita. A certificate and a cash. Congratulations, Dr. Nivedita. Next we have Dr. P.R. Reddy IMH Alumni Award. This goes to Dr. Anna Sai Krishna Yadav. Anna Sai Krishna Yadav. The award goes with a gold medal and a cash certificate of 2000.
मैं बनाया जगह लोग आ जा सकते, आप पूरा ब्लॉक कर दिए, थोड़ा सा तो उधर खसको, मैं तो इधर आगे लगा था।
Next we have late G. Krishnalila G.V. Sita Ramaya Award for the postgraduates. The winner Dr. V. Renuka. A cash prize and a certificate. Dr. V. Renuka. Somebody can collect on her behalf. Next we have for the category of Dr. B. Anand IMH Alumni Best Poster Award. This goes to Dr. Renuka. Dr. Renuka. I think we can hand it over to them. You'll take it on them. Yeah, we request Dr. No? Right. We'll hand it over to them. Same. Great, yeah. And we have the undergraduate quiz winners. The winners from GHMC Nizamabad, B. Sri Surya and Sayyid Abdul Rafe. Somebody there? Okay, we have the runners from ESA Medical College. Our faculty from the Nizamabad College, somebody can collect. That's the please. We have the runners Maulik Jain and Chirag from ESA Medical College. Okay, I think the organizing committee will take the responsibility and hand it over to them. Any faculty from ESI? Dr. Naveen, are you there? PG quiz, anybody there from Kakatiya Medical College to collect? From AIMS BB Nagar? Okay, there, sir, we will hand it over to them. Thank you, sir. Over to President, sir.
So, next, I would like to call upon Dr. P. Kishan. He is well known to all of you. He is the chief guest for this function. May I call upon Dr. Kishan.
Respected presiding officer, my teacher, Dr. Ashok Kalimchandani sir, and other dignitaries, guest of honors, Madam Kanadurga, District Judge, Jagdish Garu, Advocate, and Rasul V. Garu, Child Welfare Officer, and Kevin Kumar, Advocate. So, my opinion about this conference, I think Ashok sir already told that he raised the bar, which is very difficult to reach for further. I think Narayan Rao has to taking challenge to Karimnagar, the recently elected president from Khammam, and next conference will be at Khammam. And he is preparing now itself how to raise bar. He is also very dynamic person. So the success starts here. the Vishal, the whole hero of the story, so he started work since last 6 months, almost more than 6 months, by giving announcements and selection of the topic. So even selection, each and every person was selected by, I am grateful that greatness to all CME committee and advisors to the conference. Legendary persons like TSS Rao, one person from All India Institute of Medical Sciences, NIMHANS, covered all the institutes with wonderful topics to able teachers. And the inaugural function, generally last 10 years, the 10th conference of Telangana formation, generally we started first foundation conference is at Warangal, very simply, very humble way. Then some conference we started cricket. So that will go on to the national cricket now, South Zone to national level. So then walkathon, somebody used to have a conference with a walkathon. But Vishal introduced one more thing, pre-conference CME, like, to get awareness of local problem by involving the local leaders, and it's a very grand success almost. And for that I think he paid a lot of money, the 1 day extra almost, in the same venue, almost same hall. So he conducted a wonderful conference to sensitize and involving all the leaders of the local leaders. That was a wonderful program. Generally we used to have pre-conference press meet. The press meet, but he has done a wonderful program, complete almost 3-4 hours program with all academic lectures and sensitizing all the things. That is really a wonderful program, which is a given ambience to total program. And you should see the inaugural function. Involved all MLAs and MLC of our local leaders. Most of the nation leaders, because already Vishal being youngest person, young person among the leaders is young, but is already entered the national office as a national executive member, which also I am holding 62 years. But he is such a young fellow. He is entered before me. That was his dynamicity. We should accept young leaders when they are coming up. We should appreciate. It is asset to the Telangana State Branch, and the Telangana State Branch is a well-known branch in our national or other international person also who are visiting our national conference because it's closeness. The President National Conference came here, National IPS came here as a Rati, as a chief guest, and all presidential candidates, like Nimesh Desai from Delhi, KK Mishra from Orissa, and very problematic to arrange all the things at one place. Now even during the conference, halls are full success. You see the wonderful dinner, separate hall, the other activities like drinks in other hall and cultural program here. Wonderful program. We felicitated all the leaders of South Zone and Telangana State Branch and national leaders with really it is difficult to conceptualize this type of program. That is the greatness of Vishal and his team of Nizamabad Psychiatri Society, and I think he got cooperation from surrounding districts, not only Nizamabad Department of Psychiatry and like Surinidu and other persons of Nizamabad Psychiatri Society, as well as Jagityal Department of Psychiatry of Jagityal Medical College and Sai Krishna from Karimnagar Medical College. There was a lot of additional district came. That is his relationships, and the success goes to all the team, especially Sai Krishna and his post-graduates from Pratima Institute and post-graduates from the Jagityal and post-graduates from Nizamabad Medical College. So there is no single problem during the whole program, and wonderful interactions. Lot of papers came for PG posters, PG papers, and the pitch program. Lot of teams came. Sanjay has a lot of work to screen out the program. So that is a really evolution of our Telangana State Branch activities over the last 10 years. This is you see the valedictory program. We involved beautiful panel discussion. All district authorities are here. So because they are related to our child welfare officer is here, district judge is here, giving legal opinion, and advocate is also there, Chamber of Commerce and additional district collector also there in the dais. So this is the way he collects and is that much PR being a HOD of the psychiatry department. It is difficult to in academics as a leader, as a organizer, and Nizamabad already, I think thanks to the owner of this building, I think this building made it a grand success, and thanks to the Nizamabad people, and I think the next state conferences starts. Already Vishal has done CME, midterm CME, PCME, Southern CME also is done, Southern level, but state conference is difficult to, because big place. I think now the IMA, all leaders of other states have been to conduct the conferences. And as Telangana districts are developing, infrastructure is developing, now the Nizamabad district, the Karimnagar district conducted, and Khammam district conducted, lot of other districts like now Mahbubnagar district conduct the state conferences. The small district, now other districts also came, they are developing infrastructure. Shortly, I think saving programs taken by Siddipet district. So other districts, Jaityal is ready to take, and Munchiyal is ready to take the responsibility. So these are all the success goes to Telangana State Bank journey. Not only good treasury for 10 years, lot of treasury, having developing very good journal, and as well as district societies. Wonderful program. Again, champion is a Vishal, our community awareness programs. Always he gets awards for that from IMA as well as IPS. I think to challenge Vishal, lot of youngsters are conducting other districts. Warangal Psychiatry Society is conducting, Khammam Psychiatry Society conducting, and Jaityal, other Manchirial, different places are conducting the awareness programs. I think again champion is a Vishal. And I think I am requesting everybody to stand up, to standing ovation to the organizing committee of Nizamabad, and I think that is work to encourage the hard work, set, and it's great by Padma, Mrs. Padmani is very great patience and encouraging the Vishal. Thank you very much.
Now the next item on the agenda is the felicitation of guests of honor by our chief guest, Dr. Kishan.
So it's a time to felicitate our dignitaries. So now I would like to request our additional district judge Kanakadurga Madam, please accept felicitation. Kishan sir, please.
Okay, ready, sir?
Now I would like to request our additional collector of Nizamabad, Sri Kiran Kumar Garu, please accept our felicitation.
Okay, sir, ready?
Now, I would like to request our South Zone General Secretary, P. Lokesh Reddy sir, please accept our felicitation.
I request Dr. Raviteja and Dr.
Just
Aswani
join
to
it.
stage.
Okay, ready?
Now, our district women and child welfare officer Rasulbi madam, please accept our felicitation.
Okay, ready, sir?
Now I would like to request one more guest of honor, my well-wisher, Rotarian R. Jagishwara, our advocate and Chamber of Commerce president. Please, it's a
Sir.
I would like to request IPS TSB Telangana State President Dr. Ashok K. Alimchandani sir, please accept our felicitation.
Okay, ready?
Now I would like to request our President-elect Narendra sir, please accept our felicitation. Next, Dr. Panikant Kodaparthi, editor. Congratulations, sir. Now it's time for felicitation to our editor, Dr. Panikant Kodaparthi. Please accept. So I would like to recognize my organizers, especially Nizamabad Psychiatri Society organizers, organizing treasurer Dr. Rajendra. Please accept a small token of appreciation. He wonderful organizer. Section Rajshekhar, Pradeep, Shalini, and Vikas, Raviteja, Dr. Arun. సో కొద్దిగా వేరు చేయాలి, పెద్ద లిస్ట్ ఉంది మేడం. మీరు కొందరు ఈ కాన్ఫరెన్స్ చాలా మంది వర్క్ చేశారు మేడం. మీరు మీ ద్వారా రవితేజ he has done wonderful job. Please give a big round of applause to Ravateja. Dr. Arun.
Okay, ready?
Dr. Pradeep. Dr. Shalini, she is organizing joint treasurer come quiz master, assistant quiz master. So main quiz master, we would like to felicitate our quiz master, Dr. N.D. Sanjay sir. Please come onto the dais. Dr. Madhuvamshi.
Okay, sir, ready? Sir?
Sorry, I forgot Dr. Anupam. Behind the Anupam, Dr. Anuhya, Dr. Apurva, Dr. Sai Srija, Dr. Ritesh. Please give a big round of applause to this team. Dr. Anupam is a son of Dr. Kishan sir. Sir.
Okay, ready?
Dr. Anuhya. Apurva, Dr. Sai Sticker, Dr. Ritesh, so he is an all-rounder, academician and sports person. I would like to request Ajay Kulkarni, please accept my presentation. Dr. Ashwin, Mr. Ashwin. Dr. Uma Maheshwari from IMH. Paniraj, Kiran, Sai Kiran, Madhu, Lakshman, Madhu, please come. Lakshman, Sandeep, Rahul, Rotary Club Manager Rahul, all-rounder. Now it's time felicitation to our hotel owner, Gade Madhusudan Garu. Please give a big round of applause to our hotel owner, Gade Madhusudan Garu. Thank you, sir. Nice. So, I would like to felicitate our scientific committee chairperson, Dr. Sai Krishna. Please accept small felicitation, please. Udit Joshi, Mr. Udit Joshi, MCI, Professional Conference Organizer. Mr. Venugopal, thanks for your cooperation and active work. And audiovisual team, Ramareddy garu, please come. Next, Raju, the camera work involved, very well can Raju, photographer. The photographer, yeah, very well. Next, Bharati Channel team, Bharati Channel camera person, please come. Sai Kulkarni. Next, K6 Channel cameraman, Nani. Next, Suman TV cameraman. Next, awareness Walkathon main organizer, Mr. Jeevan Rao garu, and one more main organizer, Vijayanand garu from Excise Department. Very active person. Madam, Argadura madam. Kiran sir. And one more awareness Walkathon organizer, active Jagadish garu. వచ్చారా జీవనరావు గారు జగదీష్ గారు వచ్చారా రాలేదా ఓకే నో ప్రాబ్లం అండ్ I would like to appreciate local hospitals, Vishnu Hospital, Dr. Rajendra Prasad, and Manorama Hospital, Dr. Narasimha Katta garu, and Nova Life, Dr. Naveen garu, Sunrise Hospital, Dr. Dhanpal Vinay garu. Okay, thank you. Now it's time to felicitate our pharmaceutical companies. I would like to invite. Before that, I would like to invite. I would like to distribute pre-conference participation certificates. Venkatesh garu, please give a list of participant. Andar randi, please come. కిరణ్ సార్ మీ చేతుల మీద వాళ్ళకు డిస్ట్రిక్ట్ అఫీషియల్ చేతుల మీద ఇద్దాం మీరు అనౌన్స్ చేయండి
భూలక్ష్మి CHO కమ్యూనిటీ హెల్త్ ఆఫీసర్
మేడం
నెక్స్ట్ సంగుబాయి గారు CHO
వాళ్ళు తీసుకుంటే వాళ్ళు మనకు చూడాలి వాళ్ళు తీస్తే కెమెరా చూడాలి
స్వామి సులక్షణ BHC నిజామాబాద్
दिख रहे हैं हेलो भैया ब्रदर जुड़ा रहेगा हेलो
शांता कुमारी एन पद्मलता CHO వెంకటరమణ HEO గోవర్ధన్
ग्रुप लेते
डॉक्टर वेंकटेश्वर Dr. Sharat Chandra.
వెంకటేశ్వర్లు డిహెచ్ గారు.
Now it's time to recognize our pharmaceutical sponsors. First of all, I would like to invite some pharmaceutical people, Ramakanth Garu and team. Sintas Pharmaceuticals, Mr. Srinivas and team. Thank you. You have done a wonderful job. Thank you.
Sir, okay, ready.
Next, Intas Srinivas and team.
Okay, ready, sir? Sir, ready. Right. Your hand is coming.
Next, Ambitus Shekhar and team. Ambitus Shekhar and team.
Okay, sir. Sir, look here. Right.
Next, Icon Pharma.
Right.
Icon. Next, Sine Healthcare.
Okay, right. Okay, ready?
Sine Healthcare. Next, Crescent Pharma and team. Crescent Sridhar and Rajendra.
Okay, ready. Okay, ready?
Next, Crescent Pharma, followed by Alchem. Alchem Pharma next.
Anna. Okay. You are the behind the boss.
Alchem next, Sigmund. Sigmund Promenica. Next, Talent India.
Okay.
Talent India. Next, Amisha Shamshuddin. Pharma. Next, DD Pharma.
Hello, sir.
DD Pharma. Next Cipla.
Hello, sir.
Cipla. Next Vritti Life Sciences. Vritti Life Sciences. Next Neurosoft. 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 Next TSR. Next TSPS. TSPS. PJ Pharma. Next PJ Pharma. I hope I had not missed anyone. Had we missed anyone?
I would like to invite Vishnu Hospital, Dr. Rajendra Prasad garu. Please accept small felicitation from organizing committee. Madam, DJ madam. Is the pulmonologist?
Okay, sir. Right. Patient, sir. Okay, ready, sir?
Next, I request Dr. George Reddy sir to please kindly accept our felicitation. Madam George Reddy, if she is available, please come. I request George Reddy sir to please kindly accept our felicitation. And I request Dr. Vishal sir also to please kindly accept our felicitation. Charles. I request Padma madam to please kindly come. Dr. Padma Vishal. Yeah. Dr. Padma Vishal.
Okay, ready, sir? Okay, sir, ready? Sir.
I request Dr. Vishal sir and Padma madam to please.
It's a time for vote of thanks. The conference has come to an end. Thank you all for attending in large number. As per theme of the conference, we have designed the scientific sessions. I am happy that speakers and chairperson did a wonderful job. I thank each one of them who are a part of my conference. I hope everyone enjoyed the academic sessions. So I would like to thank all the core organizers, especially I would like to thank our organizing chairperson Dr. George Reddy sir and immediate past president Dr. Vinas sir and current president Dr. Ashok K. Alinjandani sir and treasurer Dr. Anita Rairala, and editor Dr. Pandikant Kottaparthi, and IPS South Zone representative, IPS TSP South Zone representative Dr. Ramsubba Reddy sir, and immediate past secretary Dr. Pawan Kulkarni, and President-elect Dr. Narayan Rao sir, and past editor Dr. Sai Krishna, and our EC members Dr. Aditya, Dr. Divya, Dr. Nazar Ali, Dr. Nitin, Dr. Om Prakash, Dr. Prashant, Dr. Rajendra, Dr. Raviteja, Dr. Sheetal, Dr. Jishan Ali, and I would like to thank our Chief Patron Dr. Raghuram Reddy sir, and patrons Dr. Prasad Rao sir, Dr. Chandrasekhar sir, Dr. N.S. Reddy sir, Dr. Ashok Reddy sir, Dr. Bhagya Reddy sir, Dr. Satish Babu sir, Dr. Sridhar Rao sir, Dr. Umashankar sir, Dr. Keshav Rao sir, Dr. Mayunath Reddy sir, Dr. Jagannath sir, Dr. Ramsubba Reddy sir, and special thanks to my chief advisor Dr. Kishan sir, and my other advisors Dr. B. Keshavlu, Dr. K. Shiva Prasad, Dr. K. Gangaram sir, Dr. Praveen Chittapati sir, Dr. M. Praveen Kumar sir, Dr. Jagdish Babu sir, Dr. Vishweshwar Rao sir, Dr. Pramod Reddy sir, Dr. Manmohan Raju, and my organizing treasurer Dr. Rajendra, and our joint organizing secretary Dr. Shalini, and the registration committee Dr. Dinesh, Dr. Nagalakshmi, Dr. Umesh, and Dr. Uma Maheshwari, Dr. Sanket, and Dr. Sirisha Madam, Dr. Nivedita, Dr. Hasanti, Dr. Archana, Dr. Scientific Committee Dr. Sai Krishna and Raviteja and Asha Monika, Saket Reddy, and Cultural Committee Dr. Rajshekar, Yosman Burla, Dr. Pradeep, Dr. Alladi Suresh, Dr. Vivek, and Food and Transport Committee Dr. Y. Arun Reddy, and G. Santosh Kumar, and Dr. Kalyan, Dr. Venkatarati, Dr. Niveda, Accommodation Committee Dr. Vikas, and Sridhar Dandepalli, Dr. Prem Nayak, Dr. Akshay, Dr. Bhanusai, and Sports Committee Dr. Rishikesh, Om Prakash, Dr. Ramana, and Varun, Music Quiz, Dr. N.G. Sanjay sir, and Dr. Jiti Shalini, Dr. Madhuvamshi, and all the speakers. Especially I would like to thank all the speakers and chairpersons and supporting staff and print and electronic media and audiovisual team and Kanakadurga Madam Garu and Kiran Kumar Garu and Lokesh Reddy Garu and Rasul B Garu and our Jayeshwara Garu and Chief Guest Kishan sir and all the team members. So thank you. And first of all, I would like to thank Health Department, Venkatesh and all other doctors and the other team for your active participation. So with this, I would like to thank you all for your support. Thank you very much. And in this, Rajkumar, my other team members, Rajkumar, Ajay, Ashwin, Kaniraj, Kiran, Madhu, Lakshman, Sandeep, Rahul, Nathaniel, Prashant. So if I miss anyone, please excuse me. Thank you very much. Print and electronic.
भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
With this, the program, the valedictory function stands closed. Thank you.
Backup. ఫోటో ఉంటాను నా రాజేనా ఇది ఆఫ్
తీస్తుంది రౌండ్ కొట్టే చాలా కోసం
కొంచెం లాంగ్ ఉంటుంది కొంచెం ఇటు సైడ్ నువ్వు టచ్ చేసి తీసుకురా
ఓకే రెడీ
ఒక్క నిమిషం
ఓకే
అన్న కొంచెం వెనక జరగాలి
ఓకే రెడీ సార్
ఓకే డన్
రైట్
థ్యాంక్ యూ
అన్న నా ఫోటో బ్రోకు పంపించే నాకు పంపించే నంబర్ మర్చిపోయి థ్యాంక్ యూ
కంగ్రాచులేషన్స్
అదే లైట్
లైట్ తీసేసిరా
లైట్ వేస్తే ఎంత మజా
నేను 3 సార్లు అయిపోయినా హీరో సార్ బ్యాక్ సార్ బ్యాక్
ఓకే రెడీ సార్ 1 minute సార్ రెడీ
కొంచెం బ్యాక్
ఆపన్నా ఆప్ సార్ ఓకే సార్ రైట్ వాళ్ళు కూడా సార్ పేరేంటి తెలంగాణ ఇళ్ళకు
కానీ భాయ్ కొంచెం బ్యాక్
ఓకే రెడీ కొద్దిగా స్మైల్ ఇమ్మా రెడీ వెయిట్ సార్
నా ఎన్నికి రా ఓకే
రైట్ సార్ ఓకే సార్ రెడీ రైట్ आ जाओ जल्दी जाओ ओके सर रेडी
राजू भाई राजा ना थैंक यू फॉर द सपोर्ट थैंक यू
चलो थैंक यू अन्ना थैंक यू
फिर से मिलेंगे
फोटो किस करेंगे आप?
राजन ना फोटो
विशाल सर को राहुल के ग्रुप में भी लगा देते हैं। विशाल का ग्रुप है, हाँ, उसमें लगा, आप उसमें ज्वाइन हो जाओ। श्योर सर। हाँ राइट सर, रेडी सर? राइट।
ना